and some people over there, especially Dr. Mishra, who is chairing this session, Dr. Krishnani, Dr. Rakesh Pandey, and Dr. Gupta. I think it was probably more than 25 years ago that Dr. Mishra organized a symposium, a multidisciplinary symposium on endocrine medicine. And I was participating in that along with an endocrine surgeon who accompanied me from the US, Dr. Neelima Patwardhan. So that's how far my relationship with SGPGI goes. And another thing I would like to mention today is obviously these days it's so common to have virtual lectures, like I'm here in the US and you are there in Lucknow. I wish I was there personally, in person talking to you. But it was the forward-looking SGPGI and Dr. S.K. Mishra that probably in the 90s, we did a session that live in which PGI Chandigarh folks could join as well. So I think that's how forward-looking SGPGI is. I would say information technology department was at that time, and Dr. Mishra was able to envision that you could do remote lectures. And I've been in touch with him since then. There was one that I was in Delhi. He had made a conference, and there were some groups from Calcutta who were able to join in that conference. So I'm glad that we have finally caught up with what SGPGI was thinking 25 years ago. So here I am, virtually though, but delighted to be here today to participate in this meeting. I will be talking about the recent WHO update on parathyroid tumors 2022. The blue book is about to come out, or maybe it's already out, but at the last US and Canadian Academy of Pathology meeting in the Endocrine Path Society, we did a special symposium devoted to all endocrine tumors in this WHO update. So I'm delighted to present to you some data on parathyroid tumors that is being proposed in this new classification. So bear with me if I have some technical issues, but hopefully this should go smooth. So as we all know, we have 4 parathyroid glands normally, but I've seen 5 at times, and sometimes you may not be able to find all 4 of them. They develop from the dorsal buds, the 3rd and the 4th pharyngeal pouches, and majority are located in the neck. But often you'll find them in the mediastinum, you'll find them inside the thyroid, and anywhere else. And I've been called for a frozen section by a cardiac surgeon doing a coronary artery bypass graft. They found a nodule which turned out to be a parathyroid adenoma. But it was a hyper-functioning, or I would say non-functioning adenoma at the time, because patient did not have high PTH or didn't have high calcium levels, and later on was found to have mild hyperparathyroidism. The glands, what's more important from pathology point of view, you usually weigh the glands, and I think it's good to know that the normal weight of these glands is about 30 to 40 milligrams, and combined total 4 glands should not be more than 120 milligrams. Anything above 50 milligrams is considered abnormal. This is the normal histology of the parathyroid. You see stromal fat, and then you see parathyroid cells, which may be in different phases of their physiological activity. Some are more active, like these chief cells, and then and then you see parathyroid cells, which may be in different phases of their physiological activity. Some are more active, like these chief cells, and then we have the oxyphil cells, which are the same cell but in a different phase of physiological activity. But we do classify them as chief cells, oxyphil cells, water clear cells, and then transitional cells. They do not have any clinical significance as far as pathology or lesions of the parathyroid are concerned. So this used to be the classification. Most of the time we get called to consult on parathyroid cases is because of hyperparathyroidism. Before WHO 2022, we had primary, secondary, and tertiary. The causes of primary were considered to be adenoma, which is the most common, 85 to 90% of the time, and then hyperplasia, which is 10 to 14%. Now, I've circled this here to show that this has changed now. The new name for this is multiglandular parathyroid disease or multiglandular parathyroid adenoma, and we'll talk about that later. And then rarely, thankfully, have carcinomas and atypical adenomas. And again, this name is also changed. Instead of calling it adenoma, the proposal is to call it an atypical parathyroid tumor because we don't know what its behavior is. Nothing has changed in secondary hyperplasia, which is a result of some primary underlying disorder like chronic kidney disease or malabsorption causing hypercalcemia and compensatory reaction with primary or secondary hyperparathyroidism. Tertiary, when parathyroid becomes autonomous in the background of secondary hyperparathyroidism. Some nodule may become autonomous and then become tertiary hyperparathyroidism. That's the reason pathology gets involved in it. And the way the patient comes is, in the case of primary, they'll have a high serum calcium levels. Secondary, usually it's low serum calcium. Then to compensate for that, the parathyroid is going to overdrive the produced calcium. And tertiary, you have high serum calcium levels. And incidence of parathyroidism, hyperparathyroidism is increased because of the introduction of these autoanalyzers. We do clinical chemistry tests these days. For example, before 1974, the incidence used to be 15 per 100,000 patients, and after 74, it's like around 100 per 100,000 patients. So clearly, if you do more testing, you'll find more lesions, and that's the reason hyperparathyroidism is also increased in incidence. The way, as Dr. Mishra would know more than anyone else here, who is a surgeon, that we do a pre-op evaluation of these patients, usually do an ultrasound scan or a system image scan before you plan exploration. In ultrasound, you could see hypercoic lesion. It's more sensitive for adenomas and multi-gland disease. And similarly, on a system image scan, you can see uptake. It's also taken by salivary glands, but if you look at it 2 hours later, you can see one of the glands is lighting up, suggesting there is a single gland disease. Combination of ultrasound and system image scan is very sensitive, especially for single adenomas. And then if you need to do other studies, you can do a CT or MRI scan, but less commonly used. I think what's very important for management of parathyroid disease during exploration is intraoperative PTH levels, which is very useful. We'll talk about in a minute. So, management of parathyroid gland abnormality, what is our role as pathologists? Obviously, you come into picture when there is surgery going on during intraoperative evaluation. We do a frozen section to confirm parathyroid and diagnosis whether it's hyperplasia versus adenoma versus carcinoma. This thing is difficult, adenoma versus hyperplasia, because it depends on how many glands are involved. Adenoma versus carcinoma is less of a problem. Most of the time, surgeons will make a diagnosis of carcinoma. They'll say that it's hard to take the gland out, so that's very helpful. The role of fat stain, we usually don't do these days, but there was a role or value in doing mild or minimally hyperplastic glands in which the intracytoplasmic fat is depleted. So what we're looking for is fat within the cells, intracytoplasmic. What's very valuable is intra serum PTH levels. So before starting surgery, you get a PTH level drawn. You take the gland out, and after you think you've taken the gland which was causing hyperparathyroidism out, you do another PTH level 15 minutes or 30 minutes later, and if it drops down to below 50% of the baseline, then you think that the gland that was producing the hyperparathyroidism is out. So that's just the basic background of parathyroid pathology and how we as pathologists come into play regarding management of these patients. So what has changed in WHO classification this year? First thing that has changed is nomenclature. So we're calling things with a different name. For example, hyperplasia in the setting of primary hyperparathyroidism is no longer called hyperplasia. I think this is referred to as multiglandular parathyroid disease or multiglandular parathyroid adenoma. And the reason, we'll talk about that in a minute why. Parathyroid adenoma is still the same. Nothing has changed there. Atypical adenoma of the parathyroid is now referred to as atypical parathyroid tumor. Again, emphasizing the importance that we really don't know how these tumors are going to behave, so we cannot call them adenoma, which implies it's a benign tumor. So it's what you can say, a borderline tumor of uncertain malignant potential. Nothing has changed with regards to the nomenclature in parathyroid carcinomas. What has changed is some recommendations on how to work up these cases of parathyroid tumors and carcinomas. There's a new category of tumors that they have classified as what's referred to as parafibromin deficient parathyroid neoplasm. So I think that again, we'll talk about the importance of doing parafibromin levels or expression by immunohistochemistry to start with in parathyroid tumors. Nothing has changed in the nomenclature for secondary parathyroid hyperplasia or tertiary hyperplasia. Let's look at this case I had recently, like 2 or 3 weeks ago. This 27-year-old female had a history of autism spectrum, otherwise healthy, presented to the emergency department with a fall and fracture of the femur. So that's why she came to the hospital. When they drew the labs in the emergency department, she had very high serum calcium levels, 15.7 milligrams per deciliter. High PTH, hypophosphatemia, and low vitamin D. She did not have any prior history of high serum calcium level. This is the first time she's had blood drawn. Family history, mother with multiple sclerosis, otherwise no significant endocrine neoplasia, sister with autoimmune alopecia, no history of hypercalcemia or MEN or jaw tumors in the family. She had a neck CT, which showed a 4 centimeter right inferior parathyroid, heterogeneous and hypervascular. And additionally, in addition to that 4 centimeter, the other glands were, they said, mildly enlarged. So there was one big gland and 4 other glands were mildly enlarged. She was taken to the operating room for neck exploration. The baseline intra PTH was 1537 picograms. She had right inferior parathyroid removed, which was her largest gland. So PTH dropped to 346 picograms after 15 minutes and 158 after 30 minutes of removing the enlarged parathyroid. Now clearly you can see this 158 is below, it's almost like 10% of the original level, but still, because imaging had showed other glands, the surgeon was obliged to look at other glands. So I explored the same side and we removed 4 and found to have 5 parathyroid glands identified, out of which 4.5 glands were removed. And intra PTH fell to 75 picograms after removing 4.5 glands. And I checked the values post-op, 2 days after post-op, it was 5 picograms. So clearly, what was causing the hyperparathyroidism, all the parathyroids enlarged, abnormal were removed. This was the first gland, that's the largest, which weighed 3.5 grams. It was attached to the thyroid. Here's the normal thyroid, and you can see there's a capsule between the parathyroid and the thyroid. But there's no real invasion of the capsule. It's just very smooth, fibrous capsule, no invasion into the thyroid gland. If you look at the cell, it's composed of chief cells and some oxyphil cells mixed together. What it also showed was a lot of cells with large atypical nuclei or abnormal nuclei showing hyperchromatic cells, but no mitoses. No mitoses were identified, and this is quite commonly seen in endocrine organs referred to as endocrine atypia, and does not really imply a neoplastic cell population. So that was one gland, which was like 3.5 grams. The gland number 2 we got was 165 milligrams, clearly enlarged, normal weight being 50, so like 4 times, and very hypercellular, so also abnormal gland. Gland number 3 was 264 milligrams, also enlarged and hypercellular, but not as big as the first one. Gland number 4 was almost like twice the weight of a normal gland, but still hypercellular and enlarged. So we got 4 glands, all enlarged, different sizes, all hypercellular, and usually they do a biopsy of the 5th gland just to confirm that they've documented 5 glands in the neck. And that showed a little bit of cellular parathyroid cell with adipose tissue. So, given these 4 glands enlarged, the diagnosis in this case is multiglandular parathyroid disease. I checked the post-op course just yesterday. I saw that it was complicated by hypocalcemia, gone down. There was one level of 7, but now it's stabilized to 8.5 milligrams on calciferol and calcium. And once calcium stabilizes, the plan is to do genetic testing in the coming week. So that's the real reason I'm presenting this case, and probably why WHO committee suggested this additional workup and how pathologists can help in triaging these patients to get a more definitive diagnosis with regards to the underlying genetic abnormality. Another reason they're considered to be not hyperplasia is they're considered to be clonal proliferation. They're associated with MEN1, MEN4, and the newly described MEN5 syndromes. We'll talk about that in a minute. They can be asymmetrical and occur in asynchronous manner, and you can see our case is asymmetrical. One gland was big and the other glands were smaller than the first one. The nodular proliferation of chief cells and other cell types, they often lack rim of atrophic parathyroid around the lesion, and we didn't see any atrophic or normal parathyroid around the lesion. There appears to be a germline susceptibility-driven process, and they need genetic testing, and that's why I think we come into play recommending these patients to undergo genetic testing to rule out which is actually may affect patient care in the future. The main syndromes that are associated with multiglandular parathyroid disease, as we all know, are MEN1. We all know the MEN1 gene, the protein menin, which is a tumor suppressor and has been known for a long time. MEN4 is almost same as MEN1, but with a different gene. This protein product is P27, cyclin-dependent kinase inhibitor, and also a tumor suppressor. And MEN5, which is still under investigation, not well recognized, but it has a MAX gene, which is like a big-associated protein factor X, and promotes cell proliferation and apoptosis. So these are the syndromes that we would like to know if these glands, large glands, these patients may have one of these syndromes, so other things can be kept in mind. So the importance from our point of view is that pathologists can provide additional value to genetic testing and triaging by recognizing these morphological and immunohistochemical harbingers of MEN1, MEN4, and MEN5 syndromes, and also CDC73 related manifestations, which we'll talk about later when we talk about adenomas and carcinomas. So that's good. You can identify these abnormalities, maybe good for genetic counseling, and also if patient in the future comes up with some other lesions of other organs. So that was multiglandular parathyroid disease or adenoma. I wish I was there personally. Usually you want to see if you have any questions or pause for a minute just to think about what has changed and why it has changed. So, but that's not the case here. So I will pause for a few seconds if you guys want to think about it a little, see, before I move on to the next case. So this is a 54-year-old female with history of chronic kidney disease, presented with high PTH level, bone, muscle pains, and cardiac symptoms. So the incidence of secondary hyperparathyroidism due to chronic renal disease has really gone down nowadays. You no longer see those very significant pathological fractures or brown tumors or renal osteodystrophy. They usually symptoms are mild, bone pains and muscle pains, but nevertheless they do occur because of all the addition of phosphate binders and calcium mimetic drugs. I think the incidence is much less now. This patient had all 4 glands enlarged, almost 3 are almost the same size, 4th is a little bit smaller. And the histology showed nodular proliferation of parathyroid cells, showing hyperplasia of all the glands, And these hyperplastic glands in chronic renal failure or secondary hyperplasia can show degenerative changes, hemorrhage, fibrosis, and also other changes like calcifications. There's increase in parenchymal mass resulting in proliferation of chief cells, oxyphil cells, and transitional cells. Multiple glands are involved, and most are polyclonal. But there are some studies, and if you look at individual nodules within these hyperplastic glands, they may be clonal. And that's one of the reasons drove the WHO, especially in the setting of primary hyperparathyroidism, consider them as neoplastic proliferation. But in this case, we know the cause is secondary, so hyperplasia still is a recognized entity in the setting of secondary hyperparathyroidism. So they're symmetrical, they can range in size, fat stains, intracytoplasmic fat can decrease or depleted, maybe diffuse or nodular, and you can see hemorrhage, fibrosis in large glands. So that is secondary hyperplasia. What about parathyroid adenoma? The terminology, nomenclature is still the same, what it used to be. This is the most common cause of hyperparathyroidism. There may be some predisposing factors like radiation exposure or familial or heritable disorders that we should always keep in mind. Occurs in 5th or 6th decades of life. A little bit more common in males and females. Majority present with hyperparathyroidism, minor subset reported to be non-functional. And sometimes those non-functional cases get to notice when you do surgery for other reasons. Maybe sporadic. For example, I've seen cases in which they see a neck node with thinking it's a thyroid nodule. They do an FNA, it comes back as follicular neoplasm. You take it to surgery, it ends up being a parathyroid adenoma. So those cases, they're not really producing PTH to the extent that patient you see hypercalcemia, and that's how they get picked up. So maybe sporadic or familial as part of a heritable syndrome. The single glands are involved, and most commonly it is the inferior glands, could be superior sometimes. Rarely they're good with 2 glands, referred to as double adenoma, and there are case reports, which is a little stretch. Obviously, this is before the new classification came out of triple adenomas. These cases may be now classified as multiglandular parathyroid adenomas in the setting of primary hyperparathyroidism. The glands have thin capsule with a rim of normal parathyroid and outside. And they can be variants like oncocytic, lipodenomas, water clear cell adenoma. And we'll see some examples of that. This is a case we had a few years ago. Very smooth cut surface. The important thing about adenomas is here's the nodule with the capsule, and outside you can see a rim of normal or atrophic parathyroid. And the adenoma itself can produce follicles like these. Almost looks like a thyroid. Sometimes it's a challenge to distinguish thyroid from parathyroid, especially on just on a frozen section. But as I tell my residents, that you can always look for calcium oxalate crystals that you will see in a thyroid, but not in frozen section and not in a parathyroid, because these are pseudo follicles, but they have the same kind of material that you see in the colloid, so it's difficult on a frozen section. Here again, you can see this follicular architecture of the parathyroid, rim, and then outside you can see normal parathyroid. Some areas could be more cellular, can have different kinds of cells. Some of them are oxyphil cells, some clear cells. And here you can see some larger cells. They could, again, like we saw in our case, you can have some atypia of these cells, but that doesn't really mean anything. But no mitotic figures. Rarely can see a mitosis. Variants include microadenomas, oncocytic type adenomas, water clear cell adenomas, and lipodenomas. And here is an example of microadenoma. You see nice solitary nodule in a follicular architecture with endocrine, atypia, oxyphil cells, part of the lesion. Another case with the interface between the normal and the abnormal nodule. You can see the cells are very oxophilic, pink cytoplasm, referred to as oxophilic adenoma. These cells have a lot of mitochondria, that's why they have this pink, finely granular cytoplasm. There's another gland which was enlarged, like this weighed actually 7 or 8 grams, about 5 or 6 centimeters, with very clear, foamy cytoplasm, clear cells. And sometimes it's a question in the frozen section room, is this really a parathyroid or is it some other clear cell tumor, like a renal cell carcinoma or some other? So sometimes what we do, have to do immunohistochemistry to prove that it's a parathyroid. So you can do stains that will support parathyroid origin, like PTH. You can do chromogranin, it's positive. And obviously it'll show negative for if it's a clear cell carcinoma, like renal cell antigen or other. Here's an example of lipoadenoma. You can see adipose tissue mixed with the parathyroid cells, like here. It's a lot of fat. Looks like lipoadenoma, and the cells look oxophil chief cell type. So there are different types of parathyroid adenoma. Again, I can pause for a few minutes for you to think about what I've just said, and then we can move on. This is the 46-year-old male with hypercalcemia, was found to have hyperparathyroidism. Ultrasound and systematic scan showed enlarged right inferior parathyroid, a right inferior parathyroidectomy, and biopsy of the right superior parathyroid. Interoperative PTH dropped to below 50% of the baseline after removing this gland. And here you can see the gland, 2.5 grams in weight, 2.2 centimeters, thick fibrous capsule, a lot of fibrous bands intersecting the tumor, very uniform population, clonal population of cells, very bland-looking cells, no mitoses, no atypia, no real necrosis in the tumor cells, but a lot of thick fibrous bands in areas of hemorrhage. Like here, you see this pigment is hemosiderin, so there was some remote hemorrhage, fibrosis, more of the same hemorrhage and fibrosis. There's a different case. In this case, it was a 59-year-old with high serum calcium, 3.5 grams of parathyroid attached to the thyroid here, but not infiltrating it. And I know 12 years later, checked her history, she's fine. And this is referred to as atypical parathyroid tumor of uncertain malignant potential. The reason to label this such as it requires a long-term follow-up. So I think one important point I'd like to make here is you only make a diagnosis rarely. That's one thing. You only make a diagnosis when you're not sure is it atypical parathyroid tumor or carcinoma, not adenoma. So there has to be a higher threshold for suspecting atypical parathyroid tumor. Plasma of uncertain malignant potential. The previous name used to be atypical adenoma. Now WHO 2022, the preferred terminology is atypical parathyroid tumor, and for the reason that we don't know how this is going to behave. It has worrisome histologic features for carcinoma. That's why we want to call it atypical, like intratumoral fibrous bands, monotonous sheets of cells, a little bit of atypia, microscopic capsular invasion, but no transcapsular invasion. That's important. Necrosis on hemorrhage may be rarely present, again, because of mechanical reasons, and occasional mitosis may be found, but not any of these features, which is like unequivocal features of malignancy. It's peritumoral vascular invasion, perineal invasion of the adjacent soft tissues, metastasis, and mitosis greater than 5 and 50 high power fields of 10 millimeters square, or Ki-67 index of more than 5%. So this is absolutely, if you find any of these, you call it a cancer. And again, it'll be supported by the findings from the surgeon who will say that this tumor was attached to the soft tissues, which was difficult to dissect out of the neck. The atypical parathyroid tumor is a study from 2002 by Dr. Rondellalis, and you can see all these tumors had these features that are described, and they have an average follow-up of 7 years and no recurrences in these. So sporadic, they can occur in familial settings, serum calcium somewhere in between parathyroid adenoma and carcinoma. And again, as I said before, this is only reserved for neoplasm with atypical features for which the differential diagnosis is parathyroid carcinoma, not a parathyroid adenoma. Talk about parafibromin immunohistochemistry a little later, but it will help in predicting the outcome of long-term follow-up. And it looks like this may become a routine in all parathyroid tumors because we want to see how it can assist in prognosticating these patients. So routine germline CDC73, which is the gene for parafibromin, is required or may be required in parathyroid neoplasm, especially atypical adenomas and carcinomas. Parathyroid carcinomas are thankfully rare, like less than 0.005% of all cancers. If you look at all primary hyperparathyroidism from the world literature, it's about 1 to 3% in different studies, and less than 1 per million population in the general population. So it remains a rare cancer, but incidence has increased over the years and maybe due to increased serum calcium screening and less stringent guidelines for parathyroidectomy for asymptomatic patients. These are some studies that I looked at a few years ago and looked at our own data from UMass. In our 20-year experience, we had about 400 hyperparathyroidism primary, only 4 were malignancies, so 1%. And all the other studies are in the same range. I know I looked at this study from India in which they looked at the Indian primary hyperparathyroidism registry, like 2.2% had parathyroid carcinomas in 22-year period out of 547. There were like 12 cases of parathyroid carcinoma. So it's a rare tumor, but nevertheless, it occurs more common in 5th and 6th decades of life. They usually present with very high serum calcium levels, palpable mass in the neck, vocal cord paralysis. All these things that present are pointing towards a malignancy. Recurrence of hyperparathyroidism short time after surgery. The surgery tumor is adherent to the surrounding tissues, like I said. It's difficult to dissect. And microscopically, the thick fibrous bands, capsular invasion, and vascular invasion. This is the common age, 5th and 6th decades. There are no predisposing factors, but rare cases may be associated with MEN1 syndrome. What's more important is mutations in the tumor suppressor gene HRP2 or CDC73. And that is actually nowadays almost required to do this germline testing if you see a deficient protein expression in the tumor cells. CGH, you'll see loss of 1p and 13q chromosome. There's loss of heterozygosity of chromosome 13. All these are related to the RB gene, the BRCA gene, which also become important in the downstream signaling for these tumors. Here's the histology. You see thick fibrous bands going through the parathyroid and outside the parathyroid. Here's the skeletal muscle or neck tissues outside the gland. You can see it's infiltrating the tissues. You can see the capsule of the tumor intersected by the tumor. This was attached to the thyroid. You can see there's vascular invasion outside the tumor, peritumoral vascular invasion. Mitosis can be rarely seen. Although you can see mitoses, but those are really, like I said, the 5 in 50 high power field, which is not a very high number if you look at other compared to other tumors. So there's relatively slow growing tumors. The different kinds of changes. You can see this vascular perineural invasion outside, nuclear atypia, hyperchromasia, necrosis. The recommendations of WHO 2022 for parathyroid carcinomas is that we should completely submit a parathyroid specimen for histology and do multiple deeper recuts to make sure that we've looked at all the capsule and the surrounding tissues. Count the mitoses in 10 high power fields or 10 millimeters square, perform Cas67 and parafibromin stain, and then other immunohistochemistry like APC, galectin-3, PGP 9.5, and H-TERT, and P53. Make a point here that there's no magic marker that can tell you it's cancer or not cancer, but a panel may help in challenging cases if you have multiple antibodies, they can all work together. You have a parafibromin deficient tumor that requires gene sequencing. As parathyroid carcinoma, may be potentially hereditary disease associated with hyperparathyroidism, jaw tumor, or isolated familial hyperparathyroidism syndrome due to germline mutation in CDC73 gene. So I think possibility of germline susceptibility should be considered in all patients with parafibromin deficient parathyroid carcinoma, even in the absence of suggestive from personal history, because it may be important to do a genetic counseling on these patients if you find mutation in the CDC73 gene. This has seen increased risk in benign parathyroid disease and up to 10% of carcinomas. You can see this. Gene product is parafibromin. We have antibody against, and you can do immunohistochemical stain to look for parafibromin deficiency in tumors. So there's a high rate of CDC73 mutations in parathyroid carcinoma. You can see, like, this study showed 10 of 15 cases had mutations, out of which 3 were germline, and against 6 of 7 cases. So there's a very high incidence of mutation of CDC73 in parathyroid carcinomas. Approximately 70% of them are shown. So if you do a parafibromin level, you might see loss of parafibromin immunoreactivity in this subset of patients. And that can be assessed by immunohistochemistry. And 30 to 70% of carcinomas may show reduced or absent staining in the carcinoma cells. And the way parafibromin works or functions in these parathyroid cells, you see it downregulates cyclin D1, or the CCN D1 gene that encodes cyclin D1 and c-MYC. So this inhibits cell proliferation. It also stimulates apoptosis. In addition to inhibiting apoptosis, it stimulates apoptosis and inhibits RB. We know RB inhibits cell cycle progression because it's a tumor suppressor gene. So if you look at parafibromin, it will affect both these pathways, RB causing cell proliferation, inhibiting cell proliferation, and then not able to upregulate cyclin D1, causing increased cell proliferation. So you have high tumor mutational burden, high copy number alterations, and high risk of recurrence and increased cell proliferation. This is a picture from one of the papers in which you can see this is parathyroid carcinoma, atypical adenoma, parathyroidmatosis, adenoma, and hyperplasia. And if you look at parafibromin, it's lost in carcinomas and it's positive in these other benign lesions, as opposed to galectin-3, which is positive in carcinomas and atypical adenomas and negative in adenomas and hyperplastic lesions. Ki-67, accordingly, is increased in carcinomas and shows low immunoreactivity in adenomas and adenomas. The loss of expression is at least suspicious of malignancy, if not diagnostic. And most studies recommend molecular testing for HRP2 gene mutation if you see loss of parafibromin on immunohistochemistry. And that's why WHO has come up with another category of this tumor in the nomenclature, what they call parafibromin deficient parathyroid neoplasm. So if you find a tumor that has negative for parafibromin, but it's logically not a carcinoma, you should label it as such, do a gene sequencing in these patients. And if it is atypical adenoma, these tumors may behave in a more aggressive manner. It's occasionally seen in adenomas, but more frequent in atypical parathyroid tumors and very common in carcinomas. So if you see a parafibromin deficiency in atypical parathyroid tumors, it is a worrisome feature and may suggest an aggressive behavior. So how do you work up these cases? So you do histology, no atypical features, parathyroid adenoma, you do a parafibromin stain if it's positive, no risk of recurrence and no need to do any further testing. If it's negative, no risk of recurrence, you may consider constitutional gene sequencing. If it's atypical parathyroid tumor, if it's positive for parafibromin, there's very low risk of recurrence. But if it's negative, it has low risk, but you should perform CDC73 gene sequencing. And if there's a carcinoma, positive or negative, doesn't mean high risk of recurrence, then you should perform CDC73 gene sequencing. So this is the proposed triaging of parathyroid tumors according to the WHO 2022. This is adenoma. This is atypical adenoma and parathyroid carcinoma. As you can see, parafibromin is positive in benign. It may be positive or negative in adenomas and usually negative in parathyroid carcinomas. And if other markers also help, but they're not absolute. Ki67 is another good marker that you should always do. In these cases, actually is recommended by WHO, which is high in carcinomas, usually more than 5%, and less, little bit raised in atypical adenomas or atypical parathyroid tumors, and not very high in benign or adenomas. Example from the same paper, the WHO classification paper, parafibromin in adenomas is retained, PGP is lost, APC is retained, galectin-3 is negative, cyclin P1 is another marker that is typical for adenomas, it's positive, and retinoblastoma protein is shows like a wild type immunoreactivity. Carcinomas, you can see PGP is positive, there's high Ki67, parafibromin is totally lost, and APC is also lost. So I think this stains can help. Parafibromin, Ki67 are two more commonly used stains that can help. As far as molecular studies in parathyroid tumors, we talked about MEN1 gene. You can see germline mutation in multiglandular parathyroid disease. And in subset of adenomas, you can see somatic mutation. CDC73 or HRP2 gene, which encodes parafibromin. That's another thing that should be done. And if you find that a subset of atypical parathyroid tumors, carcinomas, they may suggest a more aggressive behavior. Cyclin D1 expression is seen in mainly in parathyroid adenomas. And then calcium receptor, calcium sensor receptor, and vitamin D receptor, mRNA gene, they're also involved in parathyroid adenomas and carcinomas. They're the genes that really function like a brake pedal, like they brake the proliferation of parathyroid cells when they come in contact with their ligands like calcium and vitamin D. It's downregulated in parathyroid adenomas. The genes that you can do or look for is p53, PI3 kinase, TERT, and dicer, but these are all more like research protocols. So the way they put together is, if you look at the parathyroid lesions, there are three basic clusters: the hyperplasia cluster, mostly hypoplastic parathyroid lesions; CDC73 driven cluster, which is the parafibromin driven cluster, which is hereditary and sporadic, seen in adenomas and carcinomas; and the MEN1 related cluster, mostly adenomas or multiglandular parathyroid disease. The bottom line is there's no clear-cut recommendations of molecular workup in the new WHO 22 classification. So I don't want you to all leave this conference today, go to your hospitals and ask your hospital administrators to get all these tests to be done. It's not really recommended at this point, and it's maybe not needed also for what may be more important is CDC73 mutation parafibromin IHC. That's what we do. We plan to at least do this in all parathyroid tumors, and then if it's positive or negative, take it to the next step, especially in tumors. For example, if it is a primary multiglandular parathyroid disease, those patients will get appropriate genetic counseling and genetic testing. But for tumor evaluation, if you have a specimen, you don't have to do all these tests that I'm just talking about. Most of the time, you can make the diagnosis on histology, but what you can help is by appropriately classifying these tumors into morphologic entities and doing some immunohistochemistry, you can suggest some further genetic triaging of these patients that can help in future patient care. So I think I'm not going to talk about parathyroidism because nothing has changed here in the WHO 2022. This is just abnormal parathyroid tissues you see in the soft tissues of the neck and mediastinum. Just to summarize what I just talked, WHO 2022 update in parathyroid, change in nomenclature, primary hyperplasia replaced the multiglandular parathyroid disease because consider them as the germline susceptibility-driven manifestations of these MEN1, MEN4, MEN5, or CDC73-related genes. Atypical adenoma is now called atypical parathyroid neoplasm. Addition of parafibromin deficient neoplasm, it could be an adenoma or an atypical parathyroid tumor or a carcinoma. If you see absent parafibromin, then they should be classified as such. In parathyroid carcinoma workup, the immunohistochemistry for Ki67 and others, I said others because in addition to parafibromin, others are good to have, but they're not really required. Document mitosis per 50 high power field or 10 millimeters square, and do the Ki67 labeling index, and do the fibromin immunohistochemistry. If it is negative, then you have to test for the germline mutation, classified as parafibromin deficient neoplasm. Thank you very much. If you have any questions, I'll be there tomorrow, I believe, in the morning, and I'll be happy to answer any questions during that live interactive session. And once again, thank you for your attention. Thanks.
Complete overview of WHO 2022 classification of parathyroid tumors. I know there is importance of parafibromin. So we should always do parafibromin in all the cases of parathyroid lesions, irrespective whatever it is. Like if it is a parathyroid adenoma or parathyroid hyperplasia, we should go for it. And if required, then germline mutation is required. So all these things we have to do in day-to-day practice. We never apply immunohistochemistry, and we also don't do Ki67, which is also one of the important things which we should do in a complete day-to-day practice. So with this new classification system, at least we can go over to next step, that Ki67, mitotic count, and parafibromin. These are the three important things we should inculcate in day-to-day practice. Thank you, sir. Thank you very much for your excellent lecture. Over to you.
Thank you, sir. Thank you, esteemed speaker. That was indeed a very informative talk. Thank you, chairpersons. I now invite Dr. Gyanchand, sir, to join the chairpersons for the next talk.
Dr. Gyanchand is professor in the Department of Endocrine Surgery, SGPGIMS. His areas of interest are endoscopic and robotic endocrine surgery and advanced reconstructive breast surgery. He has vast clinical and research experience. I now request Dr. Gyanchand to please introduce the speaker for this session.
Good morning, everyone. Thank you for the lecture for giving me this opportunity and honor to invite Dr. from NSPCC, who is the director of head of Head Pathology, and the area of interest is thyroid. We have a small interaction in 2010 in Diagnostic in 2010, and we are very familiar with his voice at the time of intraoperative consultation, which we do in thyroid. Welcome to Dr. Roland Hussain from NSPCC. Over to you, sir.
Good morning, everybody. First, or good evening, I don't know. Thank you for inviting me. So in the next hour, we're going to talk about the update in regard to the new WHO classification for thyroid tumors. So I guess the best way to start this talk is by this statement from the French Canadian pathologist, which was done a long time ago, maybe 70 years ago, when he said that no classification is more difficult to establish than that of thyroid carcinoma. Of all cancers, they teach perhaps the greatest lesson of humility to histopathologists. So what is the basis of this new WHO 2022 classification of thyroid neoplasm? Obviously, the basis is the same as has been done for many, many years, for decades: cell of origin, histopathology, how the tumor is growing, of course now molecular profile, and perhaps what really made the difference here is we really took into account the biologic behavior of the tumor in many of the entities. So this is the old classification that I put here for your reference. And this is the new one. And you can see there are plenty of changes. We noticed one interesting thing here. So we brought the concept of low-risk neoplasm. So again, a behavioral concept. So I have to tell you that some of the changes are clinically important. For example, the one that relate to the definition of non-invasive follicular thyroid neoplasm with papillary-like nuclear features, or NIFTP. The one related to the position of invasive encapsulated follicular vent of papillary carcinoma, which is discussed separately from papillary thyroid carcinoma, from classical papillary carcinoma. The introduction of the new concept of high-grade follicular cell-derived thyroid carcinoma. The fact that now squamous cell carcinoma is a form of anaplastic carcinoma and not discussed separately. Another important change is that cribriform thyroid carcinoma, which was before just a subtype of papillary carcinoma, is now a separate entity, is not considered a papillary carcinoma, it's considered a tumor of uncertain histogenesis. And finally, in regard to medullary thyroid carcinoma, we introduced the concept of grading. Now, there are also other changes, which in my opinion are of relatively little clinical impact. For example, the term variant is replaced by the term subtype. Because HER2 cell is a misnomer, we prefer to use term for HER2 cell adenoma and HER2 cell carcinoma as we prefer to use the term oncocytic adenoma, oncocytic carcinoma. The entity known, a very rare entity known as sclerosing mucoepidermoid thyroid carcinoma is considered a tumor of uncertain histogenesis. We try to kill the term papillary carcinoma because really it's not a histologic subtype of papillary carcinoma, it's based on size. And instead of just saying papillary microcarcinoma, we're gonna have to say papillary carcinoma classic, or 0.5 centimeters, so on. Another also a change of little clinical impact is that the entity follicular adenoma with papillary features is considered now separate from follicular adenoma. And finally, you know, in view of the controversy in regard to whether multinodular goiter is a collection of hyperplastic nodules or a benign neoplastic lesion or a mixture of both, in order to not address this controversy, in order to calm everybody, so to speak, we introduced the term of follicular nodule disease for this multifocal hyperplastic neoplastic lesion that occur in the clinical setting of multinodular goiter. So now let's start with the changes that have significant impact on the patient. Let's start with our nemesis, our big enemy, the follicular event of papillary carcinoma and its associated lesion known as NIFTP. So here I'm going to take a kind of unusual type of approach. I'm going to take you through the history of the classification of thyroid carcinoma to let you know how we got there and how we are trying to fix it. So the story starts in the 1950s. At that time, it was very easy to be a thyroid pathologist because, you know, you labeled the lesion just based on the growth pattern. If the tumor had papillae, you call it papillary carcinoma. If the carcinoma had follicles, follicular carcinoma. If it's a mixture of papilla and follicles, then it's called mixed papillary and follicular carcinoma. But a big change happened in the 1960s and 70s. A pathologist from California, Dr. Stuart Lindsay, in 1960, described the papillary carcinoma nuclei, and he thought, he realized that this nuclear characteristic like clearing, overlapping, irregular nuclear membrane, I found not only in papillary tumors, but also in tumor with a follicular growth pattern. And he coined the term follicular variant of papillary carcinoma in a monograph that he published that is actually online if some of you are interested in looking at it. But really, this did not take off. It's Dr. Juan Rosay, that we all know, that in 1977 put this entity on the map where he described the follicular vat of papillary carcinoma in a more detailed fashion. So what Dr. Rosay did in this article, which contains 6 cases, reported on tumor growing into follicles with papillary carcinoma nuclei. And almost all of these tumors had lymph node metastasis. So there is a little detail that nobody gave attention to, is that all of Dr. Rosay's cases lacked complete encapsulation. So these tumors were not completely encapsulated. They actually were partially or not encapsulated and infiltrative. But after that article that got a lot of success, so to speak, pathologists, I don't know why, I don't know who started in the 1980s to call any tumor that was completely encapsulated with follicular growth, with the nuclear feature of papillary carcinoma. They started to call any of these tumors as encapsulated non-invasive follicular variant as carcinoma, even if it didn't contain any invasion. So encapsulated papillary carcinoma, non-invasive follicular variant. And unfortunately, no meticulous study of the outcome of that particular encapsulated follicular variant non-invasive was done for 26 years. So that led to a widespread use of the follicular variant term, an important decline of follicular adenoma and carcinoma diagnosis. We have to wait until the year 2000 to see some change. What happened at that time, we started to understand better the molecular profile of papillary carcinoma, specifically the follicular variant of papillary carcinoma. This entity at the molecular profile is different from classical papillary carcinoma, and you can see that it is much closer to follicular adenoma and carcinoma. And one of the first paper on this subject done by Yuri Nikiforov who is now at the University of Pittsburgh, where we genotype a bunch of follicular variant of papillary carcinoma. And you can see that they have a lot of RAS mutation, like follicular adenoma and carcinoma, and it's different from classical papillary carcinoma. They have very little BRAF mutation, different from follicular adenoma, like follicular red PTC mutation, similar to follicular adenoma and quite different from classical papillary carcinoma. As far as its chromosomal gains and losses. So after looking at this data, one should ask themselves, does the follicular variant of papillary carcinoma behave like papillary carcinoma? Is it really a subtype of papillary carcinoma or not? And that's why when I undertook this study with my colleagues at Memorial and my colleague Giovanni Tannini from the University of Bologna, this was some time ago in 2006, so it's talking about 16 years ago. And what we did here, we looked at, in our hospital, at a large number of follicular lesions that were called follicular variant, follicular adenoma, and follicular carcinoma between 1980 and 1995. We excluded a lot tumors with a lot of sub-centimeter separate foci of papillary carcinoma, because how can you study the uninodular follicular variant if it's living with 10, 15 micro carcinoma? We also excluded the sub-centimeter lesions because we know they do very well. So what we got is two types of animals, so to speak. The encapsulated follicular variant, when you see the capsule here, and there's clearly a follicular growth pattern, and the inset you see tumor with enlarged, clear, overlapping nuclei, so the typical nuclear features of papillary carcinoma. On the other hand, you have a totally different animal here, which is a tumor with a lot of fibrosis, and these tumors lack a complete capsule as they infiltrate you can see the neoplastic follicles infiltrating in between the non-neoplastic ones. And when you look at the lymph node spread of this lesion, it's really shocking to see that the infiltrative follicular variant have 65% lymph node metastasis, basically like classical papillary carcinoma. And this is what Dr. Ozai described in 1977. And the other one, the encapsulated follicular variant, have very little lymph node metastasis. Those with capsular and or vascular invasion have 17% only. And those who are non-invasive instead, in that study, have 0% lymph node metastasis. But perhaps the most important finding from this study is there were encapsulated follicular variant without invasion treated by lobectomy alone. And there were 31 cases, and there was no recurrence and no lymph node metastasis, despite a median follow-up of 11 years and a median size of 2.3 centimeters. Now, other studies have confirmed these findings. There was one case from the Brigham and Women's Hospital in Boston where the patient recurred, but the tumor was at the margin, so we don't know the capsule invasion status. Dr. Virginia Livolsi, that we all know, published one case that actually had distant met, but after I spoke with Dr. Livolsi, she told me that the whole capsule was not actually examined in this case, so we don't know really if there was or not capsular or vascular invasion. Now, I don't want you to leave this talk thinking that any encapsulated follicular event will not give you problems. What I was talking about were the encapsulated follicular event without invasion. But if you have invasion, especially if you have the angial invasion, you can actually have problem, like in this particular case where you have vascular invasion here and here, and the nuclear feature of papillary carcinoma here, and you can see that this nasty tumor traveled to the rib, interestingly bypassing the lymph node, which is a typical behavior of follicular carcinoma or a RAS mutated tumor. So since we have two subtypes of follicular variant, and we were interested to see what is the genotype. And if you look at the data here, you can see that the encapsulated follicular variant have no BRAF mutation. This is a study we did in 2010. And while they have 36% RAS mutation, in contrast, the infiltrative follicular variant have BRAF mutations, 26% the study, some RAS mutation, but not as much as the encapsulated follicular variant. And the encapsulated follicular variant has a no-RAS PTC mutation and can have PAX8 PPR gamma. So in 2014, a very important study was performed in the United States it was a big network of multiple hospitals funded by the US government, the federal government, where genotyping of 400, almost 500 papillary carcinoma was done, but really deep genotyping using 9 molecular platforms. And this study has shown that follicular variant as a whole is clearly a distinct molecular entity. You can see here that in almost every platform used, whether it's messenger RNA, microRNA, methylation platform, or protein expression, the follicular variant of papillary carcinoma has a distinct profile different from classical and dorsal. So you can see here, and we even put that in our paper in 2006, that the follicular variant of papillary carcinoma seems to be composed of 2 entities. To speak, the encapsulated follicular variant, which is closer to follicular adenoma and follicular carcinoma, depending whether it has invasion or not, it will behave like follicular adenoma. It has invasion, it behave like follicular carcinoma. And the infiltrative follicular variant that is much closer to classical papillary carcinoma. And actually in 2006, when we did this paper with Giovanni, we thought that maybe this entity should be reclassified as a close entity to the follicular adenoma carcinoma group of tumor. So countless number of patients with non-invasive follicular variant will be treated by lobectomy only and spare the unnecessary side effect of therapy with its attached morbidity, financial cost, and also the psychosocial impact of a cancer diagnosis. But there were obstacles. We failed to do that. Obstacles from endocrinologists who really wanted to give radioactive iodine right and left, who didn't care about the size of the lesion because of the thinking that radioactive iodine does not have side effects. Actually, it has side effects. It's can dry your salivary gland, so you can have tooth problems even with small. It can dry the lacrimal glands, It lowers the blood count, the sperm count. Even it has, in certain doses, a small but definitely risk of leukemia. Also, we had to battle surgeons who, many, even on the same island in Manhattan, in New York, where I live, did not really understand the biologic behavior of papillary carcinoma. They wanted to overtreat the microcarcinoma. And finally, the people to blame are us, expert pathologists, who failed to communicate the extremely indolent nature of the non-invasive encapsulated follicular family. Because you send it to one pathologist, they call it benign, another malignant, and when they call it malignant, they don't tell you that this is a very, very indolent lesion. So after 30 long years of overcalling and overtreating, finally things came to an end with this study were done by a large number of pathologists that I'm sure you were aware about, most of you, if you work in thyroid, in JAMA Oncology in April 2016, related to the nomenclature revision for encapsulated follicular variant of papillary thyroid carcinoma. So what we did in this study, we were 24 endocrine pathologists from throughout the world. We had a surgeon, two endocrinologists, and even one psychiatrist whose main really interest was the impact of the nomenclature of disease on patients. And he told us that, you know, the only fact that you label a patient as a cancer patient, that will create enough anxiety so the patient will accept to be overtreated. So in that study, there were 109 non-invasive encapsulated cases that were analyzed, not treated with radioactive iodine. And each case had at least 10 years follow-up, so a median follow-up of 13 years. And there was no recurrence. And these cases were approved. We concurred that these are follicular variant. It was by 24 endocrine pathologists agreed on that, and only one was aware of the outcome of these cases. So we choose this term that's kind of long, but it hopefully it is clear. It's a non-invasive we decided to call the encapsulated follicular variant non-invasive as non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Obviously, adequate sampling of the entire tumor capsule, actually sampling of the entire capsule should be done to arrive to this diagnosis. So how do we diagnose NIFTP? So the most important thing is to exclude vascular and capsular invasion. You also have to be sure the tumor is obviously encapsulated or clearly demarcated. Obviously, it has the nuclear features of papillary carcinoma. You have to exclude any high-grade features like tumor necrosis or mitotic activity of 3 mitosis or not. And then there is a specific point of contention here, which is the number of papillae. What happens in papillary carcinoma, as I'll show you, the more papillae you have in a lesion, the higher chance you have of lymph node metastasis. But we showed that we can accept less than 1% papillae. However, after this study was performed and published, 3 studies showed nodal metastasis in NIFTP with 0% papillae and, like for example, 2 to 5% nodal metastasis in 0% papillae, and 3% is less than 1% papillae. Now, however, 2 of the papers did not exclude cases with separate papillary carcinoma. So then you cannot really judge here. You cannot tell whether the lymph node mets comes from the NIFTP in question or from the separate papillary carcinoma living with it. Then there's only one really paper which I think had a good study design because they excluded separate papillary carcinoma. However, they did not analyze the primary and the met at the molecular level. And we know that sometimes you can have a metastasis from a papillary microcarcinoma that is not picked up by the sampling or that is embedded within the block or that has regressed. So because of this paper, there was a reaction by some of us in the NIFTP group, and we tried to change the criteria from less than 1% true papillae to no papillae allowed. I thought personally that was too much. It was a too nervous reaction. So I undertook this study with a long title, where basically, with again my colleague Giovanni Tallini, where we assess the percentage of papillae in encapsulated papillary carcinoma, 235 unifocal encapsulated papillary carcinoma. I won't show you all the details, but I will show you first that there was a clearly relationship between the percentage of papillae, this column here going up, and the chances of lymph node metastasis. For example, nobody, whether even if in the cases that had invasion, if you have less than 1% papillae, you don't have lymph node metastasis. But of course, if you have 15% or more papillae, you start to have much more lymph node metastasis. Same correlation between the amount of papillae and the presence of BRAF. If the number of papillae go up, the chances of the tumor being BRAF positive increase. And if the number of papillae goes down, the chance of the tumor being RAS mutated also increases. But perhaps more important for this discussion today here is what happened to those encapsulated non-invasive papillary carcinoma. So here you have to wait for 10% papillae to start to have lymph node metastasis. Again, here the same relationship. The more papillae you have, the more BRAF mutations you have, and the less papillae you have, the more RAS mutation you have. So I repeat here, you need 10% of papillae to have lymph node metastasis, encapsulated non-invasive papillary carcinoma. So because of this study and many others, we arrived to the conclusion in the WHO that that criteria should remain. It's okay to have a few papillae in the lesion. However, we added one criterion that if you have BRAF V600E positive, then the lesion is not a NIFTP anymore. I have seen cases that look NIFTP under the microscope, but after you do BRAF V600, they are positive. And usually cases that contain some tall cells. However, I've seen only one NIFTP. I'm sure it is a NIFTP histologically that was BRAF positive, but because biology is not perfect. So these are now the new criteria for NIFTP. The less than 1% papillae remains, but BRAF V600E should be negative, should not be positive. But we also expanded the NIFTP concept. Initially, some pathologists were afraid that sub-centimeter NIFTP cannot be diagnosed as NIFTP. Now, our paper, another group also showed that this is possible. Now, also some pathologists, especially in England, in the UK, were nervous regarding NIFTP with oncocytic features. We showed in a paper that these also do not recur, and they can be diagnosed. And finally, some endocrinologists were very nervous about the very large NIFTP, more than 4 centimeters. We also showed that these do not recur. Obviously, in that situation, I would advise everybody to be super careful and to really submit the entire capsule. That's no way. Anyway, in any NIFTP, you have to submit the entire capsule. So let's look at the impact of NIFTP. Why are we doing all this? In the latest paper show an impact of probably 7,000 cases worldwide each year, thinking that if you include NIFTP in the papillary carcinoma group, they represent 9% of papillary carcinoma with significant variation. You have much more of this diagnosis in North America and much less in Asia. Now, obviously, but every time you spare a patient carcinoma diagnosis, you, especially if the tumor is large, you're gonna diminish the side effect of completion thyroidectomy, like recurrent nerve injury, hyperparathyroidism, or thyroid hormone replacement. You can diminish the side effect of radioactive iodine therapy. We spoke about it. Of course, the healthcare costs, these are very odd numbers, but it's much more expensive in the US to have a completion lobectomy to give radioactive iodine. And also the psychological and financial burden of a cancer diagnosis. We never talk about it, but there are definitely a big psychological and financial burden. For example, in some countries, the bank won't give you a loan to buy an apartment if you have a cancer diagnosis. So in addition to the changes related to NIFTP, based on all the study I showed you, it's clear that encapsulated follicular variant with invasion is different from papillary carcinoma because it has a different biologic behavior, rare nodal spread, if any, a different molecular profile, RAS. Really, it behaves like a follicular carcinoma. We didn't change the name to follicular carcinoma, but at least we started to separate it by put it in as a separate entity from papillary carcinoma. It's not under the papillary carcinoma section or chapter. So finally, we're gonna close this issue of follicular variant FNIFP with this statement from Charles Darwin, who said that to kill an error is as a good service and sometimes even better than establishing a new truth or fact. Now let's jump to another subject, which is the subject of thyroid carcinoma with intermediate prognosis. So all clinicians, this is a statement from Dr. Warner, who was a pathologist at Mayo Clinic, and he said that all clinicians used to think that the classification of thyroid cancer was very simple. There was a group of well-differentiated, slow-growing tumor that never killed anybody, and a group of rapidly growing tumor that killed everybody. And Dr. Rosar used to tell us as his fellow that when he was interested in thyroid at Washington University in St. Louis, Missouri, one of his the surgeon there made fun of him, said, "There's nothing about thyroid, it's very boring, that you have either tumor that don't kill anybody or tumor that kill everybody." Well, that surgeon was wrong. Dr. Rosar was right. There are tumors in between. They have been labeled for many years as poorly differentiated thyroid carcinoma. They are tumor of follicular cell origin, showing histologic and prognostic features intermediate between well-differentiated thyroid carcinoma like papillary carcinoma and anaplastic carcinoma. And here we have to thank Dr. Ozai for putting this entity on the map in 1984, where he described insular carcinoma. These are tumors with an insular, insulae in Latin means islands of tumor cells, and they resemble very much tumor, and Dr. Ozai acknowledged it in his paper that was described by the German pathologist Paul Langhans Theodor Langhans in 1907 as proliferating stroma. So when you have a solid trabecular insular growth pattern, when you have necrosis, capsular and vascular invasion, everybody agrees, and you don't have anaplastic feature, everybody agrees that these tumors are poorly differentiated thyroid carcinoma. But what do you do if you have solid growth pattern alone or mitosis necrosis alone. Here is the rub, here where people really disagree. So let's see two approaches to the issue. The first one was done in 2004 by a very good group from Italy, Dr. Mauro Papotti, where they defined poorly differentiated thyroid carcinoma on the basis of trabecular solid insular growth pattern, irrespective of mitosis and necrosis. And if you look at the data, the cases are really in between well-differentiated thyroid carcinoma and aplastic thyroid carcinoma, 83% of survival at 5 years. But when they developed a numerical scoring system, and the main component of that scoring system is necrosis, you can see that the cases with necrosis do very well. They even do better than papillary carcinoma. So clearly, I don't think it's a good idea to call something poorly differentiated thyroid carcinoma when, as a group, it behaves better than papillary carcinoma. I don't know if there's any tumor carcinoma in the human body that behaves better than papillary carcinoma. But when you have necrosis, the tumor is in between well-differentiated and anaplastic thyroid carcinoma. So, however, there was an opposite view, and I had this idea in 2006, say, why don't we define them on the basis of mitosis and necrosis, irrespective of growth patterns? So basically, the opposite concept. And when you look at these cases defined solely on the basis of mitosis, I took 5 mitosis per 10 hyperparathyroid and or tumor necrosis, you can see that you have cases like the one on the left, where they have a solid or nested growth pattern, and they contain necrosis. These are cases that everybody agrees upon are poorly differentiated thyroid carcinoma. And you have cases with papillae or follicular growth pattern, but with necrosis. And here we at Memorial for many years were the only people labeling this tumor poorly differentiated thyroid carcinoma. So when you look at the poorly differentiated carcinoma defined on the basis of mitosis and necrosis, they have a 5-year survival at 60%. So really in between well-differentiated and anaplastic. And when you look at the variables that affect outcome with this group of tumor, things like margin and extrathyroid extension, of course, make a lot of sense and will guide the outcome. But probably what is more interesting, what did not influence survival. The growth pattern, solid versus follicular papillary, did not influence growth pattern, as well as the cell type. So after this, our paper, a group of pathologists gathered in Torino, Italy, led by Dr. Zai, where they came with this definition for poorly differentiated carcinoma that has been adopted in the latest WHO and has been worldwide used, where you need to have solid nested insular growth pattern. You need to have an absence of the nuclear features of papillary carcinoma, and at least one of the following features: a mitotic index of 3 mitoses and 10. So here there is congruence with the Memorial approach. You have at least to have tumor necrosis or something called convoluted nuclei, which I understood mean hyperchromatic papillary carcinoma nuclei. So when you look at the data here, also the tumor are in between papillary and anaplastic, poorly differentiated. However, when you look at all the data, all the non-anaplastic cases, those cases without necrosis, whether they are papillary or poorly differentiated, they do very, very well. They behave like papillary carcinoma. So here again, you can see that it doesn't make much sense to call a tumor poorly differentiated when it has a behavior similar to papillary carcinoma. So we at Memorial for many years have used the poorly differentiated thyroid carcinoma definition based on mitosis and necrosis because it's the main cause of radioactive iodine refractory disease, and most patients who die of non-anaplastic carcinoma die of radioactive iodine refractory disease. Many of these radioactive iodine refractory poorly differentiated thyroid carcinoma are initially diagnosed as a classical papillary carcinoma, HER2 cell or follicular carcinoma. And here you have to put yourself in the shoes of the clinician when she or he has to face a patient with classical papillary. They usually tell them you have one of the most indolent tumor in the human body. Congratulations. We will, hopefully when I retire, I will transfer you to my partner who will succeed me. Imagine the deception of this clinician and patient when the patient comes back not only with a recurrence after 3 or 4 years, but also with a tumor that is refractory to radioactive iodine, and the patient has to be sent to a tertiary care center like Memorial or MD Anderson or Tata Memorial for targeted therapy. We also did a study on non-anaplastic thyroid carcinoma and found out that the main cause of death from non-anaplastic thyroid carcinoma are these poorly differentiated thyroid carcinoma defined on the basis of mitosis and necrosis. To bring this to life, so to speak, look at this case of a 72-year-old man with a 5.5 centimeter mass. The mass has a solid nested growth pattern. It has a high mitotic rate, but clear nuclei. So this case, if you use the Turin proposal, will be called papillary carcinoma solid variant, which has a 90% survival at 10 years. If you use the Memorial definition, it will be a poorly differentiated carcinoma. And what happened to this patient? Unfortunately, the patient died 4 years after diagnosis of vertebral and lung metastasis. So this is here the price of, in my opinion, not having the ideal nomenclature. So what we did in the WHO, we reconciled these two definitions. So now for intermediate prognosis follicular cell-derived carcinoma, we have one appellation, one name, follicular-derived carcinoma high grade. The tumor has to be invasive, and it has to have high-grade feature, either by the presence of mitotic count and tumor necrosis, and very important, no anaplastic histology. So this new entity here has two subtypes. Poorly differentiated thyroid carcinoma defined on the basis of the Turin proposal, and differentiated high-grade thyroid carcinoma that are defined, as we show you, using the Memorial definition. So here is going into details. So I repeat for the Turin proposal. So if you have a tumor with a solid growth pattern and no features of papillary carcinoma, you need to have one of the following three features: a mitotic count, tumor necrosis, or convoluted nuclei. Now, that was the 2017 definition of poorly differentiated thyroid carcinoma. And this tumor will be called poorly differentiated because if you you define differentiation as how close the tumor is from the adult organ, this tumor looks poorly differentiated because they have a solid instead of follicular growth that are closer to the fetal thyroid organ. However, you have high-grade tumor with a lot of mitosis and necrosis that their architecture is close to the adult organ. They have papillae or follicles. So these tumors that were not included in the old poorly differentiated definition, but now are included under follicular-derived carcinoma high-grade, are called differentiated high-grade thyroid carcinoma. Here you can have papillary and follicular growth, like the tumor above here, with necrosis that is needed, either tumor necrosis or a mitotic count of 5 per 2 square millimeter, one of those, and no anaplastic features. And these two tumors have the same outcome. They have, however, overall different molecular profile. The poorly differentiated thyroid carcinoma, because it excludes tumor with papillary carcinoma nuclei, is mainly a RAS mutated driven tumor with very few BRAF cases, and the differentiated high-grade thyroid carcinoma are tumor that are mainly BRAF driven because they include cases with papillary carcinoma nuclei. So that what I showed you was a very important change in the WHO. Another change is the entity squamous cell carcinoma of the thyroid. So in the 2017 WHO, this was considered a separate entity from anaplastic carcinoma. Now it's a form of anaplastic carcinoma. And the reason for that, first of all, let me tell you how it is defined in the 2017 WHO. It was defined as a tumor composed entirely of tumor cell with squamous differentiation. No papillary carcinoma with it, no follicular carcinoma with it. And we looked at this tumor in the paper that we published. We found out that 60% have BRAF mutations. And also we found out that the outcome, as you see from the Kaplan-Meier curves on the left, are similar to anaplastic carcinoma as a whole, clearly showing that this tumor deserves to be just a subtype of anaplastic carcinoma. Now, there is an important detail regarding anaplastic carcinoma that is not a classification issue really, but I really want to communicate to you because that has been a game changer in the treatment. Every time you have an anaplastic carcinoma, it's mandatory to check the BRAF status. It can be done using immunohistochemistry, which is quite rapid, or genotyping. And this is crucial because those patients who are BRAF mutated, as was shown by this study, when you give them BRAF inhibitor and MEK inhibitor, this BRAF V600E mutated anaplastic carcinoma, there is a chance that they will become resectable. And we have seen high pathologic response rate, and there is durable local regional control. And now actually it's an FDA approved and a standard treatment for BRAF V600E mutated anaplastic carcinoma. So it's really, once you have an anaplastic carcinoma, it's really an emergency in my hospital. We have to tell them before the weekend whether it is BRAF mutated or not. And this is just to show you this incredible PET scan of treatment and post-treatment, and after that the tumor can be resected. It won't save the life of the patient, but they will be able for many years, for a few months, at least many months or even years, to not have local regional problems. Another change is of clinical significance in the WHO is the one related to the entity cribriform molar variant of papillary carcinoma. So these tumors we know now do not have BRAF mutations. Rarely they have RAS or PIK3CA mutation. The main genetic problem of this tumor is a disturbance in the beta-catenin pathway. That's why when they occur within the setting of familial adenomatous polyposis, they have the APC gene is not functioning, and the beta-catenin is accumulated in this tumor. Any problem in the beta-catenin pathway will lead to beta-catenin accumulation and is typical of this entity. Other important finding that they have always TTF1 expression, but they have an absence of focal weak PAX8 and thyroglobulin expression. So based on that, many clinicians and pathologists think that because this tumor do not make any thyroglobulin, because this tumor don't have PAX8, radioactive iodine may not be needed in this tumor. But this is something that is new, that has to be really demonstrated. But I can tell you, we had a 16-year-old with the cribriform molar thyroid carcinoma with metastasis, and the clinician elected not to give radioactive iodine because in their opinion, this tumor is not follicular cell derived. So that's why this tumor is put under the category of uncertain histogenesis. Now, let me tell you about a very important change with the issue regarding medullary thyroid carcinoma grading. Since the definite histologic description of medullary thyroid carcinoma in 1959 by this physician from the Cleveland Clinic, including Dr. John Beach-Hazen and Hock, who described the dorsal variant, we have been using clinical and molecular characteristics to stratify these patients, like, for example, age, of course, stage, sex, serum, CA, and calcitonin. But bizarrely, no grading system has been used. And this is surprising because we know that medullary thyroid carcinoma is a neuroendocrine tumor, and we know that neuroendocrine tumors are prone to grading since there are very well established pulmonary and pancreatic neuroendocrine neoplasms that have well validated and accepted histologic grading schemes. This state of affair remained until 2020, where two groups, our group from Memorial and the group of Anthony Gill in Sydney, Australia, published two grading system of medullary thyroid carcinoma. Our grading system, published a little bit earlier than theirs, was based on tumor necrosis and high mitotic rate and was an independent predictor of poor outcome. A few months later, they published their own system. The main difference between these two systems, that is, one is a two-tiered approach, ours, very simple. You put a tumor in the high-grade category if you have a mitotic index of 5 per 2 square millimeter and or tumor necrosis. The system is more sophisticated. It had a three-tiered approach with an intermediate grade that is a combination of low mitotic count and tumor necrosis, as well as high mitotic count without tumor necrosis. We learned a lot from these two papers. You can see here the Memorial data, the 144 patient on univariate analysis. We learned that histopathologic parameters such as fibrosis were not prognostically significant. Now, in addition to mitosis and necrosis, pleomorphic nuclei made a difference, encapsulation, vascular invasion, extrathyroid extension margin, and node size. This is by univariate analysis. But when you go by multivariate analysis, all falls off, and the only really histopathologic feature that matters are mitosis and necrosis. The Sydney data had somewhat similar results. After univariate and multivariate analysis, again, the only histologic parameters that matters are mitosis and necrosis. Fibrosis, amyloid nuclear grade spindle cell, whether you have them or not, prominent nuclear and vascular invasion, all these do not make a difference. Now, after these two papers, a paper from Brigham and Women's Hospital by Dr. Justine Barletta at Boston validated both of these grading systems in a genotype cohort of sporadic medullary carcinoma. That is great. These papers are great, but they're not enough. We need a universal grading system, and we need one and in order to have one, we need consensus cutoff for all indices. We need a large cohort from multiple international centers. So this is where we published the International Medullary Thyroid Carcinoma Grading System in the Journal of Clinical Oncology. This was a very nice collaborative effort. We gathered 327 patients with resected medullary thyroid carcinoma, cases from Sydney, Australia, from Institut Gustave Roussy in Villejuif, France, led by Dr. Abir Guzlan, the memorial cases from the University of Bologna by Dr. Giovanni Tallini, and cases from Brigham and Women's Hospital by Dr. Justine Barletta. We, of course, counted mitosis at hotspots per 2 square millimeters, which is equivalent to 10 hyperfield on most microscope. We did the Ki-67 count the same way it's done in neuroendocrine tumor with at least 500 cells. We looked for tumor necrosis and a large number of clinical pathologic parameters such as sex, age, tumor size, and of course, stage and status of fracture line mutation. And as far as prognostic endpoints, we looked for overall disease-specific, locoregional free, and distant metastasis-free survival. Now, all the cases were looked at by people who are used to head and neck to read the thyroid tumor, whether they are endocrine or head and neck pathologists. One point here I want to make that we didn't assess the extent of tumor necrosis. We just coded them as present or absent. And this is an example of tumor necrosis. This should be differentiated from FNA-induced tumor necrosis. There is no fibrovascular proliferation. You have nuclear debris, abrupt necrosis, so to speak. And you notice here, interestingly, that there's not much nuclear pleomorphism in this area of necrosis. So what we did on this large cohort, we assayed the memorial system, the Sydney grading system, and 8 other potential grading schemes using variance cutoffs for mitotic index, Ki-67, and the tumor necrosis. Finally, all the results were gathered. We held a consensus conference, and a single system was agreed upon, named the International Medullary Thyroid Carcinoma Grading System. And this system is a 2-tiered grading system. And to get into the high-grade category, you need either a mitotic index of 5 per 2 square millimeters or more, or a Ki-67 proliferation index of 5 or more, and or tumor necrosis. And it's important in the pathology report to mention the mitosis and the Ki-67 as continuous variable, because the prognosis worsens as the proliferative activity of a tumor increases. When you look at the data for this International Medullary Thyroid Carcinoma Grading System, it's very clear that in every survival endpoint, whether it's overall, disease-specific, local-regional, or distant metastasis-free survival, it's really separating the patients very well. Just to give you numbers here, the 10-year disease-specific survival, if you have a low grade, is 97%, and it drops to 53% with high grade. The 10-year distant metastasis-free survival for low grade is 84%, and it drops to 31% for high grade. And the prognostic significance of this consensus grading system was maintained for each participating site in regard to overall disease-specific and distant metastasis-free survival. Only for local regional free survival, we were not able to reach significance for the Italian cohort. But perhaps the most important slide for this medullary thyroid carcinoma is here. This is the multivariate analysis, and you can see that this grading system is independent from very important other prognostic parameters, including stage, tumor size, postoperative CA and calcitonin, external margin status, age, extrathyroid extension, and vascular invasion. Now, this system was validated by an Italian group in an independent cohort of 111 cases. It predicted survival in disease-free survival in the entire cohort, including in sporadic medullary carcinoma. I don't know why they could not reach they could not predict survival, overall survival in the cohort, but they predicted disease-specific survival. And a study from Brigham and Women's showed that this tumor is reproducible among academic pathologists. Just to bring this to life, so to speak, this is a 66-year-old male with no distal met at presentation. This is clear medullary carcinoma. You can see the calcitonin stain on the right, the necrosis, again here with no nuclear pleomorphism. And the patient unfortunately died of disease 2 years and 3 months after thyroidectomy. So what are the remaining issues for this grading? We still do not know the real relation between mutation and grade in sporadic tumor. One paper showed no correlation between grade and sporadic mutation, but it was a small cohort done by Dr. Bailetta from Brigham. Another study from Paris showed the independent value of red vis-a-vis grade. We still don't know, the jury is out, but now we are doing a big genotyping study on this large cohort, and soon we will have the results. So what's the purpose of all this hard work is we hope that because patients with high-grade medullary carcinoma have a worse outcome, they will may benefit from early lateral neck dissection, close follow-up, low threshold for cross-sectional imaging, and careful workup for distal metastasis. Also, this can be used as data point for clinical trial because one will assume that high-grade patients may benefit more from adjuvant therapy. So basically, I would like to close this talk by showing you that we are really going toward a new nomenclature in tumor that better reflects behavior. That was done a few years ago with the staging system that went from anatomic staging to anatomy and prognostic staging. And you can see here that for histopathologic entity, we should base the definition on prognostic irrelevant histologic feature rather than clinically irrelevant histopathology, because we look, as Dr. Reuter, the Vice Chairman of Memorial said, because at the end, we pathologists are simply clinicians with a microscope. And here I would like to finish with this statement from Julian Huxley, who was a well-known British biologist, who said in 1958 in a lecture at the Sloan Kettering Institute, just a few hundred meters from my office, that cancer malignancy must be defined according to what the tumor cells do, not what they look like, otherwise the term ceases to have biologic meaning. And if we had done this with the follicular event, we would have spared a lot of patients unnecessary treatment and side effects. So this is the end of the talk. Thank you for your patience, and I'll be ready to answer questions. And thank you for the organizer for inviting me. Bye-bye.
Updates in classification from the Precursor 2022. And we will take the question answer in the next session. Thank you very much. Over to Margaret.
Thank you, esteemed speaker, and thank you, honorable chairpersons. The online participants may post their queries in the chat box, and the offline participants may write them down. They shall be duly addressed. This brings us to the end of the first session. Now I request Dr. Shalini and Dr. Shaila to take over for the next session.
Thank you, Dr. Radha. Thank you, Dr. Alka. Good morning, everyone. I, Dr. Shalini.
And I, Dr. Shaila Fareen from Pathology Department, SGPGIMS, and we will welcome to all for the second session of 24th International. Sorry for interruption. I, Dr. Shaila Fareen from Pathology Department, SGPGIMS, Lucknow, and we are honored to welcome you all for the second session of 24th International Academy of Pathologists Indian Division here at SGPGI.
We would like to begin our first talk of the session on grossing and minimal data set reporting in endocrine lesion. For this, we would like to invite Honorable Chairperson, Professor Uma Shankar Singh. He is the head of the Department of Pathology at King George Medical College. Professor Francisco Couto, he is a professor of pathology and the director of Goa Medical College.
He is also a vice president of Asian International Academy of Pathologists. And Professor Nuzhat Hussain, ma'am, she is head of pathology department at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow.
And she will be joining us online.
I request Dr. Francisco Couto sir to kindly introduce our speaker of this session, Professor Neha Mittal, ma'am, from Tata Memorial Hospital, Mumbai. She will joining us online.
Good morning, everybody. It's me great pleasure to introduce the speaker for our next session, Dr. Neha Mittal. She is professor in the Department of Pathology, Tata Memorial Hospital, in areas of interest of oncopathology. She has got a large number of national and international publications. Dr. Mittal will be talking to us crossing and minimal data set reporting in endocrine organ lesions. You may have Dr. Neha Mittal's talking.
Thank you. Am I audible?
Yes, ma'am.
Okay, I'll start sharing my screen. Is my screen visible?
Yes, ma'am.
Are the slides moving for you?
Yes, ma'am.
Okay, then I'll start. Good morning, everyone. And at the outset, I would like to thank all the organizers for giving me this opportunity. It's indeed an honor to be taking this talk with stalwarts like Dr. Khan and Dr. Gosain and all the other faculty members. Thank you, Dr. Couto, for that introduction. And my talk today is made much easier by Dr. Khan and Dr. Gosain by their wonderful talks and by apprising you all of the changes that have happened in the new WHO 5th edition 2022 in these endocrine organs of the head and neck region, namely thyroid and parathyroid. And I'll be restricting to the grossing of these organs only. So no financial disclosures, and some pictures in this presentation are from external sources which has been appropriately referenced. So I will start with thyroidectomy specimens. So learning objectives of this talk will be what, why, and how. So what specimens can we expect? What is the specimen that has been received? Why? Clinically, why the said procedure was done in a particular case? And from a pathology point of view, why a particular pathology warranted that particular surgical procedure? Or is the pathology enough for that surgical procedure, or patient needs to get something more? How? Then how to gross different types of thyroidectomy specimens that come to our table, and then how to report them, which is the minimal data set reporting. And this schema will say the same for parathyroid lesions as well. So starting with the that is the types of thyroidectomy that we receive. So it is hemithyroidectomy or lobectomy, total thyroidectomy, isthemectomy, and near total thyroidectomy and completion thyroidectomy. And on the right hand side, you can see that these are the usual principles for why we receive these specimens. So for a less than 4 centimeter classical papillary thyroid carcinoma without any high risk features on imaging or on clinical examination, a hemithyroidectomy will be done. A less than 1 centimeter follicular thyroid lesion or follicular carcinoma or a follicular lesion, a hemithyroid will be done. From 1 to 4 centimeter, the literature is divided. Some people would still go ahead with hemithyroidectomy. Like at Tata Memorial, we would still go ahead with hemithyroidectomy for up to 4 centimeter of follicular thyroid lesions, whereas some people would like to do a completion in such cases. Then medullary, poorly differentiated thyroid carcinomas and anaplastic thyroid carcinomas always undergo total thyroidectomy. So it is important to know the clinical suspicion, the preoperative imaging findings, as well as the preoperative FNA findings that are present in a particular case. Then I come to why. What are the indications for thyroidectomy? So thyroidectomy may be done for benign or inapparent lesions. It may be done for thyroid nodular disease, multinodular disease, multinodular goiter, or it may be a genetically determined nodular disease of the thyroid, refractory hyperparathyroidism, large solitary nodule, refractory hyperthyroidism or Graves' disease, large solitary nodule for cosmetic reasons, and a prophylactic thyroidectomy for Men's syndrome. Malignancy, it may be done for malignancy which is FNAC proven. So when you have a definite lesion, then you may have a thyroidectomy. In such a case, it is very important to record the clinical, which is the clinical and the USG thyroid findings and the pathology findings of the preoperative procedures, which may be an FNA in most cases, but also may be intraoperative consultation or frozen section examination. All those findings are very important. Any touch smears, any imprint smears made at that time must also be included in your reporting. Thyroid nodule. FNAC results are suspicious, Bethesda category 3 lesions repeated twice or indeterminate. And in such cases, the procedure may be diagnostic, that is a lobectomy or a hemithyroidectomy, which may again be received for frozen section or directly for final histopathology. Thyroid nodular disease and prophylactic total thyroidectomy, as I've already said, for Men's syndrome. What are the relevant points that we have to take into account before starting to gross any thyroid specimen? What is the type? It is mandatory to record what was the type of procedure. As I said, what was the purpose of that procedure? What was the indication of surgery? In particular, whether a malignancy was suspected or not, based on any prior surgery, FNA or intraoperative consultation. And this is also very important, whether there was any prior procedure that was done, any prior surgery. Is this a surgically naive patient, or is this a completion thyroidectomy or some kind of a revision surgery? If available, and I would insist that actually they should be available, that imaging findings, which includes the number of suspicious nodules, their location, their sizes, a good imaging should always be accompanied by when you are looking at a thyroid specimen or to gross or report a thyroidectomy specimen. And in fact, imaging of thyroid has undergone revolutionization, and they can actually give you scores and tell you risk of malignancy in a particular thyroid nodule just based on the ultrasound features. And this is the American College of Radiology TIRAD system, which is the most commonly used system worldwide, which is based on composition, echogenicity of nodules, shape, margin, and echogenic foci. And they actually give you a risk of malignancy in which 4C and TIRADS 5 are highly suggestive of malignancy, whereas the others have probably benign or low risk of suspicion. So it should be, the thyroid ultrasound should be reported in accordance with these guidelines. And these are the reasons why the nodule may look more malignant, is that solid appearance, taller than wider, irregular borders, microcalcifications, and markedly hypoechoic. So even if the TIRADS has not been mentioned in your ultrasound thyroid report, please look for these features in the thyroid ultrasound report in the particular case when you are looking at a thyroidectomy specimen. Then this is our own data from Tata Memorial, where we came up with this new classification system on imaging, which is known as the TMC RSS score, which had a very high sensitivity and specificity to identify malignancy and characterization of thyroid nodules. And this is also used in multiple places in the world. And this is a combination of TIRADS, vascularity, and elastography, Doppler and elastography, and has a very high sensitivity and specificity. All to tell you that imaging findings are very important before we start grossing or start looking at a thyroidectomy specimen. And coming to how to gross a thyroidectomy specimen. So as you can see, this is on the right hand side is a total thyroidectomy specimen. Identify the type of specimen, laterality in case of lobectomy or hemithyroidectomy. That must be done. Type of specimen, orient the specimen. For orientation, identify the isthmus, which is located inferiorly to the two lateral lobes. So identify the isthmus, which is located at the lower part of the two lateral lobes, and must remember that thyroid on the anterior surface is convex or bulging, and on the posterior surface is convex. and that is concave, sorry, is concave, and that is how you can orient a thyroidectomy specimen, which is not distorted beyond distorted because of the nodules or because of the disease. And if that has happened, in that case, please ask your surgeons. It is a good idea to mark a suture at the superior pole of one or both lobes in that situation, which will definitely help you then identify and orient your specimen, or go back to your imaging findings. And that is one more important feature of the imaging findings. Go back to your imaging findings and try to correlate with the size of the lobes and their features on ultrasound for orientation of the specimen. The lobes tend to taper superiorly and are broader at the inferior pole in most cases. Then weigh the gland, it is important, orient the gland, record the dimensions of each lobe, isthmus and other tissue attached before slicing the lobes. Then comment on external surfaces, both anterior and posterior. Are there any additional findings? Is there any attached strap muscles? Are there any other attached structures? Is there fat associated? Do you have any nodes around the isthmus region? All those features have to be described and taken, made an account of in the gross recording. Then anterior surface is convex and encapsulated, as I said. Appearance, nodular or bossylated, all those have to be. Then what is the appearance of the external surface? Is there unilateral enlargement, presence of any nodule or cyst? Please look at your right. This superior pole has been marked, as I said, with the thread. This is the left lobe, this is the right lobe of the thyroid. And what you see here as a slit and something that is seemingly, questionable, what is this, whether it's a lesion or not, sorry for this thing, is actually a thyroglossal cyst, which has been diagnosed. And this is a thyroglossal cyst seen on the anterior aspect of the thyroid. And later we will see more sections of the more grossing of this very specimen. Again, capsule, situation of the capsule, whether the thyroid, the irregular thyroid capsule, whether it's intact or breached, any other structure adherent to the gland. Look for parathyroid gland along the posterior surface. And if you can identify grossly, please record the presence or absence or number of glands. Then ink the specimen. As shown previously, it is a good practice to ink the both lobes and the isthmus with separate colors. You can ink the right lobe with the blue color and the left lobe with the black color, and the isthmus with yellow or orange color, as done in this case. This helps easy identification of the lobes in final histopathology as well, and the margins also. So ink the specimen. This is just to show another specimen, another common specimen, which is the hemithyroidectomy. Orient the specimen. As I said, in this case, you might need the help of the surgeon to orient the specimen, preferably asking the surgeon to put a stitch at the superior pole. Ink only the cut end of the isthmus with a different color. If you're trying to ink hemithyroidectomy with different colors, only the cut end of the isthmus and not the entire isthmus has to be inked with a different color. And then serially slice from superior to inferior, whether it's a total or a hemi, serially slice from superior to inferior pole, leaving the different cuts attached to each other. Do not separate the lobes before fixation is completed. So this is just to show a diagrammatic representation. Hemithyroidectomy, only ink the cut surface of the isthmus to identify this as the surgical margin. Do not ink the entire isthmus as a separate color. And then serially slice from superior to inferior. Total thyroidectomy, ink the two lobes and the isthmus separately. And again, serially slice from superior to inferior. The isthmus has to be sliced from one lobe to the other, or left to right. Ink, serially slice, and formalin fix the specimen. Formalin fix all thyroid specimens. It is very important in a high volume center like ours, where it is very easy to gross a thyroidectomy specimen the same day because it's a very small specimen and it can be done very quickly. Do not do that. Formalin fix all the thyroid specimens. Always remember that nuclear features are an artifact of fixation. If the specimen is not fixed properly, the nuclear features may not be well developed. So always fix all your specimens. And that is why I said, when you serially slice, do not separate. Do not separate. Separate when you are final grossing the specimen. So when you are grossing it finally the next day after fixation of around 24 hours, then separate the two lobes and the isthmus. Serially slice each lobe and isthmus. Slice the lobes. What is the way to slice? As I said, superior to inferior. How, if your lesion is less than 2 centimeter, correlate with your USG findings if your lesion is less than 2 centimeter. If your lesion is more than 2 centimeter, then it's a good idea to avoid bulging of the nodule in those serial slices. And then you will not get an idea of the capsule. The capsule will retract and the nodule will bulge. So if your lesion is more than 2 centimeter, first halve the specimen, like you would slice the kidney. Like you would go from the center of this thing, make a half of both the one lobe, and then serially slice them from superior to inferior and submit according to the lesion that you're looking at. If there is a lesion, if there is a discernible lesion, the lesion has to be measured in all 3 dimensions. Though the largest lesion dimension is absolutely important to be measured, but it is preferable to measure in all 3 dimensions of the lesion. If there is a measurable or a describable nodule, then what all factors will you see in the nodule? Of course, the number of nodules, their location, dimension of all the nodules in all 3 dimensions, gross appearance of the nodule, whether it is solid, cystic, what is the consistency, shape, color, and circumscription of the nodule. Is there a gross capsule present? If present, is the capsule infiltrated grossly? Are there multiple nodules outside the capsule? And what is the distance of the capsule, thyroid capsule or ink surface or the margin from the thyroid nodule capsule? Extrathyroidal extension present, absent, and if available, correlate with intraoperative nodes. It's a very good idea to correlate the extent of extrathyroidal extension with the intraoperative nodes, because the meaty brown color of the thyroid sometimes merges with the strap muscle, the brown color of the strap muscle. And when there is a tumor which is infiltrating, there is a fibrous reaction. There may be a fibrous reaction. So small amount of strap muscle may not be very discernible in a gross specimen. And please do correlate with intraoperative findings. And if the intraoperative findings mention gross extrathyroidal extension, which is a very clinically significant parameter, then please go ahead and sample more of the external surface of the thyroid with the surrounding attached tissue, where whatever is available. Then appear, color, and consistency of the adjacent thyroid. Do not forget the adjacent thyroid, and always sample as well as mention the status of the adjacent thyroid in your grossing specimen. So this is to show you the grossing of the total thyroidectomy specimen. So serially sliced from superior to inferior. This is when you are suspecting, you have the previous information of FNA or intraoperative that you are suspecting a PTC, a classical PTC or some variant of PTC. In that situation, you are serially dissecting superior to inferior. You can see the lesion has started appearing, and you measure the lesion, as I said, grossly before you serially slice and lay these out specimen, the sections. You should have measured the lesion in all 3 dimensions, identify the characteristics of this lesion, and in the right lobe, the ultrasound findings described the right lobe lesion, which correlated with what we saw on gross. But also when we serially sliced the specimen, we discovered that there was a 3 millimeter nodule in the left lobe of thyroid, which was not described on the USG findings. And this is an incidental finding, which is very important because in this situation, looking at the 2 on gross, it seems to be the same tumor nodule and makes the lesion multifocal. And this is just a closer view to show you that this is an incidentally detected 3 millimeter nodule in the left thyroid lobe. And here in this area, you see some brownish tissue at the edge of the tumor nodule, which appears to be the skeletal muscle or the strap muscle. There is very little of this peripheral tissue that is available, and this is suspected extrathyroidal extension. It did correlate with the intraoperative nodes as well. And that is why this area definitely needs to be included when you are blocking your sections, when you are putting your sections in the cassette to look at presence of extrathyroidal extension. And this is again coming back to that specimen which showed you this cystic structure on its anterior aspect. Further dissection showed that the smooth walled cyst is transitioning into this friable papillary growth, which is extending to the left lobe of the thyroid as well. You can see this friable papillary growth, and this is how then we further grow this specimen, where we have again dissected this from superior to inferior. All the entire thyroglossal cyst has been sampled. Again, multiple serial sections, and both the lobes and the isthmus have been dissected from superior to inferior lobe. And we can see that this is a thyroglossal cyst. We can see on the extreme right, the cyst wall, which is transforming into this solid area. And this area is also showing papillary excrescences. So this is actually a case of PTC classical arising in a thyroglossal cyst, which is also extending to the thyroid lobes. This was for classical PTC, when you have an idea that you're dealing with classical PTC or any of its variant. The grossing protocol will change if your preoperative FNAC suggests a Bethesda category 4 or a follicular neoplasm. In that situation, as I said, most of the times what you'll receive is a hemithyroidectomy, and this is just to show you the hemithyroidectomy specimen. This is what I said by meaning that you have to halve the lesion when you have a tumor which is more than 2 centimeter to avoid bulging of the nodule in your sections, and in that will make it improperly sectioned later on, so that the capsule will not be appreciable. And after that, the grossing protocol remains similar till the fact that superior to inferior serious slicing of both the halves has to be done. However, after doing that, this area, which is the interface, you can see this is a very nice encapsulated lesion, and here the capsule is becoming the thickest. So these areas of the capsule and all the areas of the capsule have to be sampled. So it is essential to submit. I cannot emphasize this enough, that it is essential to submit the entire tumor capsule in an encapsulated lesion. And these areas of thick capsule have to be especially serially sliced at 2 to 3 millimeter intervals, and thin sections of these areas to submitted them entirely. This does not mean that each of these sections has to come on a single slide. And I've just to show you, this is a pictorial representation that how you can put different sections of the capsule. These are 3 different peripheral areas with the capsule and the surrounding thyroid. And I put them on one slide like this, like a crescent moon. So multiple slices of the capsule, I'm sorry, can be put on one single slide, but do not fall short of sampling the entire tumor capsule. It is absolutely essential in a hemithyroidectomy for a solitary or multiple encapsulated nodule of the thyroid. So this is just to show you diagrammatic representation, sorry, of the same thing. It is essential to submit the entire tumor capsule, submit the central part as well, because it is the central areas which show papillary architecture. So when you submit the periphery, you look for capsular invasion, you look for angio invasion, you look for criteria of malignancy. But when you submit the central area, you help in subclassifying the lesion, because that is where many a times your papillary areas might be sitting. So as Dr. Gosain has already said, 1% papilla, more than 1% papilla changes the criteria. It cannot be a follicular lesion anymore. Though up to 10%, he showed the data that up to 10% papilla does not lead to lymph node metastasis. But as per the criteria, 1% more than 1% papilla is unacceptable for follicular lesions. So what are the sections? Once you've done the grossing in this manner, what are the sections? Again, the sections are determined by what were your gross findings. So that is very important that you gross it properly. If there was no focal lesion, then each lobe at least 3 sections, isthmus 1 section, and multinodular thyroid gland, each nodule at least 1 section, including rim and adjacent normal. You can never predict which one of those nodules may actually harbor a neoplastic lesion. So that is why it is all those individual nodules have to be sectioned as if they can later on turn to be neoplastic. Additional sections from nodules with thick capsules. This is very important, or heterogeneous appearance. Submit sections from all foci of white cream tissue. The moment the previous grossing I showed you, the lesions were white and cream, that is high risk for malignancy. And all such foci of white cream tissue have to be submitted, as they may represent cancer. What about solitary encapsulated follicular lesion, like the last picture where you clearly see a lesion? Less than 3 centimeters, submit the entire lesion. In thyroid, the more the better. Please follow the protocol, the more the better. More than 3 centimeters in maximum dimension, alternate serial sections or 1 section per centimeter of the lesion. I would say try to do as much as, I would say 2 sections per centimeter at least, or if possible, if it is a if it is acceptable for your lab, then try to sample as much as possible. As I said, more is better. Regardless of the size of the lesion, submit the entire tumor capsule demonstrating relationship with the adjacent tissue. There is no shortcut to this. The entire tumor capsule has to be submitted. Non-lesional tissue has to be blocked, further blocks from each lobe and 1 from the isthmus. Non-involved lobes, 2 blocks from each lobe and 1 from the isthmus, even if they are seemingly uninvolved. For suspected cancer, papillary, medullary, or undifferentiated, less than 2 centimeters, submit all tumor tissue. More than 2 centimeters, again, 1 section to 2 sections per centimeter. As I said, the more the better. Non-lesional tissue, 3 further sections from each lobe and 1 from the isthmus. Prophylactic thyroidectomy for suspected medullary carcinomas, submit all tissue. Those thyroids are usually small, the lesions are grossly inapparent, and hence it is a dictum to submit all tissue. Completion thyroidectomy in a known case of malignancy, submit all foci of white cream tissue. Better to submit all tissue for processing if possible in your lab, but definitely submit all white cream tissues. Other rare inflammatory conditions may also require extensive sampling of the thyroid to look for small foci of incidental malignancies. Then, and you cannot ignore the lymph nodes and additional tissues that have come with the thyroidectomy specimen. Lymph nodes, record them separately. The ones retrieved from the resection specimen, again describe site and the number, and then separately submitted. Collective size of 3 dimensions, grossly identified lymph nodes, and maximum diameter of each, and if they are grossly involved or not. Adjacent tissues such as fat, skeletal muscle, and parathyroid glands, and note any extension of tumor into these tissues. Coming to minimum dataset reporting of thyroid, it is basically a combination of 3 things. The 8th edition AJCC staging protocol, which is the T, N, and M classification, again further subdivided. The T and M of the thyroid is dependent on the histological subtype. It is different from papillary, medullary, and anaplastic thyroid cancer. But this is what we take into account when we are reporting the minimal data set. The newer WHO classification, about which you heard in detail already from Dr. Gosain just a while ago, the newer classification, and the ATA risk, or the American Thyroid Association risk stratification of thyroid lesions, which for the first time actually took into account the histological parameters. For example, aggressive subtypes of PTC, tall cell, columnar cell, hobnail variant, then BRAF mutation present or not, then what is the multifocality if it is present or not. Minimal extrathyroidal extension on microscopy has no ATA risk stratification significance. However, gross extrathyroidal extension changes the category of ATA risk stratification to intermediate risk, and that is why recording of gross extrathyroidal extension is very important. So a combination of the parameters required for AJCC staging, WHO classification, and ATA risk stratification will automatically give you the minimal data set reporting, including the core and the non-core elements of the thyroid reporting protocol. The core elements, which are the absolute must and must be included in all reports, are the type of operative procedure, the operative findings, the specimen which has been submitted, tumor focality, site, dimensions. In this, the largest dimension is mandatory. All 3 dimensions are preferable. Histological tumor type, mitotic activity, tumor encapsulation or circumscription, capsular invasion wherever applicable, lymphatic or blood vessel invasion. These are two separate things. Lymphatic invasion is different from angio invasion. Lymphatic invasion happens in PTC, whereas angio invasion happens in follicular thyroid cancers. Angio invasion is a harbinger of poor prognosis, whereas lymphatic invasion is just a way of papillary thyroid carcinoma to spread to the lymph nodes. Hence, angio invasion is what you are looking for, especially in a follicular thyroid lesion. Necrosis absolute must. Extrathyroidal extension, gross, more important than microscopic. Margin status, whether free or not, whether the tumor has been completely resected or not, because that changes the TNM stage. Lymph node status, again very important prognostic factor and changes the TNM stage. Coexistent pathology, parathyroid gland status if present, histologically confirmed distant metastasis, again important for TNM, and pathological staging, which is the PTNM staging or the, as I said, AJCC staging criteria. All these parameters are an absolute must. This is just each of these in detail. Mitosis, urine and MSKCC. So depending on the case in hand, whether 3 or more mitoses are significant, or MSKCC criteria, whether more than 5 mitoses and or necrosis is important. Differentiation or grade where necessary, as has been told, medullary thyroid, high-grade differentiated thyroid carcinoma, poorly differentiated thyroid carcinoma, presence of differentiated component, and the grade depending on mitosis and necrosis has to be mentioned. Number of tumor foci, angio invasion and lymphatic, as I told you. Classification of angio invasion into less than 4 and more than 4 vessel. Extensive angio invasion is further harbinger of poor prognosis. Perineural invasion is no longer a core element in the thyroid reporting protocol. And these are just to show you the different types of histological subtypes. The first picture on the left is a NIFTP capsule, totally encapsulated, subtle nuclear features of PTC, and absolutely no capsular or angio invasion. Then cribriform morular, the insert shows the strong beta catenin. This is a recent entity, adamantinoma like U-wings of the thyroid. Then tall cell subtype, 3 times taller nuclei than wider. Very well developed nuclear features of papillary thyroid carcinoma. The insert shows the BRAF mutation. These are practically now in 90% cases defined by BRAF V600E mutations, and combination of TERT promoter mutations with BRAF is an indicator of distant metastasis in these lesions and is important. Hobnail subtype, again a high risk subtype, and medullary thyroid carcinoma. So all of these, presence of tall cell subtype, especially in a patient who has been subjected to hemithyroid, if it was a 2 centimeter lesion, but this is a tall cell subtype, BRAF mutated, or a Hobnail subtype, you have to inform the clinician that the patient has to undergo a completion thyroidectomy because of presence of high risk features in the final histopathology. And that is why there is importance of each of these histological subtypes as well. Then necrosis, mitosis, increased mitosis. You can see even in this field, there are 2 to 3 mitoses in a single field in this case. Then capsular invasion and extrathyroidal extension into the skeletal muscle. There is again a controversy regarding what should be taken as the definition of extrathyroidal extension. Describe both big vessels, big venous channels, big arterioles or arteries. If you see tumor next to them, most likely that is extrathyroidal extension, and extension into skeletal muscle is definite extrathyroidal. So mention presence of tumor adjacent to big arteries or vessels or veins, and mention that there is no skeletal muscle involvement, but mention that there is involvement of these structures, and record it as your extrathyroidal extension. Record both. And then angio invasion, in which we have specific criteria for identification of capsular and angio invasion. So for capsular invasion, only when it has gone beyond the capsule, even though there might be a pseudo capsule around that mushrooming out lesion, there may be a pseudo capsule, but only when it has gone beyond the capsule will you call it capsular invasion in a follicular neoplasm. Something like this is not capsular invasion. Something like this B is not capsular invasion, I is not capsular invasion, G is also not capsular invasion. But at the same time, please refrain from calling any such lesion with B, I, or G-like pattern as NIFTP. Go ahead, sample more, take deeper sections, but do not upfront call something which shows B, I, or G-like areas as NIFTP. It is unlikely to be NIFTP. NIFTP should not even show this much. So be very careful about what to call as capsular invasion, and of course, on the other hand, also what to call as NIFTP. In angio invasion, it is I will just mention, I'm sure you all know, but this D category in which there is an endothelial line over the tumor, and the tumor seems to be present within the wall of the vessel. This is one controversial area. Some people do consider this as angio invasion and the others do not. But this is one area in which, where this angio invasion or not, it is, controversial. We've not decided whether to call, but something like this E, where you have a tumor thrombus associated with the tumor, which is attached to the endothelium, is a definite focus of angio invasion. And so is this, which is outside the thyroid capsule, outside the tumor capsule. And this is already has been told to you by Dr. Gosain, in which this is just to show you in summary the how do you classify the follicular, different follicular pattern lesions of the thyroid. So less than 1% papillae is important. No nuclear of features of PTC, so follicular lesions. Then look at whether it is minimally invasive or early or angioinvasive, encapsulated angioinvasive follicular carcinoma. If nuclear features of PTC are present, then see if it has a capsule or not. If no capsule, follicular pattern, then this was known as the original infiltrative FVPC with the spidery type of infiltration, which Dr. Gosain very beautifully described in Dr. John Rosai's paper. And that is why this category has now been included in classical PTC, because this behaves like classical PTC and is BRAF mutated. And in this entity, these two comprise the new entity which has been taken out of the PTC criteria, PTC subtypes now, which is the invasive encapsulated FVPC, in which you have tumors which have a well-defined capsule with capsular and or angioinvasion, and these are RAS mutated and more close to follicular lesions or follicular thyroid carcinomas or adenomas as compared to classical PTCs. And the NIFTP, where you will not have any capsular or angioinvasion and you will have complete encapsulation. And now the new criteria of negativity for BRAF has also been added for NIFTP. And also you can have now NIFTP diagnosis in less than 1 centimeter and even purely oncocytic lesions. So these are documents which I have already said. Nodes, very important to describe the nodes. Number of nodes, nodal levels, size of largest metastatic, presence or absence of extranodal and nodal level. Distant site involvement, if present, is mandatory. Pathological classification, PTNM, is mandatory, and additional tissues and ancillary studies, if present, are desirable. With that, I will shift to parathyroid very quickly. Coming to parathyroid lesions. So parathyroid often come for intraoperative consultation. So in order to identify parathyroid tissue or to verify a lesional gland, it is important to weigh all of them, even a small fragment that comes for frozen, measure in all 3 dimensions, ink the outer surface, serially section and photograph. Describe outer and cut surface, size, dimension, cut surface. If small, less than 2 grams, submit entirely. If large, without worrisome features, submit multiple representative. Ideally speaking, again, more is better, submit entirely. If worrisome features, which means very large, heavy, adherent to surrounding structures, or the surgeon raises a concern for a malignancy in the parathyroid, or the preoperative biochemical markers, very high serum calcium, more than 15, very high serum parathyroid hormone levels, all those, then submit entirely after inking the outer surface of the parathyroid gland. It is very important. This is the new WHO classification on the left hand side, and this is the summary of core and non-core parathyroid data set. This thing again, almost the parameters remain the same. Again, clinical information, operative procedure is important. Specimens submitted, tumor site, weight, histological type, tumor dimension, grade, invasion, lymphovascular invasion, perineurial necrosis. So extent of invasion, capsular invasion has no significance presently in the parathyroid. Only invasion of the surrounding tissue. It may be thyroid, it may be extrathyroidal, it may be fat. Only invasion of the extra parathyroid tissue is important. Capsular invasion is not taken as a feature of malignancy in parathyroid tumors. But in lymphovascular invasion, you have to document both of them separately, lymphatic invasion as well as vascular invasion within the tumor capsule or outside the tumor capsule. Necrosis, mitotic count, lymph nodes if present, and then again histologically confirmed distant metastasis and pathological staging. Then it is preferable to do parafibromin staging. One important INSM1, which is a new marker for neuroendocrine and neuroectodermal differentiation tumors all over the body. For reasons not entirely known, INSM1 is entirely negative in all parathyroid lesions. So parathyroid adenomas and carcinomas are negative for INSM1. And that is an important fact when you are trying to distinguish a parathyroid lesion from a neuroendocrine lesion or of any other site. And, or if you're trying to diagnose a parathyroid lesion at a metastatic site. This is the essential criteria for parathyroid neoplasm. As I said,
Neha, can we wind up fast, because I think we're really running late.
One more slide.
Thank you. Thanks. Wonderful presentation.
Thank you. So this is one of our cases, just to show you a gross of this thing. This was a lesion which was suspected on FNA as query parathyroid, query thyroid with atypical features. And as you can see, this was almost in this picture, it may not seem that way, but it was like an 8 to 10 centimeter lesion. And this was pearly white, these areas. And then there was some surrounding thyroid tissue at the periphery. However, this nodule looked separate. This nodule looked different. So if we sample only this area, the white area, this was like an anaplastic. You can see a very undifferentiated looking sarcoma. But only when they sampled this area, this different looking pale brownish area, that we discovered that this was actually a parathyroid carcinoma, which was having this kind of an anaplastic transformation, so to say. So this is present terminology is not clear. This is only 2 more cases are reported in the world. So this is actually a parathyroid carcinosarcoma. So just a case to show you, it's a very odd case, very rare case, but just to show you that even for lesions in the thyroid, in the parathyroid, submit all different looking areas for a proper categorization of the lesion further on. And this is just one slide on paragangliomas, which are another endocrine neoplasm in the head and neck region. Again, it is actually metastasis, which classifies a paraganglioma as malignant, and SDHB IHC should ideally be done in all cases, because it helps us differentiate the familial and the genetically determined paragangliomas, which are more likely to turn malignant than the ones which are sporadic. Rest, extent of invasion, lymphovascular, margin status, proliferative fraction, all those parameters stay standard for whatever neuroendocrine tumors we have seen or other tumors that we have seen till now. So this is just to show you in gist the grossing of all the neuroendocrine related and thyroidectomy specimens of the head and neck region. My acknowledgements, Dr. Savri Patil, Dr. Munita Bal, Dr. Swapnil Rane and Dr. Katha Kante, my colleagues in head neck pathology DMG at Tata Memorial. Dr. Gosain, this talk cannot end without thanking him. In whatever little time I spent with him at MSKCC, he literally opened my eyes to the beautiful world of thyroid pathology. All the colleagues, residents and histotechnicians in my department, and definitely my head and neck disease management group at Tata Memorial Center, which always push us to do more and better. Thank you. With that, I would love to take questions.
Since time has been overshot, as we told, don't have time for questions. Thank you once again, Dr. Neha. And thank everyone for attending this session. On behalf of my co-chairperson, Dr. Mozart Hussain, I think is online, myself, thank the organizers for asking us to chair this session. Thank you very much.
Thank you very much.
providing us importance of blocking and reporting. And it will definitely help us in future.
Thank you, all respected chairpersons.
And we have both online and offline participants here from across country and other countries as well.
Requesting all the online and offline participants to kindly post your query for the meet of expertise session at 5 p.m. All are feel free to interact with the online expertise. Now, we hand over the next program of inauguration to Dr. Alka and Dr. Radha.
Thank you, Dr. Shalini and Dr. Shaila. Now we shall have a short inauguration function. We welcome you all again for the IPID annual 24th IPID annual CME 2022 here at SGPGIMS. Now I invite Dr. Seema Sharma, Head, Department of Pathology, SGPGIMS, Dr. Manoj Jain, Organizing Chairperson, and Dr. Vinita Agarwal, Organizing Secretary at IPID CME 2022 to welcome the guide.
So let's start. Due to heavy rain, we had to make just makeshift arrangement here. I apologize for all the inconvenience to all the participants, and on behalf of all organizers, I welcome you all. So we just deeply regret that this just makeshift arrangement we could make, and after that we'll be having our regular session here.
So we all welcome you, although not warmly, but really. So I hope that you will forgive us for this arrangement, but sorry for this arrangement. But I hope that after this we will go on smoothly. Thank you very much for being here.
We will be having shortly our informal inaugural function. Our dean and director could not join us. So as a mark of gratitude, we wanted to felicitate our all senior teachers here. So that just we will be doing that part, and then we'll be moving forward. So can you start?
We are truly privileged and honored to have with us some of the distinguished persons in the field of pathology. We would like to honor them as a mark of our respect and gratitude.
We have with us Professor R.K. Gupta, sir. He was the former head, Department of Pathology, SGPGIMS, as well as the Dean of this institute. a pioneer in establishing renal pathology as a subspecialty in the country. He was also the founder of Indian Society of Renal and Transplant Pathology and one of the brains behind the investigation revolving fund established at SGPGIMS. So we are honored to have you. We request Dr. Seema Sharma ma'am to honor sir.
Thank you, sir. I now invite Professor A.N. Srivastava, former senior professor and teacher, KGMU. He is currently serving at Eras Lucknow Medical College as Director of Research and Head of Department Pathology. He has wide areas of interest, including a keen interest in research. We are honored to have you here, sir.
We request Dr. Manoj Jain sir to present a token of gratitude.
Thank you very much. Thank you. All these have been my students in MDs. Sir is my mentor, my MDs is a guide.
Thank you, sir. Now I invite Professor S.M. Natu, a beloved and astute teacher, a former senior professor at KGMU. His prolific work dedicated to clinical chemistry and lab medicine is noteworthy. It is a pleasure to have you here, sir. I request Dr. Vinita ma'am to kindly present a token of our appreciation to sir.
Sorry. Thank you. Thank you.
Thank you, sir. Thank you, ma'am. Now I invite Professor Asha Agarwal, ma'am, an eminent professor and former head of Department Pathology, GSVM Medical College, Kanpur. She has a vast experience in histopathology and has been a very popular and dynamic teacher. We are glad to have you here, ma'am. I would request Dr. Seema, ma'am, to kindly honor.
And Seema is my friend, and she has, I'm so proud of you. Thank you. It's always proud when yes, you
Thank you, ma'am. Now I invite Professor E.M. Pathak. Ma'am is a senior pathologist and also a former president of Indian Association of Pathologists and Microbiologists. Ma'am, it's an honor to have you here. I request Dr. Vinita ma'am to please present a token of our appreciation.
Thank you, ma'am. Now I would request Dr. Arvind Rajvanshi, former head Department of Cytopathology, PGIMR, Chandigarh, Now currently he is serving as the Executive Director at AIIMS Raebareli. I would request Dr. Manoj Jain sir to kindly honor. Yes, sir.
Thank you very much.
Thank you very much, sir. We would also like to acknowledge those who are unable to join us today due to unavoidable circumstances. Professor Rakesh Pandey, former Professor and Head Department of Pathology, SGPGIMS. Professor Manjula Murari, former Head of the Department, Pathology at SGPGIMS. Professor Ashutosh Kumar, former Head of the Department, Pathology, KGMU. Professor M. Bagchi, Dr. P.K. Agarwal ma'am, and Dr. Madhumati Goel ma'am.
Also, I would like to inform that we have prepared the e-souvenir of 24th IAPID Annual CME 2022. The soft copy will be available on the website for downloading.
Now I take the pleasure in inviting Dr. Anita S. Baduri ma'am, President, International Academy of Pathologists, Indian Division, to address the gathering.
Very good morning to all the dignitaries in the audience, senior and junior colleagues from India and the USA, and all participants of the CME. On behalf of the IAPID, I extend a warm welcome to you all to this beautiful city of Lucknow and the SGPGI for the 24th annual CME of the IAPID. Lucknow is known as the Golden City of the East and has been playing a pivotal role in India's history. It was also the center of many cultural movements, the seat of royals, Nawabs, British viceroys, not to forget the Mughals and the Persians. The quintessential Lucknowi tehzeeb that we admire today, with the love of arts, music, poetry, and grand traditions, typifies the heart of soul of Lucknow. And we can see that today's inclement weather has jinxed all the plans that the team of pathology at SGPGI had put up, and how they have risen to the occasion and tried to make a success to the best of their abilities. I think we need to give them all a big hand. It's a pleasure to meet in person so many of my contemporaries, juniors, seniors, and I myself am a UP ki beti, having been born and brought up in the neighboring city of Kanpur. It is befitting, therefore, that Dr. Manoj Jain, the organizing chairperson, Dr. Vinita Agarwal, the organizing secretary, Dr. Ritu Verma, the joint organizing secretary, Dr. Seema Sharma, the HOD of pathology, are organizing the CME during my tenure in the IAPID. After the disruptions caused by the COVID-19 pandemic, over the past 3 years, it feels great to be back to in-person meetings. I'm thankful to the Dean of SGPGI, Dr. S.P.M. Besh, and the Director of SGPGI, Dr. R.K. Dhiman, in absence here, for facilitating this academic opportunity at their institute. I'm obliged to Dr. Amitav Srivastava, USA, who has willingly offered his help in preparing the scientific sessions whenever requested, and to the highly experienced and expert galaxy of speakers from USA, SGPGI, TMH, PGI, Chandigarh, and AIIMS. I'm sure that the stimulating academic program over these 2 days will be a feast and a treat in every which way. Thank you all for coming in person and for being there online for the academic proceedings and making this a huge success. Thank you very much.
Thank you, ma'am. Now I request Dr. Francisco Couto, Vice President IAPID, to say a few words.
Due to the heavy rains, we are not having the director here. He was supposed to be the chief guest. In absentia, Professor Dr. R.K. Dhiman, Director SGPGI, Dr. Anita Baduri, President IAPID, Dr. Rini Malik, Secretary and Treasurer IAPID, Dr. Manoj Jain, Organizing Chairperson, Dr. Vinita Agarwal, the Organizing Secretary, Dr. Seema Sharma, HOD Pathology, SGPGI MS, other dignitaries here, especially all the senior pathologists who are here, who have been felicitated as well, other dignitaries, faculty, both international and national, members of the IAPID, delegates. I'm very happy to be here at Lucknow to attend the 24th annual CME of the International Academy of Pathology, Indian Division, the IAPID, organized by the Department of Pathology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, and being held in hybrid format on 16th and 17th of September 2022. It is indeed wonderful to see so many of you attending it physically after a long hiatus due to the COVID pandemic, beside all the other online delegates. And I'm sure the CME deliberations will be very fruitful to all. As the Vice President of the International Academy of Pathology, the IAP, I convey the greetings of the IAP to the IAP Indian Division and its members, and best wishes for the great success of this program. As you know, the IAP and its Indian Division always holds academic programs of the highest standards, in keeping with the ethos and mandate of the IAP in promoting high-quality pathology education worldwide. Started in 1998 as a new activity with the aim of covering recent advances in pathology and new frontiers in pathology, the IAPID annual CME has become very popular. The theme of this CME, Diagnostic Update and Molecular Advances in Endocrine Organ Lesions, is very interesting, and we have excellent scientific sessions with a renowned national and international faculty exhaustively covering various aspects of this topic and sharing with us their vast knowledge and expertise. And we express our thanks to all of them for this. Our sincere thanks are due to Dr. Manoj Jain, Organizing Chairperson, Dr. Vinita Agarwal, Organizing Secretary, and their team for conducting this CME and for all their hard work and efforts to ensure the success of this meeting, which I'm sure will be a rich learning experience. I wish this annual CME of the IAPID all success. Thank you.
Thank you, sir. Now I invite Dr. Rini Malik, Secretary, IAPID, to briefly address the gathering.
A very good morning to all the dignitaries, all the senior pathologists, Dr. Anita Bhadri, President, IAPID, Dr. Francis Couto, Advisor, IAPID, all my seniors, Dr. Arvind Rajavanshi, Dr. Adotra, Adam Pathak, and of course, Dr. Manoj Jain, the organizing chairperson, Dr. Vinita Agarwal, organizing secretary, Dr. Seema Sharma, head of the department, pathology, and Dr. Kishnani, and all the participants. I feel extremely honored for having been bestowed the responsibility on behalf of IPID to welcome this elite gathering today, who has assembled to attend the annual IPID CME of 2022, organized by the prestigious Sanjay Gandhi Institute of Medical Sciences. And I'm grateful to the organizing chairperson, Dr. Manoj Jain, and Dr. Vinita Agarwal, organizing secretary, who undertook this responsibility and have been striving since months to connect all of us together here. वो कहते हैं ना सोने पे सुहागा, जैसे मैडम ने कहा कि इस गोल्डन सिटी में इतना गोल्डन इंस्टीट्यूट, ग्रैंड इंस्टीट्यूट, और उसके ऊपर आइसिंग ऑन द केक इज this outstanding theme of endocrine pathology, the complexity of which will be unveiled by our eminent and experienced speakers. With immense admiration, I welcome all our speakers, offline as well as online, who will share their knowledge with the participants and guests who took efforts to join this CME, especially those who are offline, both virtually and in person from different places. I'm sure it will be a wonderful experience for all. Once again, on behalf of IPID, I welcome you all. Thank you so much.
Thank you, ma'am. We will now have a break for tea, post which the session will commence in the telemedicine department in the second floor. The tea is organized in the telemedicine department. All the senior persons will be taken by lift or car. The rest may proceed to the adjacent block. Thank you. All the poster presentees, please put up your posters in the first floor of the telemedicine department during the tea time. Poster presentees.
for this, we would request our respected panelists kindly start this interaction centered on this session. Professor Marine Johansson from HCPGIMS, Department of Pathology, Professor Varshan Ma'am from TNMC and Baylor Institute from Mumbai, Dr. Amit Agarwal from the Department of Endocrine Surgery, and Dr. Uma
इसलिए प्रेजेंट कर सकती हूँ.
We request Professor Manoj and the moderator of this session to kindly
प्रॉब्लम हो गया.
start the interaction for this session. Sorry for more Dr. Girish. And Dr. Gaurav.
Let's start. Mic लगाओ.
यहीं से शुरू करें.
आप बोलेंगे ऑडियो जाएगी. So welcome everyone. We are having problem because of rain, but still we are trying to manage. So this after tea session, we are having work. Intraoperative consultation with thyroid and parathyroid lesions. This is very important topic, pertinent topic, because there is always gap between the surgeons and pathologists. What surgeons' expectations are and how much pathologists are communicating. So we just had thought that this will resolve some our discussion and resolve our issues. Like so, in the panelists, we have got a very eminent endocrine surgeon, Dr. Gaurav Agarwal is professor here, professor of endocrine surgery and breast surgery. He is CMS of SCPGI also. His areas of interest: breast surgery, oncoplastic surgery, central lymph node biopsy, minimally invasive endocrine surgery, parathyroid oncogenesis, Pheochromocytoma. Is immediate past president of breast surgery international, convener SCPGI breast cancer awareness. We conducted more than 2,000, around 2,000 awareness sessions, published extensively, more than 220 index publications with high index rate, more than 7,000 citations. In the top 22% most cited scientists in the world, as Stanford University, popular speaker, faculty at global and Indian conference and workshops. He has got to credit numerous awards, donations to his credit. Our second panelist is surgeon is Dr. Gyan Chand. Dr. Gyan Chand, he is also professor of endocrine surgery department. His area of interest are minimal invasive endocrine surgery, thyroid and breast cancer. His achievement: fellowship in robotic thyroid surgery from SNUH, South Korea, 3-time Young Scientist Travel Grant Award by Japan, accredited fellowship MSKCC New York, several national state level orations. So prize winner in the best paper award, Celsicon. So we have got very two eminent endocrine surgeons with us. So he'll be just discussing the issues intraoperative consultations. Among pathologists, we have got Dr. Varsha Mayur Dhume. She's associate professor in the Topiwala National Medical College, BUL Nair Hospital. Her areas of interest: endocrine pathology, head and neck pathology. For last 20 years, she's pursuing this area. She is faculty speaker of CME of adrenal neoplastic lesion at CON 21. Guest speaker on PTC classification. Moderator of CME of PTC. She has got vast experience in the endocrine pathology. Our other panelist is Professor Narendra Krishnani. He's an eminent pathologist, and his areas of interest: histopathology, cytology, GI and hepatic pathology, endocrine pathology. More than 35-year vast experience. She has done extensively work on the parathyroid and thyroid lesions in molecular studies. She has more than 200 publications. So I welcome all the panelists here to discuss. So as we know, methods of intraoperative consultations are frozen section and intraoperative cytology. In intraoperative cytology, we do imprint smears, scrap smear, square smear. So for this thyroid and parathyroid lesion, the section is done. Sometime imprint scrap smear is also prepared with limited scope. So we'll have some pertinent questions from the surgeons. What is the role of frozen section in intraoperative consultation? How does this help to surgeons? And what desired information they want to listen from the pathologist after sending the specimen? These pertinent questions I'd like to ask.
Then time frame for getting information and provisional report. What should be the optimal timeline which will help their further deciding management. Then how it helps intraoperative decision-making, extent of surgery. That's also important because they are based on our reports only. Then utility of cytology and imprint and scrap smear intraoperative consultation. How does this help to the surgeons? So there are some specific issues in thyroid surgery to decide the extent of the surgery. They have got prior FNAC report, which sometimes that can be equivocal. Then radiology thyroid score can be there with them in which suspicion of PTC. These topics has been extensively covered in previous sessions by our Ronald Gesson and Dr. Neha. So their queries, the lesion is benign, malignant, or borderline, just like in 2022 newer classification. Then nodules on thyroid is also there. They can mimic adenoma, nodular hyperplasia, minimally invasive tumor. Then NIFTP and UMP, their newer terms have come. Then variant of PTCs can be there. Then they also want to know extra thyroidal extension, whatever they are sending lymph nodes, whether they are metastatic or not. Either they have fat or some aberrant structure has been taken out. Similarly, in parathyroid surgery, if they do, so that's really a challenge for, I was just reading the literature, it's a really challenge for them to identify parathyroid intraoperatively, especially when minimally invasive surgery has come into role. So what is their experience in this? Surgeons for the parathyroid surgery and their localization. Knowledge of parathyroid physiology, variation in appearance, and orthogonal locations, they are very important for them. So identify parathyroid tissue and differentiate from nodule or thyroid gland, small lymph nodes, aberrant thymic tissue, but that can be grossly mistaken. So they want to listen from us that what the structure we are reporting to them. It is hyperplasia or adenoma. So in your classification, those issues has been addressed. So as pathologists are concerned, as a pathologist, they want from us effective, timely communication, because that is the mainstay of the intraoperative consultation, because that helps early deciding whatever the surgery they want to do. So reducing turnaround time is always a challenge for pathologists as well for surgeon. So there are various logistic issues in this. State of preparedness to receive sample is very important for pathologists. When we are prepared, then only we can effectively communicate. Experience of reporting pathology also matters in reporting. Then performing an intraoperative imprint or smear can expedite turnaround time and useful of compliance of frozen section. There are many technical issues that those surgeons has to be realized that there are many technical issues which we face in laboratory, in just like freezing artifacts, sectioning artifact, float folding of the float folding and staining artifact, the cellular bloating can be there. So frozen section has limited value in assessing capsular invasion. So those points will be taken up. So these just to apprise, these are the recommended as per literature. These are the recommended turnaround time for the intraoperative consultation. So if you see logistic time 10 to 15 minutes for cytology and frozen section, then processing time is more for the frozen section, that can be around 20 minutes. In intraoperative cytology, it will be 5 minutes. In staining time, again, this will be 7 to 10 minutes. Reporting time can be taken as 5 to 10 minutes. So if we see the logistic total turnaround time should be 40 to 55 minutes for the frozen section and for 25 to 40 minutes, half an hour for the cytology. So with this introduction, I'll ask Dr. Gaurav and Dr. Gyan. So what is the role of frozen section in intraoperative consultation? What desired information they want to listen from us, and time frame what they want, and how it helps in their intraoperative decision making. So they can take up for thyroid first, then parathyroid. So over to Dr. Gaurav.
Thank you, Professor Manoj Jain. Firstly, thank you very much for involving us surgeons in this interesting symposium. Well, let me begin by saying that we surgeons, especially when practicing any procedure relating oncology and for hyperfunctional or hyperactive endocrine glands, we are almost entirely dictated by the anatomical pathology of the gland. Unfortunately, much of it is not available, or that information is not available until we have operated the patient and a few days later until that time. So what we base our surgical decisions on is a combination of information or the information derived from a combination of our clinical findings, imaging, and whatever preoperative cytopathology or other pathological assessment we may have. And as a result, often we do not have a firm diagnosis at hand before we operate a patient. And we have to make appropriate decisions during surgery, at times even after surgery. During the surgery, while dealing with a thyroid pathology, we want to know whether the pathological diagnosis, cytopathological diagnosis, which has been offered to us is indeed accurate or is it something else. We try to reduce those occasions to the bare minimum, but still there are occasions when we have an inconclusive or suspicious cytology, and we ask our pathology colleagues to give us a pathological diagnosis based on either intraoperative frozen section histology or whatever form of cytology or combination thereof. But the major role of intraoperative consultation for us is to decide the extent of surgery, more specifically about the extent of lymph node dissection that a patient deserves. It is a standard practice as part of gold standard protocols that we would remove any suspicious lymph nodes from the lateral compartment and even at times from the central compartment, send them for frozen section histology or cytology, and decide on the extent of lymph node dissection on these reports. Why do we need this? Can we not do without it? Well, we certainly cannot do without it because we want to individualize the extent of surgery for individual patients' needs. One simplistic way of thinking could have been, as perhaps has been practiced until some decades ago, was that for any patient with suspicious, where there's a suspicion of a differentiated thyroid cancer or a medullary thyroid cancer, and you have any lymphadenopathy visible, or even without, you may carry out prophylactic or therapeutic lymph node dissection irrespective of the extent of disease in an individual patient. But this one-size-fits-all approach doesn't work. It is neither required in a vast majority because there are no lymph node metastases in quite a few patients. And secondly, it is fraught with, because this is an over-treatment, there is a scope of causing morbidity. And the specific two things that we are afraid of during thyroid surgery, including thyroid cancer surgery, are vocal cord palsy following surgery and hypoparathyroidism. And both of these are linked with the extent of surgery. These are linked with the extent of lymphadenectomy that we have to do in an individual patient. So by and large, if I may put a little simplistically, in a patient where we are dealing with a solitary thyroid nodule, cytology may be papillary carcinoma or highly suspicious of the cancer. We want to know whether there's any metastasis to the lymph nodes. As Dr. Manoj said, if there's a palpable lymph node or a lymph node visible on an ultrasound preoperatively, we would try to aspirate it, do a cytology on it, so that we have a preoperative diagnosis of pathological diagnosis of lymph node metastasis. But often this is not possible. It is not accurate. There is ultrasound guided FNA from a central compartment node has a sensitivity as low as around 30%. And which means a vast majority of such lymph nodes, which either have not been identified on ultrasound, or even when they are identified and aspirated, the cytology may not accurately predict whether they are metastatic or not. There's a fair mix of false positive and false negative. So we have to rely more on the intraoperative histology or cytology rather than only preoperative cytology for deciding whether the patient deserves central compartment lymph node dissection. And as I said earlier, this central compartment dissection is to a large extent is a determinant of the postoperative morbidity in form of vocal cord palsy and hypoparathyroidism. Similarly, lateral neck dissection, which is an additional procedure, which in our experience, no more than about 20% of all papillary thyroid cancer patients require. And this is a much larger chunk or number proportion in our experience compared to say certain Western countries where it would be even lesser, because on an average, the disease stage at diagnosis is earlier. So if we were to have, if we were to adopt a practice of routine prophylactic lateral neck dissection, we would be doing disservice to the patients up to tune of 80%. So that is my take on what is the extent of or what information we need as far as extent of surgery is concerned. So do you want me to go ahead with the rest of the questions, or would it would be more appropriate actually
some input if Dr. Gyan can give on this in thyroid, some input if Dr. Gyan can provide, that will be good.
Thank you very much, Dr. Gyan, for inviting me on this panel discussion. So Dr. Gaurav has already covered most of the things like lateral neck dissection and central neck dissection. But sometimes what happens, like the tendency is benign or suspicious, and we plan for like in solitary thyroid nodule, and we plan for hemithyroidectomy, and we went ahead during the surgery, and we found there is some adhesion, or clinically or as a surgeon we find that there is suspicion of malignancy in this case. So what we like to ask review and send a consultation, take a specimen, mark it and send it to pathology for doing the frozen section and identify whether it is malignant or benign. If it is possible to identify it on the table, whether it is benign or malignant, then we can extend the completion thyroidectomy immediately. Otherwise, patient have to go under contain for the thyroid surgery. So one thing is this, another is situation when we have some medullary thyroid cancer, where the calcitonin itself is a marker for doing the extent of thyroid surgery, but sometimes we require some frozen section biopsy in those scenario also. And third thing is the locally advanced thyroid cancer, where the thyroid is extensively involved into the surrounding structure, whether it is nerve or whether it is a trachea. So we have to know the margins of whether we have taken the adequate margin and margin negative for doing the completion of the surgery. And another thing is that sometimes parathyroid, we have confusion in the parathyroid. Electively, we do the central compartment lymph node dissection and we think whether it is lymph node or parathyroid. So we take a part of parathyroid, send to the frozen section. If it is positive or if it is told by pathologist that this is a parathyroid tissue, then we can do the auto transplantation of the rest of the parathyroid. So these are the scenarios where we require your consultation, and these things are helpful for us. Thank you very much.
Thank you, Dr. Bhatt. So, yeah. Okay.
So, you want me to go ahead with the other questions that you?
I think in thyroid we can discuss more. Dr. Krishnani can highlight how much we are reporting and how does it help. Just like in minimally invasive follicular carcinoma, the report is sufficient for you or not, because hemithyroidectomy already you have done. So we'll go for further surgery or not with that. So how does that help?
As far as frozen section is concerned, I think it is more useful, especially when we give in Bethesda class. So it is only that useful because we don't know whether this, we only say that this is a suspicion. But if we say class 3 and 4, it is not going to help much because the almost accuracy, while if we see accuracy is okay, and chances of malignancy, if we suppose whatever way we say that capsular invasion is there, it is difficult to give the definitive opinion based on frozen section. So in class 3 and 4, I don't think it is much helpful. In class 5, it is helpful, and in class 6, there it is to some extent. We can give the type of malignancy. We can also confirm that margins are free. We can also give the lymph node extension, whether this is there or not. But otherwise, as such, role of cytology in frozen section is not very much, especially in diagnosing the case. So this is the way, because the cytology almost accuracy more than 90%. So what is the rule? So for making diagnosis, I would say no. And for making, for difficult cases, well, sometimes we also mention that interoperative frozen section should be done. So in many reports, we label on cytology. We write it down. So in that case, only this happens. As far as the rest of the things are concerned, sometimes we get, and lymph node, we get parathyroid tissue. So it is important that we should tell them that this is a parathyroid tissue, and so that they can also plan for auto transplantation if it is possible. So in that way, we can help to the. And there are other things which are very difficult. At times, some other tissue comes, and fat tissue, there are many errors like thick section, folding of section, staining. These create a lot of problem, and sometimes it is possible that we may give some false positive. So it is better not to give definitive opinion all the time. So even in papillary carcinoma, it is difficult many times because most of the times actually are less and they are not well formed, and it creates a lot of problem in making diagnosis. And as far as the nuclei are concerned, that this particular variant of papillary carcinoma and others, I don't think that we should attempt much in giving that diagnosis, because in front nuclear clearly, or we can see in many cases, and so it is always difficult, and we should try to avoid in that case.
So experience on solitary thyroid nodule, in which we give just equivocal follicular adenoma or some report. So in your experience, how many cases they are later on converted to be total thyroidectomy? Just for surgeon, this question.
So it so happens that only very recently we have audited our experience of last year, 2021. We have a policy of annual audits, which are usually done in the months of January and February. For some logistic reasons, we could do it only recently. And that's why I can give you some data. In the year 2021, of the patients where we operated based on a Bethesda category 3 cytological diagnosis, close to 20%, 19% to be accurate, they turned out to be malignant. But not all of them had, not all of them required complete thyroidectomy. A small proportion, around 1/4 of all, we performed upfront total thyroidectomy because the patient had a bilateral nodular disease, or there was some strong suspicion for a malignancy based on which we did an upfront total thyroidectomy. And of those patients who underwent any thyroidectomy, about a third of them actually underwent endoscopic any thyroidectomy. Only about a quarter of them have been so far subjected to complete thyroidectomy. And the reason is that quite a few of them are papillary microcarcinomas, low risk, whom we think we can follow them up. And these are low risk patients. Had we known a diagnosis of a papillary carcinoma less than 1 centimeter or even up to 2 centimeters with no high risk features, we probably would have treated them with thyroidectomy or lobectomy alone. So that's the kind of picture that I'm looking at. And then especially one entity that we often get perplexed with, or rather one of the few, is minimally invasive follicular carcinoma, because there is not as much clarity with that regarding the extent of treatment that is required for these patients. And with an NIFTP and certain other newer entities coming in, I mean, it's adding to the complexity, but hopefully some more clarity will emerge. But I'm sure Dr. Gyan can add to this.
Thank you, sir. And regarding this surgical procedures, as Dr. Gaurav said, like how important you can imagine that if you're doing robotic thyroid surgery, heavy thyroidectomy, it's costing around 1.5 lakhs in LTPDA. So if the patient have to go again for completion thyroidectomy, he or she have to spend again same amount of money. So if the frozen section gives some clue, most of the time that surgeon suspecting that there is some intraoperative adhesion, because sometimes there is delay, especially in the COVID period, we have seen that gap between the FNAC and the date of surgery. And also we have some logistic, due to logistic issue, we have dates around waiting period of around 2 to 3 months. So between the FNAC and the surgery. So sometimes maybe the reports what we have received from the cytology and during the surgery. So we suspect that there may be chances of malignancy. So if we send for further section biopsy and we find some positive results or positive conclusion that this is benign or this is malignant. So in that case, we can save the money for the patients. And same for endoscopic thyroid surgery is costing around 40 to 50,000. So all these things, they are psychologically and financial trauma we can save by just giving a further section report. So those things are helpful. And second thing, what we find that in other center, what we have seen in MSKCC also, that this frozen section is taken seriously by the pathologists. So they have the senior most pathologist or senior who is interested in the thyroid pathology. They usually give the reports of frozen section biopsy directly, especially if the fax images are available. They send the fax image and they are saying that these are the findings are present. And on the basis of this finding, this is the report we are sending to you. So those things are important for us. And second thing is if you put this frozen section facility near close to the operation theater, that is also going to help to us. Thank you very much.
Now, I like to ask to Dr. Varsa, what technical issues and artificial changes which limits our reporting and communication to surgeons?
I think everybody will agree with me that frozen in thyroid is not an easy job. I mean, as it is, thyroid is such a small gland and coming with very small number of tumors. But let me tell you, for last 20 years, I'm practicing it and it's a difficult job to every case, whether to put a label, it's a task. And you have to go meticulously, and frozen in thyroid is definitely problematic because what are we doing it for? Because papillary, yes, 90% of the cases, if they're sampled well on sonography, ultra-guided FNC, you will get the diagnosis. But then those 10% which you will miss will really trouble you. And then medullary also, calcitonin will help you. When frozen section in thyroid, first of all, sampling. Because when it comes to papillary tumors, if you are suspecting one, then the nuclear features are not there to help you at all. But a small, what I can say, addition to this is what we practice in our center, and I think most of us do in our labs, is interoperative cytology. In the frozen section sample, before we give the sections, we take either straight, imprint, and that gives a little air to pick up the nuclear features. That is one thing. Second is follicular regions, if you look at, then the problem is you have to pray to the God. If at all there is an invasion, it should fall in those 5-6 sections which I'm taking. Because there is a limitation. It will totally depend on your center to center, how many number of chucks you have and how many sections you can give. Third thing, as Sir said, that the freezing artifact will definitely hamper. And if time permits, I have few photographs for you all to show how the things go better here and there. Then another thing which I agree with you, lymph node problem is there, definitely. And we do receive a lot of lymph node for frozen section for analyzing whether the papillary or medullary also is there or not. But the nuclear features which normally help you are the one which caused you the problem in frozen. So that is one thing. And then if your site pathologist is not giving you answer in immediate 15-20 minutes like any other organ, then you should know that the poor fellow is struggling with the capsule and taking more and more sections, and should help him out with that. I mean, be patient with him, rather, I would say. So that's it. So then, as far as parathyroid, we discussed.
Now, the question to Dr. Gaurav. For parathyroid, minimally invasive surgery is now being done. So one side parathyroid you give us. So, and we always report look for other parathyroid to set hyperplasia or adenoma. So what is your experience? But IPTS level helps you, or you wait for our report for another gland? What you do?
I'll come to this, but if I may be allowed, when we call the pathology reporting room during surgery, the intention is to find if the pathologist is there or not. Once we are assured the pathologist is at the job, then we don't call again. So this is just to All right. Well, as far as parathyroid surgery is concerned, once again, we surgeons are slaves of anatomical pathology. The gold standard for diagnosing a parathyroid pathology is peripheral section histology, and not just of that lesion that we remove, a comparison with at least one more normal looking parathyroid. But for the last 2.5 decades or so, we do not have the luxury of sampling more than one parathyroid. We do, as far as possible, minimally invasive or focused parathyroidectomy. And how do we choose patient for this is based on, firstly, the clinical context. If there's a patient with a familial, possible familial, and one for sure we will not do a focused or minimally invasive parathyroidectomy. Based on our clinical evaluation and the imaging, I'm sure our pathologists are so well versed with this, our pathology colleagues. They are equal stakeholders in this meeting, so they are well aware that we do a set of imaging, one anatomical, one functional imaging. Certainly parathyroid scintigraphy, for example, there is functional imaging and a high resolution focused ultrasound at the very minimum. And based on the combination of the information derived from all these, and also added to it, our own expectation from an individual patient, we decide whether the patient is a candidate for focused parathyroidectomy, minimally invasive, or whether we should do bilateral neck exploration, which even today continues to be the gold standard theoretical procedure for primary hyperparathyroidism. And I'm restricting this discussion to primary alone right now, because secondary and tertiary are different discussions altogether. So during the surgery, what we expect from our pathology colleagues is to tell us whether this is indeed a parathyroid and not something else to begin with. And if you can tell us whether it's a hypercellular parathyroid lesion or a normal parathyroid, that will be as much as I expect from intraoperative consultation with the pathologist. I don't expect the diagnosis of parathyroid adenoma versus hyperplasia to be made on closed section histology or cytology, and certainly not the diagnosis of parathyroid carcinoma to be made. Well, we do suspect, or rather over-suspect, our threshold for considering parathyroid carcinoma as a diagnosis during surgery is rather low. And I wouldn't shy away by saying that at times we are proven wrong later on. But in the best interest of the patient, it's better that we overtreat such a situation rather than leave the patient uncured. So, but that was just a sidebar. But the important thing is that during surgery, based on the preoperative imaging, we find an enlarged parathyroid gland in the location which has been provided based on the imaging, and indeed that fits into the criteria of adenoma. It's a globular, maroon colored, at least, if not, and it's a firm globular kind of lesion. We excise it, send it for frozen for the reason I told you. Almost always we couple it with intraoperative PTH estimation. Now, intraoperative PTH estimation or monitoring is indeed helpful only in such cases where there's a failure. If it is confirming cure, it just gives you some extra cushion, extra confidence in your own procedure. But there is about 5% false positive rate. So even when we have cured the patient, there was only one parathyroid lesion, the PTH may not drop to curative limits. And if we were to entirely depend on the intraoperative PTH, we would over-explore the patient. We would convert from a focused unilateral approach to a bilateral exploration. But this is, based on the data that we have close to about 700, 800 patients of 700 to 800 patients of primary hyperparathyroidism accumulated now. Close to 60% of them are focused or minimally invasive parathyroidectomies. And only rarely we have had a problem. The failure rate is certainly less than 5%. And it's not to say that all these failures are because of lack of our identification of pathology. A small proportion is because of misdiagnosis, where we considered them to be primary, but they turned out to be tertiary. Unfortunately, that number is minuscule. And failure to identify multi-gland disease during surgery, which I don't think pathologists or the pathology colleagues can help unless we provide them more than one parathyroid.
System maybe helps in those cases.
Well, sensitivity again has a sensitivity of close to 80%, and it has a fair proportion of false positives too. There would be patients where there are multiple enlarged glands, only one or one of them is more hyperfunctional compared to the rest. And this is the common scenario of failure. We remove that, the most dominant gland, and few months later or a year later, the rest of the hyperfunctioning glands, they kick in. And then
how much importance you give weight of the parathyroid?
Immense.
That's a very important.
So weight of the parathyroid, unfortunately or unfortunately, is the only guide available on gross examination to determine whether it's a pathological gland or normal gland. Dr. Goran Ekstrom, the one who did the seminary studies to provide us with the nomograms of parathyroid glands, he is a surgeon, an eminent one from Uppsala, Sweden. And he dissected a obscene number of cadavers, studied their parathyroid sizes and weights. He's visited us. Many of us are close friends of his, and we visited his center. Even if in his own version, this is not a foolproof thing, but that's as close to perfect information as we get. So we do attach a lot of importance to size and weight, but maybe one comment here that can be made is that the weight of the gland that we should take or we should consider is the weight of the gland alone, and not the weight of the periparathyroidal fat, which is almost always there.
Thank you, Dr. Gaurav. So I think we are reaching to time, close to time. So quickly we can take one or two questions because time.
Some anecdotal tests has been described in the literature. Any experience with that?
It's an intraoperative.
Yeah. So pathological parathyroid gland, that's not really very helpful as far as distinguishing normal from pathological glands is concerned. Often we have to discern between a fat lobule and a parathyroid, and we do this density test either in just saline or in mannitol. If the lesion floats in a saline bath, we know it's a fat lobule. If it sinks, we know it's a parathyroid gland. Mannitol test has been tried, but I don't think it's a very foolproof test.
I haven't seen my surgeon doing it, but I thought.
Thank you, Dr. Gaurav. So quickly, I can take one question. So Dr. Andras wants something else.
So,
yeah.
Interesting analysis data there, Dr. Gaurav. I was just wondering if you analyze that for cases where you had a high resolution ultrasound and you had a prior FMA diagnosis, in how many cases did the frozen section actually help you? Because there is a lot of controversy on literature, and we know as pathologists that once that specimen is disturbed and with all the artifacts that are there in frozen section, how accurately, especially in terms of follicular lesion, can we really comment? And when that capsule is destroyed and those sections are out of our repertoire of routine reporting, then are we missing those microinvasive carcinomas because we have eliminated that particular tissue which went into frozen, though we do reprocess that tissue, but we are still losing some part of it. So what is the general opinion of the house here on whether frozen sections should altogether be abandoned in thyroid? I mean, that's really a controversy there, and there are several articles in literature which suggest that. So,
may I respond? Yeah, please, sorry, please.
As far as I am concerned, at PGH Chandigarh, we have minimal chronal sections of the thyroid. We don't get any chronal sections. There used to be Dr. Bose who retired 10, 15 years back. They used to try. I told him, why are you sending this chronal section of thyroid? I can't give you an answer. He said it is just for your practice. Just for your practice. So as far as parathyroid is concerned, I think yes, chronal section is required, but because we need to confirm whether it is a parathyroid or sometimes it is lymph node, small lymph node and all those things. But I have more important comment to make, and that is, I think when Manoj was presenting the turnaround time and all, I think personally I would believe the turnaround time which Manoj was told is a little higher than what it should be. But however, rightly said, 15-20 minutes is more than enough. The reason I'm telling how to do it. Because these days we all have mobile phones. And whenever an intraoperative chronal section comes, tell your residents to write the mobile number of the resident or the clinician. And when I report a chronal section, I make it a point that I immediately phone the surgeon. Okay, this is this. So I think because our, as you said, the chronal section should be close to the theater, so which unfortunately we don't have. But I cover it with that thing that I immediately phone the where is it, kya hai, kitna bada hai, kahan hai, not only in thyroid but otherwise also location kya hai. So I think that would be very, very helpful, that rapport between the two and using mobile phones, and also that if possible then SDPJ has a very good system of our person is रास्ते में आके वीडियो दिखेगा, 15 मिनट सवाल लग जाते हैं, then somebody looking for क्यों कहाँ गया, pathologist कहाँ है, technician कहाँ है, so it has to be an elective process. That is why I think elective, as it has to be prefixed. And in UK actually, if you don't give the report to the surgeon, it is not accepted. If you do this accreditation and all, people do see that when you are passing on the report, if the report from a pathologist is not given to the consultant surgeon, it is not valid. So I think those kind of things should be done here, and it is not difficult to do. And I think
Thank you. I think we can close the session. So because we are time is already
Just only
10 minutes.
1 second. As far as my personal view is, frozen section in thyroid should be as less as it could be. First off, because most of the time cytology is the most accurate way of diagnosing this thyroid. As far as parathyroid is concerned, what I would say nowadays with the advent of interoperative parathyroid hormone assay, I don't think there is much need of even doing frozen section in parathyroids. So as far as whenever there is a problem, only one should go for parathyroid as well as thyroid frozen sections. And the second, as far as the timing is concerned, I'm a strong proponent of having a frozen section suit nearby to the operation theater, which I was trying long back, but I couldn't. But this is thing which we have to do it, and we should do it. And it should be routinely reported everywhere nearby to the operation theater complex. And the final report should be immediately given there. That is what I do.
So there are logistic issues. Those points have been discussed various times. There are many logistics, duplication of resources. So there are many issues. So those centers of center that can vary and opinion can vary. So a technician, pathologist, everything. So I think we'll close the session because yeah. Okay, no, we are time limiting. Yes. So because the endless discussion, we can go with this way. So I'll thank all our distinguished panelists, Dr. Gaurav, Dr. Gyan, Dr. Krishani, Dr. Varsa, for enlightening us with this, and all the delegates and participants for presentation. Thank you all.
Sir, system है. It's a bit of time, but at times. So, over to Mayo Clinic में St. Mary's Hospital.
Thank you all the
Lloyd.
for this interactive and interactive
See the specimen themselves
sharing of experience and deep
for
knowledge.
more than 5 minutes.
For moderate with discussion.
From all over the country and from other countries.
Specific to all the offline and online participants, kindly post your queries for which the answer is moving for the next area, which is entitled as Precursor Lesion of Thyroid Neoplasm by Professor Uma Nahar ma'am.
I think privileged to welcome our honorable chairperson, Professor Seema Sharma ma'am. She is the head of Department of Pathology at PGI. Professor Yusuf ma'am. She is the head of Department of RML
And Professor Madhumati Goyal ma'am, she is head and director of lab medicine at Parathyroid. She will join us online. I think Professor Sharma ma'am to speaker of this session.
Please, आप इधर आइए.
नहीं. Because people say it here.
मेरा मोबाइल.
And
Now I introduce next speaker, Dr. Uma Nahar Setia, who is Professor, Department of Histopathology, PGI Chandigarh. Her area of interest are dermatopathology, endocrine pathology, and cardiovascular pathology. She has received a number of awards and achievements like Torrent Research Award, Fogarty and ICMAR fellowships, Healthy Mind Better Award, Fellow of International Medical Sciences, Academic Studentship, Member of National Academy of Medical Sciences. I invite the online adjustment.
We have Dr. Madhumati Goyal who has joined online. Yeah.
Welcome, Dr. Uma Nair. Welcome to Lucknow.
I saw you in the morning, I guess. No? Okay. Maybe mistaken for someone else. Well, after the difficult area of frozen sections in thyroid and parathyroid, another difficult area is precursor lesions of thyroid. When Dr. Vinita called me, he says, nobody is there to take up this topic, I'm giving it to you. I said, of all the people, why me? So anyways, I'll try to do justice to the topic, though I'm not going to go in the intricacy of it because it's easier said than done. As we have just talked about the frozen sections, easier said than done, and everybody has highlighted the importance of doing or not doing the frozen sections either in thyroid or in parathyroid. So not wasting much time, I won't be keeping you long between your lunch and this talk, so I would be brief. Since morning, we've been listening to WHO updates by Dr. Hussain, we heard from Dr. Neha about the grossing of thyroid, and my job has been made easier by Dr. Hussain about talking about some precursor lesions, NIFTP and all that. PowerPoint. So partly you have all been briefed. My job is to just elaborate on the entities which have been a little bit mentioned. बैक की फीलिंग ही नहीं आ रही है.
That's true.
उसको वहाँ पे ड्रा कर सकते हैं. Wait. Go back. Session 3. No. Go back. It was there. Session 2 minutes. 2 minutes. तो खोलो. ये this is it. Because technical glitches. जल्दी में हमेशा देर होती है.
आपको डेस्कटॉप पे कॉपी कर लेना चाहिए। ये तो डेस्कटॉप पे है। It's here. है नाम आपने नहीं लिखा। नहीं ये तो सीडी है। So let me ask the residents who are sitting at the back. So what do you understand by the precursor lesions of thyroid? I'm not going to do a monologue. I just want it to be a little bit interactive. So what do you understand by precursor lesions of thyroid? How many of you are aware of these entities? Anybody who can name these lesions? Anybody? The final years, the senior residents? Anybody? Nobody wants to say anything. Okay. Now you have listened to this classification in the morning, so I'm going to only touch upon the ones which are highlighted in the red, because the rest have been a little bit dealt with and told about, and you have a recent WHO classification, the article is already there, you can go through that. Now, why do we need to know about borderline and precursor lesions of thyroid? So where is the missing link? Now, if we see that this is the follicular cell and you have a parafollicular cell, so these are the driver mutations, that is the RAS and the BRAF. However, each lesion which happens in thyroid does not go through neoplastic transcription. Why so? The clonality has been proven. Even then, the lesion may not progress to the neoplasm, either benign or malignant. Now, this is what happens with the epigenetic or genetic mutations further after the driver mutations. There is some mumbling in the room. If I request everybody to be a little quiet. Sir, may I request you to be? Thank you. So if you see, this is a schematic view. If you see the follicular cells, you have this driver mutations, and even if you have RAS, PPR, PAX8 and PPR gamma mutations, it may not transform to the follicular adenoma or carcinoma. So you have to have certain epigenetic and genetic mutations further to make it a neoplasm. For medullary carcinomas or parafollicular cells, it is relatively easy. So there has to be a sequential events and multiple steps carcinogenesis happening. There would be corresponding genetic and epigenetic alterations within the normal follicular cells or even in benign proliferative lesions, which may include benign follicular adenoma, which may give rise to further well-differentiated carcinoma, poorly differentiated or undifferentiated carcinoma. So how do you classify the precursor lesions of the thyroid? Broad categories, like you would say, if broadly we say that genetic alteration in the morphologically normal looking thyroid, you can have. Chronic inflammation and autoimmune Hashimoto's thyroid is a very important precursor lesion which can predispose the patient either to the capillary carcinoma or even non-Hodgkin's lymphoma. The solid cell nests which are seen sometimes, especially in the hyperplastic nodules, they could be possible stem cells in the thyroid gland and may give rise to neoplasms later. Certain benign neoplastic or non-neoplastic nodular lesions in the thyroid, along with hyperplastic adenomatous nodules, goiter, and dyshomogenetic goiter. We hardly see specimens of the dyshomogenetic goiter. However, we are lucky to, I'll share an example of one of them. And then last but not the least is the encapsulated variant. Now it says it's encapsulated, though it qualifies for the well-differentiated thyroid carcinoma. I find this one the most difficult. Now, the WHO classification has introduced these terms, thyroid follicular nodular disease and follicular adenoma with papillary architecture. Before that, we know that follicular adenoma existed, and the Hurther cell adenoma has been replaced by oncocytic adenomas. These also qualify for the precursor lesions of the thyroid because they also have a clonality. Now, let me show you an example. Now, this is a thyroid. In the morning, you learned about the grossing of the thyroid. So, in the same manner, if you see sequential sections of the thyroid specimen, you can see multiple nodules. If you see. Clinically, this would have been probably called it as multinodular goiter, or maybe hyperplastic nodules, or maybe neoplasms. And you have so-called this creamy architecture or cream-colored nodules, which are not really well encapsulated. And if you see the microscopy, you can see these hyperplastic areas not having a defined capsule, but there's a lot of lymphocytic infiltrate around. Another picture showing the same. So what do you want to call it as? You want to label it as just multinodular goiter, which is a clinical diagnosis, should not be used in these times, or you want to call it as follicular nodular disease, or you want to just label it as a follicular adenoma. For follicular adenoma, the capsule has to be there. Even in the new WHO,
the capsule has to be there. I think I'm enough. Am I audible to all?
Yes.
So if we have to call, so this one represents an example of colloid nodule, and these are all the examples of hyperplastic nodules, and this one is the adenomatous nodule with the thick capsule, which was not present all around. Now let's see what is this FND. So it's a multifocal non-inflammatory benign proliferation of follicular cells, which we used to call it as hyperplastic nodule previously in a case of multinodular goiter. There could be multiple clonal or non-clonal nodules within this FND. That's why it's important to recognize this entity. And MNG is a clinical term, and we should discard this term. The pathologist should not use this term in the bottom line. And follicular cell proliferations which lack invasive growth or nuclear features of PTC should be labeled as thyroid follicular nodule disease. If you see the gross examination, so this was a hemithyroidectomy specimen. You see there's a large nodule and you have multiple colloid filled cysts also. So it has variegated appearance, both gross and microscopically. Though there are certain variations in the acceptable terms, which could be either nodular follicular disease or follicular nodular disease. One can even call it as an adenomatous nodule, which again falls into the gray zone. Now, why it has to be classified separately? Because there is a clonality associated with it. So the thyroglobulin or TPO or sodium iodide importer NIS or dual oxidase and TSHR mutations have been shown in this. Though the prognosis in these patients is very good, 100% free survival from the disease after the resection. However, some reports also say that MNG can be inherited as autosomal dominant pattern. And there are certain variants described to this in familial goiter, right? So that's why the importance of labeling this as FND is there. And benign follicular nodules, this FND will neither recur or metastasize after complete excision. Now, this is one of the examples of case which was resected completely. It was a total thyroidectomy specimen, and it came to us as a clinical diagnosis of multinodular goiter. Now, what we see here is a totally encapsulated lesion. The capsule has some calcification, and you have a predominantly microfollicular pattern. However, in the same tumor, in the same section, we had another nodule which did not show any capsule. Rather, you can see there are two nodules. So there was no capsule at all. Again, you have a microfollicular pattern. So what would you like to call these two as? So the first one, anybody? Is it an adenoma or is it a FND? And the second one. So it's a tricky situation. That's why it's important. Let me show you the higher magnification. So if you see, sorry about the photo quality because I took it from the scanner slide. So you have predominantly microfollicular pattern, no capsular invasion, but no nuclear features of papillary thyroid carcinoma also. So your NIFTP is out, right? But if you see these nodules, again, these are incomplete nodules, no capsule. So this qualifies for FND. So this is a follicular nodular disease. Now let's go to the next entity, that is follicular thyroid adenoma with papillary architecture. Now these are benign, non-invasive, encapsulated follicular cell neoplasms, and they have an intrafollicular papillary architecture. And again, they will lack the nuclear features of PTC. And they're often associated with autonomous hyperfunction of the thyroid gland. And they have been shown to have TSH mutations in around 70% of the cases. A very small subset have also shown GNAS mutations and have been associated with McCune-Albright syndrome. So for these entities, one can even use the acceptable terms like follicular thyroid adenoma. But again, you have to demonstrate a thick capsule or a thin capsule all around the lesion, or a hyperfunctioning thyroid adenoma. Sometimes you may call it as toxic thyroid adenoma. Now let's see the picture. What does it show? It shows multiple papillary projections. Again, it was a case of multinodular goiter, and it showed these kind of areas with scalloping or colloid, lot of papillary projections, but these are not true papillary. There is no fibrovascular core seen in this. So this was just a follicular nodular disease with papillary architecture. So most of you must have encountered these areas. So single layer of cells, some papillary projections here and there. And someone will say this might be a Sanderson poster, but it's not a Sanderson poster because it has a micropapillary projection. So micropapillae has been given a lot of importance in these lesions. Now let me share this case. This was a 27-year-old male. Fortunately or unfortunately, fortunately for us, because we got to examine the thyroid in detail, unfortunately this patient did not survive, and this was sectioned at autopsy. So if you see this thyroid, multiple section, it weighed around 70 grams. It was very rubbery in consistency. And the cut surface shows you multiple nodular areas. None of them is well defined or capsulated. So gross appearance, you probably would think, am I dealing with a neoplasm or am I just dealing with a follicular nodular disease or a follicular adenoma with papillary architecture? Now, this is what the microscopy showed. The entire thyroid showed uniform morphology. There was no capsule in any of the lesions, and you had this diffuse micropapillary projection. No fibrovascular core was seen, and there was no nuclear features to suggest PTC. So now what do we call it as? Do we leave it as just papillary hyperplasia, or we call it as a follicular nodular disease, or we call it as a follicular nodular disease with papillary hyperplasia? So everybody in the department had different opinions. And finally, if you further see on a high magnification, there is some scalloping of the nuclei, so some hobnailling, sorry, but there is no nuclear features to suggest PTC. So this was finally labeled as diffuse papillary hyperplasia, which was a case of dysorganogenic goiter secondary to Graves' disease. And the patient died, of course, with cardiac arrhythmia, not because of this. Now, what are the main differential diagnoses in such tumors? So either the Sanderson posters in follicular nodular disease, or sometimes you may have diffuse papillary projection in a case of MND. So you just leave it as a FND with papillary hyperplasia. Now let me share this case. The most common talked about entity since morning, and everybody talks about this, that is NIFTP, a favorite of many. So what you see here is there's a well encapsulated lesion. No capsular invasion should be there for NIFTP. And if you see closely, microfollicular pattern and the nuclear character of the cells would be showing you PTC-like feature. That is optically clear nuclei. You may even have overcrowding, which is not very common. However, optically nuclei can be seen. So diagnosis of NIFTP is only possible when you have taken multiple sections and rule out capsular invasion and you demonstrate the nuclear features of PTC. And they have also been associated with RAS-like molecular alteration in around 52% cases, and minor solid growth pattern is allowed in around less than 30% of the tumor area. The new WHO has again revised. There were a criteria which was given. Now this is another case which you see that this case was made as an encapsulated variant of PTC by my residents. And when I saw this entire tumor, I regrossed it, multiple sections were taken. It did not show any evidence of invasion. There was no papillae anywhere. So it was called as, again, NIFTP. Now, why it is important? This slide has been shared by Shipra. She's sitting right in the audience. Thank you, Shipra. Now, again, if you see, the capsule is not very well formed, but you can see focally you have a thick capsule, again, microfollicular pattern, and you see the nuclear characters. So nuclear characters are very, very important. And when you talk about nuclear characters, you have to do a nuclear score. So 1, 2, 3, that is the Turing's score, and you do it by a visual scale, though there will be a lot of subjective errors, but broadly you can say there is no overlapping or enlargement of nuclei in the first one. In the second one, you can say irregular contours or maybe grooves or sometimes inclusions. And the third one, you know that all the characters of PTC nuclei will be seen. So yeah, so this is a score 1 case. The score 2, where you have nuclear enlargement, some overlapping and optically clear nuclei. And score 3, you have all the features of PTC. So why is it important to classify these lesions? Because these tumors behave very well after complete excision. This is one another case which had more of this eosinophilic cytoplasm rather than having these nuclear features, very thick capsule and the surrounding thyroid parenchyma. And high magnification again shows this kind of oncocytic morphology, which previously was called as Hurthle cell adenoma, which has been dropped by the new WHO. And the high magnification again highlights the oncocytic nature. Now it's been called as oncocytic adenoma. You may encounter occasional mitosis. Mind it, less than 3 mitosis per square millimeter is allowed in this adenoma. So this is now relabeled as oncocytic adenoma rather than Hurthle cell adenoma. This is yet another case which was misdiagnosed as PTC by my own colleagues, and then patient had done hemithyroidectomy initially, and the clinician went ahead and did a total thyroidectomy. I happened to see the second set of slides, and this is what it showed. It had a capsulated lesions, some microfollicular pattern, and focally you have papillae. Now, less than 1% papillae are allowed in NIFTP again. There was a revision of criteria from the original allowed to not allowed, and again allowed by the new WHO. You see, nicely nuclear crowding and nuclear features of PTC could be seen in this case. So it was re-signed as NIFTP. So what are the diagnostic criteria of you heard Dr. Gosain in the morning. I don't have to, I'll just re-emphasize the fact that mostly follicular pattern, which could be micro, normo, or sometimes macro. True papillae should not be seen, but less than 1% is allowed. No samoma bodies, no capsular invasion, and only less than 30% of the area should show solid trabecular or insular growth pattern. And nuclear features of the PTC should be either 2 or 3, not 1. And no tumor necrosis, and as a mitosis is allowed less than 3 per millimeters. If you can do BRAF or MVES mutation or IHC for that, that is a desirable criteria. So this was the criteria which I was talking about, the what is allowed and what is not allowed in NIFTP. So originally it was this, so papillae were allowed. However, in revision criteria, it was not allowed, and again it is allowed. So this is the algorithm of NIFTP. So if you see an encapsulated well-demarcated lesion, there is no capsular lymphovascular invasion. Solid areas less than 30%, mitosis less than 3. It goes in, and with nuclear features of PTC, it goes in favor of NIFTP. However, if it has infiltrative pattern or it has solid areas more than 30%, mitosis a little more, it will not go in favor of NIFTP. Then it will go for encapsulated variant of follicular variant of parathyroid PTC, right? Now, the other variants which are involved, which are described with NIFTP, subcentimeter NIFTP, that is also described in the oncocytic NIFTP. Now, why they have been described is that they have also been found to be, though they have a low prevalence, but there is no BRAF mutations associated with these tumors. But if you see a morphological variation, you just need to mention to the surgeon. And in these patients, only lobectomy is sufficient. No radioiodine therapy is required further. This is yet another case which was given to me by Shipra. Now, here, if you see, one may say this is capsular invasion or no capsular invasion. I also would be having a doubt. Now, these are the cases when you say that it is of uncertain malignant potential, or you may sign out as NIFTP with a guarded note for the surgeon that this patient needs close follow-up. So, I find these two categories the most difficult. I've only diagnosed only few cases of follicular tumor of uncertain malignant potential, and I'm yet to diagnose one of this category. So if you see the criteria, in all of them, you can have these mutations. And invasion is absent in adenoma, but is questionable in the WTV or FTUNP. And again, the BRAF B600 mutations is absent in all. So it's a difficult situation. We are still standing at the gray zone area or a border zone area from where the enemy can fire from anywhere. So we have to be careful. If we are not sure of the invasion, you put a good note for the surgeons. Yeah, so this is all about the encapsulated follicular pattern tumor. So you can have, as I said, microfollicular pattern, mixed pattern, or a macrofollicular pattern, but look for the nuclear features. That's the hallmark of any of these precursor lesions, especially for the NIFTP. Right now, what would you call? Although the diagnosis is already written. Now here also, you feel that there is a capsular invasion, but it's not going into the capsule way beyond it. There is a microfollicular pattern. This is not a true capsular invasion. This is just an outpouching. So this again would be going for NIFTP only. So other follicular pattern tumors also should be known when you're diagnosing a follicular pattern tumors, although usually you will not make a mistake, because if you find samoma bodies, if you find papillae, or if you find positivity for BRAF, you probably would go for a diagnosis of PTC. Sometimes intrathyroidal parathyroidomas can be a problem, but that usually is seen in follicular pattern tumors in around 30% of the cases, where you see clear cell morphology, but then parathyroid IHC helps us. So we've repeatedly talked about this. So how do you diagnose NIFTP and how do you put your diagnosis at WT? I actually personally don't like putting the lesions in this category, because it's a very dubious situation both for the pathologist as well as for the treating surgeon or physician. So if at all you are in a situation like this, just put a clear-cut note to the surgeon that this is what needs to be done. These patients need close follow-up. Now, let me share some of the examples of tumors of solid mess. So if you see this, these are the solid mess of cells, some microfollicular pattern. And if you see this, they are expressing P63. We never used to do P63 in these tumors. So that represents that they are from the basal region. And they are also expressing TTF1. So indeed, they are occurring in the thyroid. They are thyroid stem cell. They are also expressing P63. The other variant is hyalinizing trabecular tumor, which is also classified in the borderline category again. But the very interesting finding is this hyaline material, which stains positive for collagen 4. And interestingly, the MEB1 staining is membranous rather than nucleus in hyalinizing trabecular tumor. Though the pattern will not mislead you anywhere, but sometimes you may be not having a good section, or maybe the this area is very focal. So you have to have at least more than 50% of the area showing this morphology to diagnose this lesion. What is the utility of IHC? Actually, I feel single IHC, no use. So you have to have a panel of IHC, maybe at least 3 to 4 combination of antibodies to help you differentiate between sometimes malignant versus benign or precursor lesions of the thyroid, which mainly includes HPME, Galectin-3, CK19, IMP3 or CITB3. So you have to remember this table by heart if you are doing a panel of IHCs. Now we don't do all of them. We are only doing top 3 along with the thyroglobulin stain. So that most of the times it solves the puzzle, but sometimes you may not be in a situation to do so. So again, you have to be careful in reporting such cases. Now let's come to the C-cell hypoplasia. Now that closes the chapter with the follicular cells precursor lesion. C-cell hypoplasia is again tricky one, usually associated with Grange syndrome and often present in multiple foci. So if the patient is not clinically symptomatic or the thyroid is not significantly enlarged, probably you will not see these cases unless and until a prophylactic thyroidectomy has been performed for Grange syndrome. And the criteria for that is you have to have more than 50 cells per 100 naturally of variably dysplastic morphology. So they can be cell alterations. Most of the times the resident would tell me that the C cells would be lying outside the thyroid follicle. No, it has to be within the basement membrane, right? So you have to know where the C cells are located. In a given case, you may not be able to identify the C cells in a given situation. Like supposing that you see this section, this picture, you probably will just pass it off as a thyroid follicle and you will not notice these cells in a normal situation. But if you see something like this, there is a C cell hypoplasia happening. And this is a cluster of C cells. So this usually is associated with Grange syndrome. So you have to be carefully examined it. If you're not sure and you're doubtful what it is, you do a calcitonin stain. Now, again, a cluster. Now, you have to thoroughly sample the thyroidectomy specimen to rule out a medullary carcinoma in these patients. Most of the times, it is associated with medullary carcinoma. If you see here, you have small clusters of C cells all around, and that can be only demonstrated by IHC. Now, this, I share these two pictures, and then I go back to the original one. Now, see this case. This was contributed by Shipra. This was a 28-year-old male who had an ill-defined neck swelling for a long duration. He had history of palpitations, and there were cervical lymph nodes also which were enlarged. In addition, he had marfanoid habitus, multiple nodules, though the history gives away the diagnosis. But what do you see? You see that there's some microfollicular pattern, but it is not. So you have to pay attention to the nuclear character, which is different. Now let me show you this picture. What do you feel about this? Since these are scanned pictures, so I think little bit of blurring is there. So what do you feel about this picture? Again, you have this kind of microfollicular pattern, but then again, you focus on the nuclear character. So there is optically clear nucleus, some overlapping. So this is a papillary microcarcinoma. Papillary microcarcinoma is again classified under the borderline category now because there's a 100% survival and people don't know how they're going to evolve. However, if they are associated with lymph node metastasis, a total thyroidectomy has to be performed. And this was a case of C-cell hypoplasia with men. Now, what is this? What does it look like to everyone? Blue tumor of thyroid. Is it like that? So I think I'm just left with 1 or 2 slides. So it looks like a blue tumor. Everyone says yes. But you have some square structures in between, right? The diffuse sheet. The history of TPO positivity came later after and this was removed as a goitrous lesion. The clinician did not know about the lesion. Unfortunately, FNAC was not performed earlier. Had it been performed, it would have changed the diagnosis. And these are the iron magnifications. So you see there is a follicle here, which is infiltrated by the lymphoid cells, both in the wall, and almost complete destruction of the follicle is happening. And the cells are not very high grade. Usually it is DLBCL, which will involve the thyroid secondarily. However, these cells are not very higher looking of DLB cells. So they have a monotonous cell population. Some of them do show angulation, causing lymphoepithelial-like lesions. So this was reported as myeloma. I couldn't trace the slides of IHC to show you the IHC photograph. And this patient had autoimmune history of autoimmune thyroiditis earlier. And after a long-standing thing, she had a goitrous enlargement, which was removed, and there was positivity for TPO, which was very high. So to summarize, you need to identify precursor lesions of the thyroid to reduce the overdiagnosis and overtreatment of thyroid nodules. Because as Dr. Krishnani said, or I don't know, some of the panelists said that the surgical cost involves around 1.5 lakhs. So the patient has to repay. If you're doing a surgery one time and you have a diagnosis which favors malignancy, probably patient has to undergo surgery again. So the logistics have to be worked out. Since it's a multi-step carcinogenic process, one has to take care of that demonstration of any of these driver mutations, that is ZPTC, PAX8 or PPR gamma variants, and even RAS mutation. They are only initiation steps. The further progression of events will only happen after genetic and epigenetic alterations, which may give rise to either benign or malignant tumors. And it's very important to know these lesions for the clinical management, thereby reducing the surgical resections and even mutation-positive thyroid nodules, especially in the borderline category. Thank you for your time and patience for hearing me out. I also take this opportunity to tell you that we are organizing the 25th BSI meeting in November. Please join us in November. GINO at Chandigarh.
Offline, online?
It's offline, but we have kept the option of hybrid also. Yeah, it's offline mainly.
It was a very informative session, and thank you for clearing our concept regarding the follicular lesions and NIFTP.
That was an excellent talk, Dr. Uma.
Thank you so much. Any questions? Although it's not
in
easy.
fact, this is one area where the pathologists need to know much more than the malignancy. Malignancy is very evident actually. So this is the major area of problems for pathology. So it was an excellent and well explained talk. Thank you so much.
Thank you.
Do we have time to ask one or two questions? If anybody can ask something.
Someone there from there. Yeah, please. Yes.
But is there any recommendation for minimum number we should embed before ruling out any invasion? It's not possible anytime to embed the entire thyroid.
See, in the morning you heard Dr. Neha re-emphasizing this fact again and again, that totally embedding of the thyroid, especially when you're in doubt about the invasion. So you have to embed it totally, especially the areas which includes the capsule. She clearly showed that pictorial photograph with crescent shaped sections, right? So you take sections from the capsular area if you're not wanting to embed the whole thyroid. So sample the entire capsular areas, including the center, and then because it is the center where most of the times you will see the papillae. So that's the importance. And depending on the size of the lesion, you have to sample, but capsule has to be embedded in total.
Entire capsule.
Yes.
Irrespective of the size.
Yes, irrespective of the size. Otherwise, you would be misdiagnosing these cases.
I think it depends on you. If you want to make a right diagnosis, you have to do it. आपकी मर्जी के दोस्त को ही आपने diagnosis देने हैं तो whatever. But I think it is important what Uma has said. That you should sample maximum capsule and validate the tumor. Let's say you should and usually these are not very large ones.
Yeah.
So about the papillary microcarcinoma you said. So another was the medullary hyperplasia.
Yeah.
Can't we say it medullary microcarcinoma? Yeah. How can we differentiate from hyperplasia to microcarcinoma to carcinoma? So that is the question, because the same size was there.
This is what the story is now, that the sequence of hyperplasia to adenomatous nodule to benign adenoma to carcinoma, something like which happens in GIT. So, but though they also show clonality, but they may not be neoplastic. So in due course of time, they may become neoplastic, they may not become neoplastic. So it's difficult. That's why microcarcinoma also has been debatable now, especially in the new WHO. But if it is associated lymph node metastasis, it's malignant.
I think that was the discussion in the morning
Yes.
also, that medullary carcinomas actually coming to the, so
Yes.
they would have like a grading like NETs where you have a hyperplasia.
Now we have a
G1
proper
and
grading also for
and a
that.
G3.
Yes. Yeah.
Probably they will get into that in the next classification.
Yes. And that is
So
why
the coverage of the entire topic. I would also like to add here for the purpose of the residents and all who are here, that when you have like an osteoparathyroidism, that is again, you could say in a way a precursor lesion, because you have to really look for the papillary carcinoma there, and any patient who has a history of radiation.
Yeah.
Again, even a normal thyroid with radiation history comes into the category of a precursor.
yes.
Thank you. Thank you very much.
Thank you so much.
Thank you, ma'am. Thank you, Honorable Chairperson. Now, the one announcement, we had Professor
Promotion.
the Department of Pathology is Delhi. So, hi, everybody. Ma'am, very user talk. Somebody asked about capsules. What we do in Delhi is we process some sections of the capsule. If they show invasion, well and good. Otherwise, we process an entire thing. So we do it as a two-step process in case it's a large nodule. So that's what you can
follow. We have a two-step process. Like first, if we respect on morphology, then we embed the entire capsule. But that too, there is something for the first step. Is there any recommendation of the society that we should at least embed 5 6?
No, there is no such recommendation.
No. For yourself.
By the criteria, everything has to be embedded. But as Dr. Shipra is highlighting, two-step process. And usually it happens like that. Because you see the tumor and you feel, no, it is not this. You go back to the gross and you take more additional. But that wastes little time. So I always say, if you are not sure it's a bigger lesion, please sample the entire capsule. And you can put the capsule 3 sections in one block. You can always do that. So usually these are less than 3 centimeters or whatever. Not more than that.
Multiple wedges. Yeah. You can put 3 or 4 in one capsule.
One block.
Multiple thin wedges can be put. I just had a small announcement. So I have a talk tomorrow on diagnostic pitfalls in thyroid cytology. It's going to be a case-based discussion. So I have numerous cases. I'd like to have some resident volunteers to discuss the cases for me, so that it can become more interactive. So anybody, any of the residents who's interested can give your names, Shalini, or anybody who will be organizing. Thank you.
I wanted one comment on what will be the impact of all this happening in the thyroid histopathology or follicular pattern lesions. You know, on our cytopathologists are always have to undergo this. I would say the Atypical now and then they keep calculating our sensitivity, specificity, diagnostic accuracy, and so on and so forth. And we all know that you have highlighted some of them are so challenging. What somebody will call as FPTC tomorrow, somebody else will go and call it as NIFTP, based on how extensively you sampled the experience of the pathologist. And this is really true that even it's not just in one center. I'm sure it is. Everybody has this problem.
Yes.
So I really want to know just your comment on that. How would it impact, these kind of sensitivity calculations of cytology, number one, and what is the general experience here of the prevalence of NIFTP in our population? Like in the morning, we heard the Western data is somewhere around 9 to 10% of all PTCs would be NIFTP. What would be in our have good studies being done in India at all, or we still have to look into it?
I think me and Dr. Shipra, we are having a collaborative project on artificial intelligence on these lesions only. So we're yet to compile the data. However, I think I'm audible enough.
Yeah.
So we are yet to compile the data, but recently there's been a surge of diagnosis of NIFTP because probably the sensitivity towards it has increased. So as I said many times, the residents would just bring it as it's a papillary carcinoma, but it is not. You go back to the ground, you take more sections, you see the more slides, and then you call it as a NIFTP. The sensitivity has increased, so the incidence will also increase. We haven't analyzed our data as of now, but so I don't know the exact figure.
But the finding with the pathologist always goes.
Yeah.
Otherwise, other things will follicular.
It's a debatable area again.
I think follicular test like BRAF and HLSK errors
is helpful here. So you have to do these things, and that is another way of dividing the two. You have to be that. That is what is actually advised also.
I think that there are a lot of questions there, but we have to stop it here right now because of lack of time. So thank you, Dr. Uma.
Thank you so much. Thank you for having me here.
Thank you.
Thank you so much for the chairperson and Professor Uma.
That's all for this section. Now we request everyone to join for lunch at the Interoperative department ground floor. And post the session will be held on 2:15 p.m. at between telemedicine auditorium ground floor.
No, yes.
And please get your selfie, your selfie for the documentary. Thank you.
We have to similar at ground floor.
Yes.
Ground floor auditorium.
So now we have resumed and we have resumed now our all sessions will be downstairs in our auditorium, proper auditorium. And everyone is complimentary, mug is there with selfie, the point is there. So everyone get printed their mugs and can take. No.
kindly unmute your mic for the upcoming session. CV को इसी को बस management and I have to look up for this professionally. We continue to among the circle the relevant and delegates are completed because of the unique short circle. नहीं वो अनम्यूट
that's one one yeah.
यहाँ पे क्या है दो नाम का प्रेजेंटेशन हाँ हाँ ये ओके करें ठीक है इसको चलते रहने देंगे ये खोल देंगे इसको नीचे कर दे तुमने वो बनाई थी ना कोई स्लाइड we'll start the session in 2 minutes at 2:30 sharp. Welcome back everyone at Telemedicine Auditorium for 24th IAP CME here at SGPGI. It will be a panel discussion on role of molecular test in thyroid neoplasm. And we are highly obliged to invite our panelists to moderate this discussion. Professor Neeraj Kumari ma'am, she is head of pathology department and dean of AIIMS Library, and Professor Gaurav Agarwal sir from Department of Endocrine Surgery. Professor Neeraj Rastogi sir from the Department of Radiation Oncology, SGPGI, and Associate Professor Nipul Kani from Tata Memorial Hospital, Mumbai. Associate Professor Dr. Alok Gupta, Head of Hemato-Oncology Department, Medanta, Lucknow. And Dr. Siddharth Srivastava sir, non-molecular biologist. I request Professor Neeraj Kumari ma'am to kindly introduce our moderator, Professor Vinita Agarwal ma'am. Thank you, everybody. I request all the panelists to kindly come on the stage. I am Dr. Vinita Agarwal. I am professor in the Department of Pathology, and I will be moderating this session. I thank all the panelists. So we have with us panelists of surgeons, molecular biologists, pathologists, and specialists in molecular techniques. So we have with us Dr. Gaurav Agarwal, Dr. Nupur Karnik, Dr. Neeraj Kumari, Dr. Siddharth Srivastava, Dr. Alok Gupta from Vedanta, he's a medical oncologist, and Dr. Neeraj Rastogi, who is a radiation oncologist. So as we know, over the years, for the past 20 years, there have been so many advancements in molecular technology, and it has touched every one of the medical fraternity's life. And now the knowledge is accumulating over the years. But with the coming of the next generation sequencing, there is a mass explosion of the knowledge which is there, leading to reclassification of many entities. And therefore, we stand today here to talk about this very important aspect of thyroid neoplasms. So what I'll do in the next 30 minutes, we'll talk about these 4 main topics. That is, what is the role of molecular testing in thyroid neoplasms? When we deal with differentiated thyroid lesions with a follicular or a papillary pattern, poorly differentiated and anaplastic thyroid carcinomas, medullary thyroid carcinoma, what is the strategy of testing? And then we'll take up questions from the audience. So we go one by one, and now we come, so when we talk of differentiated thyroid lesions, basically we have one pattern is a papillary and the follicular pattern. These are the most common patterns. So if we see the PTC is a BRAF-driven malignancy and follicular tumors are the RAS-driven tumors. So there is a wide divide between these 2 types of entities, and therefore the molecular classification is coming in. So the question that the first we request the panelists to answer is, what are the situations of the lesions in differentiated thyroid lesions, be it papillary or follicular pattern, where molecular testing is indicated? So I'll request Dr. Neeraj Kumari, who is a professor and head at the Department of Pathology at All India Institute of Medical Sciences, Raebareli, to present her view.
I think the role of molecular testing is mostly in the cytopathology specimens in thyroid, mostly in the lesions which are Bethesda class 3 to 5, because there we cannot distinguish whether it's a malignant or benign. So there it has a role of diagnosis. Once we come to histopathology, we have the tumor there is a role of in the management. The role is in the management. So mostly class 3, 4, and 5, there we can have molecular testing.
Okay. So Dr. Nupur Karnik, what is your view on Dr. Nupur Karnik is from PMH Mumbai, and
I think ma'am has nicely summarized the indications for molecular testing in thyroid. I would just like to add that in some patients, after the histopath diagnosis, if the patient presents with a progressive disease, sometimes in our case, we do get requisitions for NGS in which a wide panel of genes like BRAF, RAS, RET are tested, just to look for any possible therapeutic options for the patient.
So in your scenario, what do you think is the most common indication when it comes for a BRAF or a RAS testing when they're asking to you to do? Once post-operative and the pre-operative scenario.
So usually, commonly we get acquisitions for anaplastic thyroid carcinomas, and followed by either progressive follicular carcinomas or progressive papillary carcinomas.
Okay. So we have Dr. Siddharth Srivastava, who is from IIT Jodhpur, and he has extensive experience over molecular pathology. He has joined online. And Dr. Siddharth Srivastava, can you hear us and can you give your comments on your experience? He established the Newmark Institute of Genomics at Ahmedabad. Dr. Siddharth, please.
Yeah, I can hear you. I wonder if you can hear me. Can you hear me, ma'am?
Yes, we can hear you. You can be a little louder, please.
Okay. So yeah, as Dr. Neeraj Kumari as well as Dr. Nupur has suggested. I think for any differentiated thyroid carcinoma, BRAF testing would be a must because of both therapeutic indication for the patient as well as for prognosis. So, and also one more thing I would like to add here is the, if possible, mutation analysis of TERT promoter, because TERT promoter mutation along with BRAF, the progression-free survival is even poorer. So that's the only thing I would like to add to this.
Okay, so do you ask for TERT promoter mutation in all differentiated tumors, or there is a group of tumors in which you will ask for it?
Actually, to be very honest, in the first go itself, if you know, if it's a already differentiated thyroid carcinoma, and the question is, you know, what we can do for as far as the prognosis and therapy goes, then definitely TERT should come into picture for prognosis.
Okay, thank you. So now we move on from the pathologist and the molecular biologist to the clinicians. We have with us Dr. Gaurav Agarwal. You have already been introduced to him. He is from the Department of Endocrine and Breast Surgery at SGPGIMS and has a vast experience. So for, in your view, Dr. Gaurav, what are the situations when you have prognostically or management-wise where you think you will require some molecular testing for a patient in management?
Well, I concur with whatever has been said. As far as diagnosis is concerned, I mean, things have been covered, but we also, today we are practicing in an era when we are transitioning from clinical and anatomical based decision making to molecular based decision making. There are a subset of all our patients where we are not certain, based on the conventional biomarkers available to us, whether the patient is going to have a low risk or an intermediate or high risk disease. And there, the role of these molecular markers does come in. So I agree with what has been talked about follicular carcinoma. And patients with especially follicular variant papillary carcinoma, not just for diagnostic discernation, but also for assigning prognostic classification to that individual patient, these markers can be useful. We do not use them as often in our clinical practice today as we would like to, because of the obvious reasons of inavailability and cost. But eventually, I suspect over the next few years, just as we are now doing for so many other conditions. I mean, I'll take an example of medullary carcinoma within this whole group, where entirely our management is today dictated by a combination of RET mutation results as well as the calcitonin and CEA levels. And then almost never we manage a patient with medullary carcinoma without this set of information. But in coming years, hopefully, for every patient with differentiated thyroid cancer, or at least for a majority, we would include BRAF and RAS for sure, maybe TERT promoters as well, before we arrive at a firm treatment plan for them.
Comment. Like as far as treatment and prognosis is concerned, BRAF, V600E and TERT, they are more important because the tumors which are positive for them, they have more of lymph nodal invasion, invasiveness, bilaterality and metastasis. That is more common in LEN. And BRAF, we have therapy. So as far as therapy and management is concerned, these 2-3 markers like P53, RAS, BRAF, they are more important.
I'll request Dr. Alok Gupta to kindly present his view on this very important area.
So, a few points have been made regarding the prognostic implication of these markers. Just to add, BRAF is supposedly a poor prognostic marker, as has been commented here. With regards to the therapeutic implications, I would say testing for these markers have become an integral component of the management, especially in the radioiodine resistant setting.
Yes.
Or the radioiodine refractory tumors. It has become a very much integral component, and these tests are very much routinely available with us in our clinical practice. Now, most of these patients in the radioiodine refractory setting would be carrying some form of molecular abnormality. In many situations, this molecular abnormality can be targeted. But even if these markers cannot be assessed, there are multi-kinase inhibitors which will be acting on multiple pathways. So if we talk about differentiated thyroid cancer, we know that within the papillary subgroup, there would be activation of the MAP kinase pathway and the genes involved in MAP kinase pathway. And now we have multiple molecules which can target specific abnormalities within those pathways. Similarly, for follicular, we know that RAS is driving and the PI3K-AKT mTOR pathway is activated, and there are molecules which act on those specific things. Just to highlight that these molecules are very much there in the clinical practice now. An example is lenvatinib, which came in way back in 2015, around 7 years back. It was a very large phase 3 trial which demonstrated improvement in survival outcomes compared to supportive care. And before that, it was sorafenib. So these are multi-kinase inhibitors, and inherently these molecules inhibit multiple aspects. So for example, RET is inhibited by most of these. Then there is PDGFR, then there is VEGF. So these multi-kinase inhibitors are acting on those multiple molecular aspects which has been shown in the diagram.
Yes. So there are now actionable mutations which are coming up, and so that is becoming more and more important. So Dr. Neeraj Rastogi, as a clinician who sees these patients day in and day out, as a radiation oncologist, there has been talked about the radioactive iodine also. What is your view on this topic?
I think radioactive iodine after the surgery is the important aspect in the management of thyroid cancer. But those patients who are not radioactive avid patients. So in those patients, one can use the external beam radiation therapy to the tumor as well as to the lymph node. But as Dr. Alok has already told that nowadays in metastatic setting, even in recurrent settings, these patients require a lot of actionable mutations which we can manage, especially RED mutations, BRAF mutations, and MSI, as well as DNA MMR. And these are the few mutations which we have to look for when these patients present with the either metastatic disease or recurrent disease. Then we don't have any options available. So according to these mutations, we have a lot of drugs. Where Dr. Alok has told that nivatinib and sorafenib, and third drug is the cabozantinib. These 3 drugs can be given, but along with the other drugs, like the BRAF mutation, like dabrafenib and other drugs, which is depending on the mutations, that should also be, we have an option for these patients.
Thank you, Dr. Neeraj. So to summarize, we can say that it is now more and more mutation analysis and molecular testing is required, not only for diagnosis, sometimes in indeterminate lesions, but also as a prognostic factor, as has been elucidated, and also because now there are management strategies which are in place so that you can help those patients and give a personalized therapy. That is the new era that is there. So Dr. Krishnani, I think, wants to make a comment.
I think that first BRAF and other things like RAS and the third promoters should be first applied in the cytology specimen, first of all, because this makes us to decide what way we have to proceed. So this is to be done in routine practice. I think it should be done, and we have done it here also. And the rest of the things where it is refractory, as Dr. Alok said, that in that scenario we have to use NTRK and this mTOR inhibitors. There are many other where the immunotherapy is available. We should apply that thing in our day-to-day practice in that condition. So for that, I think nowadays panel is available, and we can do it in routinely, apart from medullary carcinoma and others.
Thank you. Dr. Radhika, you want to make a point?
Yes, thank you very much. And just to continue what Dr. Krishnani has said, that yes, we talk of prognosis and predictive markers, but that's still an emerging area. Whereas the research has matured as far as diagnostic testing, molecular testing in thyroid lesions, or even there it is, we can see that it is still evolving to a large extent, but we know at least about the major mutations. But it's not just restricted to mutations. Number one, about the RAS-RAF that we already talked, we have a whole developing upcoming field of microRNA testing. We have gene expression classifiers, the thyroid affirma, and all of these have been done on the FNA samples. So that is very, very important. And we've been talking the whole morning about indeterminate thyroid nodules, right, and the role of frozen section and et cetera, where the surgeon has to decide on the operative management and the extent, the type of surgery and the extent of surgery is determined by, so we have to improve the diagnostic accuracy of FNAC in the, particularly in the category 3 and to an extent in category 4 and Bethesda category 5 lesions. I will be covering that up in my
we looking forward to that.
But I just thought the audience today who may not be there tomorrow should know that it's a whole range of molecular testing that is to be done. And simply, if you simply take BRAF alone, it's only seen in about 40 to 50% of the PTCs. So alone, it is not even sensitive. It's not good enough just to have a standalone molecular test. So we should understand, while we know the, while we're talking of the big things that are happening in this field, we should also be very well aware of the limitations of these tests.
Thank you, Dr. Radhika. So now we got to the aspect we want to differentiate
one more point.
Carcinoma. It has already been elucidated that there are high-grade variants. We had a talk in the morning by Dr. Ronald Gosen, and we now know that there are a group of tumors that is a high-grade PTCs and the poorly differentiated thyroid carcinomas and aplastic thyroid carcinomas, which show a third promoter mutation. And it is important to elucidate whether these are high-grade PTCs or poorly differentiated thyroid carcinomas. So according to the RAS or the BRAF mutations. So I'll ask Dr. Nipun Karnik first. What do you think is the recommendations at present for these group of tumors, basically in diagnosis and maybe in prognosis and typing?
For these tumors, BRAF V600D testing is a must. So in these cases, we usually receive a call from the medical oncologist right when they are raising a requisition that please expedite the report. Because BRAF and MEK inhibitor combination is approved for use in such patients, and such patients are critically ill most of the time. So that is one indication. And BRAF and TERT is obviously a poor prognostic factor in poorly differentiated thyroid carcinomas. And from a diagnostic point of view, when the histopathology is something like that of a pure squamous carcinoma, when we are not sure of a thyroid origin, maybe BRAF V600D may help us in classifying that under an anaplastic thyroid carcinoma. However, now it is under the squamous carcinoma is a part of anaplastic thyroid carcinoma, but when we have a diagnostic dilemma, we may use a molecular test.
Thank you, Dr. Nupur. So what is the routine sample that you get in these patients? You doing it on an FNEC or you asking for a biopsy?
No, we do it on the tissue.
That is a biopsy?
Yeah.
Okay, thank you. So Dr. Siddharth Srivastava is online. So what is your experience in these group of tumors?
Sorry to interrupt. She said biopsy.
Actually, if it is poorly differentiated or anaplastic thyroid carcinoma, then in my opinion, on the...
Just a minute, Dr. Siddharth, Dr. Radhika has a point to make. Just a minute. Yes, ma'am.
Question was, when you said biopsy, were you using fresh tissue? That's a core biopsy. Or was it
FFP sections?
No, FFP sections, because our protocols are validated for FFP sections.
Okay, Dr. Siddharth, you may continue.
Yeah, so, if it is already diagnosed as poorly differentiated or anaplastic thyroid carcinoma, then in my opinion, all bets are off, because we are looking at maybe 6 months or around 3.5 years of time. So typically one should use a large panel, which should definitely include BRAF, and it should definitely include RET, and apart from RET, it should also include NTRK. So RET and NTRK gives some handle to the medical oncologist of sulfatinib or entrectinib, those kind of drugs, if the patient can afford. So definitely a larger panel, and along with that, maybe we should also go with MSI or DMMR test so that the immunotherapy option also opens up. So if it is anaplastic or poorly differentiated, all these a larger panel will always be very helpful. Now, one extra point that I wanted to add based on the previous discussion was that the genomic test can easily be done on FNA samples. So we have actually done that. We used to take FNA samples in RNA later solutions, and it used to give beautiful results. So we don't have to always stick to the tissues. But as far as the differentiated, poorly differentiated anaplastic, large panels.
Yes, thank you. So Dr. Neeraj, would you like to add on this point as a pathologist?
Yeah, in poorly differentiated and anaplastic tumors, as far as diagnosis is concerned, if it is an FNA sample, most of the times it is obvious, or we have, as Madam said, we have large panels. We have like panels which can rule in and rule out. For example, we have Thyroseq version 3, which can rule out because it has a high positive predictive value. Whereas we have a FERNA gene expression panel, which can rule in, which has a high negative this thing. But as far as diagnosis is not a problem in these tumors. Mainly, we have to decide on prognosis and management. For those, I think the TERT, BRAF and RAS, they are more important because there we already have the diagnosis. We just need to decide the prognosis and the management. For example, even BRAF V600E is mostly seen in the invasive and the classical papillaries, whereas in NIFTP and all, we have different BRAF mutation. That's K600E. So even the different types of mutations also matter.
Thank you, Dr. Neeraj. So now we move on to the clinicians. Yes, ma'am, please.
I just wanted to add, I don't know how many of you are aware that there is one published study of these looking at the 5 gene enterogen real-time PCR kit. It's simple. It's only looking at the KRAS, HRAS, NRAS, and of course at BRAF V600D. So there are 2 in KRAS, so that's why it's a 5 gene assay. We did it on FNACs. On direct samples, and many times we have simply scraped the smear, and that is very useful. So you know, sometimes at the time of doing FNAC, you can't take a sample for molecular test every time because you don't know what it's going to turn out to be, but you could have protocols. But what we found very useful was scraping, cell scrapes.
Okay.
You scrape the smear and you extract DNA, even RNA can be extracted from that. And all the tests, including NGS, can be run not just on a direct FNA sample. That is wonderful if you can collect it at the time of FNA and RNA later. But if you didn't, your source is also the smears, which are an excellent source of both DNA and RNA, and you'll get excellent results, provided it's within a year or so. We haven't done it in very stored archival smears, but at least up to 1.5 years, we have had no problems in getting good quality DNA and RNA from them. Thank you.
Thank you. Can I go to Dr. Alok to give his comments?
We did from enterogen. It has that all the RAS, NRAS, SRAS, as well as BRAF. We did it on FNA smears only by scraping, and we had a good results with that.
We published that in Journal of Cytology. Somehow, people don't want to quote Indian studies, but I thought I should bring it to the notice of the audience that there is a published study.
Thank you. Dr. Alok, what is your experience on anaplastic and poorly differentiated, and how do you go about it?
I mean, everyone who has treated these disorders would agree that these are very difficult to treat, and no matter what is the underlying molecular abnormality we detect, most of these patients would ultimately progress and die of their disease. Patients who carry BRAF mutation, definitely there are oral medicines which are available, dabrafenib, trametinib combination, which has actually all these molecular research has reached thyroid malignancy at least 5 to 10 years later compared to other diseases, I would say. So all these molecular markers as well as the targeted therapy first came in melanoma, then in RCC, hepatocellular, and then gradually into thyroid fora. So these are difficult to treat. If you are able to find out a molecular abnormality, treat that molecular abnormality. Otherwise, it's mostly palliation. If it's a localized large volume infiltrative disease, then maybe Dr. Neeraj can administer radiation to that part to provide palliation. Else we can use multi-kinase inhibitor for some form of palliation. Chemotherapy doesn't provide significant responses even in this disease.
Thank you. So Dr. Gaurav, Dr. Neeraj Rastogi, would you like to comment on this?
I think this poorly differentiated anaplastic carcinoma is very difficult to treat these patients. Even the surgeon is unable to remove the complete disease as well. So these are the patients which are usually actionable mutations are not frequently seen in these patients. So these are the patients which require either radiation therapy or some type of chemotherapy. As Dr. Alok has already told, they don't respond very well with the chemotherapy. But some of the agents of the chemotherapy like paclitaxel and the doxorubicin, and they work on these patients and along with the external beam radiation therapy. Because these patients have a lot of compression effect on the esophagus and the trachea. So radiation therapy can relieve these symptoms of these patients and can do the growth stunning. So these are the patient can be relieved, but already because they have a very poor prognosis. And so we have to give these in palliative setting most of the time and very short life expectancy of these patients.
Thank you. Dr. Gaurav, what is your experience as a surgeon?
Well, I agree with the views provided so far, but I would like to draw attention of everyone to the few facts which are overlooked often. Poorly differentiated and anaplastic thyroid cancers, one may call them orphan diseases. Not many people want to treat them. When we talk of thyroid cancer, we immediately either think of a curable, imminently curable disease like a small PTC or a universally fatal anaplastic carcinoma. Often we forget there's a lot in between. And within this space of anaplastic and poorly differentiated, there are, though not so very frequently, patients who are treatable, who are not beyond treatment. As Dr. Alok and Dr. Neeraj said, that vast majority of anaplastic, when they come to us, we just have to talk about palliation and symptom control to the extent it is possible. But there is a small subset of patients who are treatable, and any center with a reasonable collection of thyroid cancer patients, we all have anecdotal patients who had anaplastic carcinoma and have been living for decades. Well, often we are asked whether you made a mistake or if this was a misdiagnosed case, but there are certain cases where we are absolutely certain of the diagnosis of anaplastic, but the very fact that these patients were picked up rather early and they had intratumoral anaplastic carcinoma, intrathyroidal anaplastic carcinoma, and they could be operated with a curative intent. Not always it is possible, but when this is possible, even from the viewpoint of palliation, a thyroidectomy is the best palliation available for anaplastic carcinoma. No amount of drugs and radiation would give you that kind of lasting palliation, symptom palliation. So we cannot, point I'm trying to make is that let's not write off any patient merely because there's a cytological diagnosis of anaplastic, and certainly not for poorly differentiated. As we have also published ourselves, there are poorly differentiated areas within well-differentiated cancers, and they behave quite similar to well-differentiated thyroid cancers. And then there you have really poorly differentiated cancers. And even within anaplastic carcinoma, we have to make a distinction of a de novo anaplastic versus a long-standing thyroid cancer turning into anaplastic. Again, depending on what step or at what stage of their progression we have caught them, if it is possible to treat them with a curative intent, that's the best possible option.
Thank you, Dr. Gaurav. Now we another important area, that is a medullary thyroid carcinoma. This is a tumor where mutation analysis has been done for quite some time now, more so because many of the cases are familial, and so they are picked up. And red point mutations are the one which are the most common. So, in short, we'll just drive upon the topic by first the clinicians and then I will come to the pathologist. So Dr. Gaurav, in your experience, because we diagnose a lot of medullary carcinomas, both familial and sporadic at our place in our center, when do you ask these patients to get a molecular testing done? Because this is usually a FNAC diagnosis that you get from the Department of Pathology.
Yeah, well, medullary carcinoma thyroid diagnosis almost universally attracts or requires molecular testing. I mean, this may not be, I mean, so far we have talked about molecular testing on thyroid aspirates or on tissues, but first step is germline mutation testing for RET.
Right.
In these cases, we do not want to miss a patient with MEN2, and specifically, we do not want to miss the diagnosis of a pheochromocytoma, possible pheochromocytoma in these patients and families. So this is one group of patients where some sort of molecular testing is required universally and as early as possible. And it's not in certain other conditions, we can wait until the primary treatment is over. Here, we want to know about this information right at the very onset and at the very beginning so that we can make appropriate treatment decisions. If the patient has a germline mutation for RET, then of course our treatment plan is entirely different compared to a sporadic. Even in the sporadic, seemingly sporadic medullary carcinomas, again, we published that a few years ago. There's about 40% RET mutation positivity. I'm talking of somatic mutation positivity. And there is a correlation with outcomes. RET mutation positive cancers have fared poorly as compared to those which did not have RET mutations. And so it is preferable to know about the somatic mutation status too, but germline for sure.
Thank you, Dr. Gaurav. So Dr. Alok Gupta, would you like to add something on what Dr. Gaurav already said?
So generally, these patients come to us in advanced stages if they progress and they have metastatic disease or widespread disease, inoperable disease. As far as the treatment is concerned, if the RET is mutated, there are selective RET inhibitors which we do not have currently in our practice. Like selpercatinib, it's not available. But then there are other molecules like cabozantinib, which are also inhibitors of RET in addition to other kinases. Then lenvatinib also inhibits RET. So these molecules can be tried in advanced stages. Cabozantinib, we have a phase 3 data in medullary thyroid cancer where the response rates were around 30-35%. So, yeah, with regards to the advanced staging, that is.
Okay, that is an important point which you have made. And Dr. Neeraj, what is your take on medullary thyroid carcinomas when you look at them and they come to your clinic?
Just I want to add that along with the red fusion gene, which is being studied in these, one important is the tumor mutation burden. If tumor mutation burden in these patients is high, more than 10 per megabase, then one should use the PD-L1 inhibitor, like the pembrolizumab, which has come recently, that can be used in these medullary carcinoma, which TMB is high. So we have, so there is still some options are available based on the actionable mutations.
Thank you, Dr. Neeraj. Dr. Siddharth Srivastava, what is your experience apart from the RET mutations that are routinely done now in medullary thyroid carcinomas? Do you have anything which you like to add in MTC?
I think the only other thing would be, definitely getting the genetic counselor into the picture to identify men or also familial adenomatous polyposis that can also result in this, and Cowden syndrome, which is caused by a germline mutation in PTEN. So a genetic counselor will take enough time to get the family history and all kinds of cancers that have happened to different members to then again report to the medical oncologist and it can move ahead. But as my earlier speaker suggested, that it is very important that apart from RET, immunotherapy option is explored, and I think doing a TMB, which is again a genomic test, or maybe an MSI, both may tell whether pembrolizumab might be applicable or not.
Okay, Thank you. So in metastatic disease, they have an important role to play, right? So Dr. Neeraj, would you like to add on this group of tumors?
Nothing much, as Dr. Gaurav has already said that this is one tumor where we don't need a selection criteria. Once we have the diagnosis of medullary carcinoma, we have to do molecular testing for it because it has an impact on familial screening, as well as we have different kinds of mutations which have high risk, low risk, as well as intermediate risk. So we need to classify those tumors in different risks, as well as for familial screening, we have to do mutation testing.
Thank you. Dr. Nupur, what is your experience in TMH on the MTCs?
I agree with the discussion so far. And just the presence of RET mutation is not important. The type of the RET variant detected is important. So some variants like the one at the 814 position at the tyrosine kinase domain, that is a classifier of poor prognosis, even in sporadic medullary thyroid carcinoma. So the variants are important.
Thank you. Thank you. So now we move on to the most important topic, which is perplexing for not only for the pathologist, but for everyone, for the clinician. So what is the strategy of testing? I'm not delving too much on biopsies and FNACs because that will be taken up by Dr. Radhika tomorrow. I don't want to take that space. So what is the strategy of testing? What tests will you like to do in these? So we have a panel, as Dr. Neeraj pointed out, we have targeted panels. She talked about thyrosequencing. So we have other modalities. You have commercial panels. I have not named them here. You also now have a lot of microRNA panels. NGS is something which is all around. So now my question to the pathologist is, so what is your basically strategy for testing, sampling, and basically the technique? Of course, it depends upon the mutation that you want to look for, the group of tumors that you're looking for, but what is the general take on these tumors? So Dr. Nupur, and your experience at TMH.
For thyroid tumors, the type of test actually depends on how much the patient can afford. Because most of the larger panels are very costly. So in some cases, it might exceed the cost of the surgery. So, in ideal cases, a smaller panel which includes BRAF, RAS, TERT, that should be the first choice of molecular testing. And if we have to look for additional therapeutic options, maybe a larger NGS panel could be done.
Okay, so for these three mutations, what will be your what will be the test that you would like to do? You would like to do targeted sequencing, or will you like to go for
BRAF Sanger sequencing is the gold standard. Right. You could also do a real-time PCR, and now even the BRAF V600E IHC has been validated. So that is also a very good screening test. And similarly for RAS, we could use a real-time PCR or a Sanger sequencing, and third, Sanger sequencing is better.
Okay, thank you. Dr. Siddharth Srivastava, you have been working in the institute. So what is your experience? So for most of the samples, what are the tests that you receive in those days?
Yeah, so in the sampling domain, very important that if the tissue sample is taken, that it is fixed in 10% buffered formalin for the stipulated amount of time that is recommended, around 24 hours. And overexposing or acidic formalin or non-buffered formalin, all of these things are going to really damage the molecular test that will happen downstream. It is very advisable that the lab should also try to devise protocols where they can take FNAs and could do these tests. That will be so. As far as sampling goes, these are the two things that I would suggest. And as far as technique goes, if it's a very simple question that it is differentiated thyroid carcinoma, I want to do, I want to know whether the prognosis and testing, how should it, which way I should go. So then you are looking only for BRAF V600 and maybe TERT mutation. And that can be done by different methods. But let's say if it is an advanced thyroid carcinoma, tumor, and not responding to RAI, etc., then you have to go to a larger panel where you will add, apart from BRAF, you may be adding RET as well as NTRK, and other mutations, which will give more handles to the medical oncologist to try more treatment. The problem here, the cost is not too much about the testing. If you throw in everything along with immunotherapy, you can still wrap it up somewhere around 30 to 35,000. It's more of the accessibility of the therapy and the cost of the therapy. I think the testing is possible, and it is happening also across India. It's not very unusual now.
Thank you. Thank you, Dr. Siddharth. Dr. Neeraj, would you like to talk about the sampling and the techniques that we do for these?
As far as sampling is concerned, I think the FNA sample is the best because there you have to make a diagnosis whether it's malignant or not. So the FNA samples, they also don't have that disadvantage of the formalin fixation. Regarding the technique, and in the FNA, you can even have stain slides as well. We have tried from MTG stains. We have also tried from HNE stains, and our results have been good on those smears. As far as technique is concerned, there are multiple techniques, as already discussed here, like Sanger sequencing and all. But I would, in my experience, I think the real-time PCR, it has a very high sensitivity. We can multiplex the probes, and as discussed earlier, we have like 5 gene probes, HRAS, NRAS, KRAS, as well as BRAF and all. It's combined, and so we can use small amount of DNA, small amount of nucleic acid, and we can do that. So real-time PCR is the best, and it's highly sensitive. The testing and the technique also depends on how rich the institute is and how your patients are affordable. If the patients can afford, if we have the infrastructure, we can also go for NGS-based testing. Otherwise, for minimal, at least we can do real-time PCR.
Thank you. So the clinicians often send the samples to other places for molecular testing. And then how do you think that what do you want from a pathologist or a molecular biologist that is easy for a clinician when you are at the bedside of the patient for strategy for testing? Dr. Neeraj Rastogi.
I think the molecular testing only comes in the stage of when it comes to during follow-up, when patients come with the metastatic disease or the recurrent disease. Otherwise, most of the time it is very well taken with the surgeon, followed by radioiodine therapy. So, and when you ask for these tests, you have to think of whether patient is able to afford the cost of the therapy. Because except the common drugs which is available in India, like lenvatinib and sorafenib and cabozantinib, rest of the drugs are not available in India, and they are very expensive. And even like the pembrolizumab, it is costing about 2 lakh rupees per month, and it is very, very difficult for the patient to afford for at least 6 months to a year. So once you ask these testing, you have to think of the cost of the therapy, whether patient can afford.
Yes, right. So Dr. Gaurav, would you like to make your comment on this strategy of testing? How do you go about it?
Ma'am had a point to make. Should I?
Yeah, please, Dr. Radhika. I didn't see your.
I think as far as testing strategy is concerned, I'll have to say that we need to break it down into the scenarios. What is the purpose of that particular test? So at least 3 different scenarios I can think of, though these are not things which are not kind of scenarios we often encounter and we use. But wherever we are trying to use molecular testing as a problem-solving tool for diagnosis, of course, they have to be performed on cytology smears. And we haven't been doing that, but for obvious reasons, the panels, either Thyroid or Afirma, they are the flavor of the season. But given a choice, if there's a need, we have been using very anecdotally BRAF, for example. But that is as far as diagnosis is concerned. For iodine refractory and progressive advanced stage diseases, these have to be again tailored to. I don't see a scenario where we'll be able to use a whole panel. They'll have to be tailored to the individual patient's anticipated benefits, rather than having a whole panel done together. And then as far as medullary carcinoma is concerned, which is, I wouldn't say that's the commonest, but that is the most interesting cancer of these all for us endocrine surgeons. We have a very straightforward individualistic rather than a combined approach to a lot of different molecular tests being done. We start with red, and more often than not, our requirements are kind of fulfilled by just doing red mutation testing.
Thank you, Dr. Gaurav. Dr. Alok Gupta, will you share your experience?
So let me just restrict my answer to the radioiodine refractory advanced cancers, besides the medullary and the other aspects. So within those specific situations, I would say the cost plays an important role. And as has been said, cabozantinib, lenvatinib, and sorafenib, all these three drugs, the generics are available and they are relatively easy to use and afford. And we have gained significant experience with these drugs. So the therapy might cost somewhere between 3,000-4,000 a month to as much as 10,000 a month. So that's the range of that's the answer to the cost question. In practical scenario, BRAF test is the only test which might help me change my treatment decision making for those patients, because for BRAF we have specific inhibitors available. We do not have RET inhibitor, the selective inhibitor for RET as of now. But again, the BRAF inhibitor, vemurafenib and dabrafenib, which are available, vemurafenib would cost around 35,000 to 50,000 a month. So if somebody can take that cost, we should go ahead and test for BRAF. Now, this is as far as the therapeutic aspects of papillary and follicular radioiodine refractory cancer is concerned.
So will you ask the pathologist to get it done by IHC, or would you like to send the samples to for
medical oncologist? NGS has become a very favorite. It makes our job easy.
Right, that is what is. So now Dr.
In fact, I have had experience where the BRAF, which was done by PCR, was negative, and I sent the same sample to Foundation One US. And they did an NGS and it came out to be positive. And that patient survived for 1.5 years on dabrafenib trametinib combination.
Okay.
So
yeah, that is true.
I mean, yeah, it also depends on the.
It will always be difficult to compare RT-PCR to NGS. So Dr. Radhika has a point.
I think most of the points have been very nicely summarized by the panelists. So I just was comparing, this emerging field in thyroid actually to slightly the lung cancer field, where things are a little more crystallized now.
Right.
And we, all the stakeholders have sat together at the international level, of course, and they have clear-cut guidelines, regarding like all the questions that you posed. What is the sample? What is the strategy? How to go about it, etc., etc. So I think we are still looking at it. Maybe in the coming years, I think guidelines for thyroid molecular testing will actually see the light of the.
They're crystallizing slowly.
Slowly. Yes. I just want to add, while I was preparing for this talk, I just came across a couple of papers which could be a game changer for BRAF testing, and that's ddPCR.
Yeah.
It is so simple, so easy to do, a point mutation, and that can be done even in low resource settings also, rather than, of course, NGS is the costliest. And like you said, yes, Sanger sequencing is good, but then we know that the sensitivity of Sanger sequencing and the allele frequency is less than 20% or so, it doesn't work well. It can miss a lot of cases. So these are a lot of issues, I think, and I really look forward to the day when the Endocrine Society, along with the pathologists and molecular pathologists, and all of them sit together and really provide the guidelines.
Dr. Shipra wanted to make a point.
Yeah, so what we do is we use a stepwise approach. First, we do RT-PCR, we do BRAF if the patient requires a targeted therapy. If that comes negative, that's when we resort to NGS. So RT-PCR we are doing in-house, it's easy. So we use the kit, we provide a solution. And in some cases now the clinicians are also coming back to us for PDL1. So PDL1 also we are doing and providing the results. So that's how we do it. Again, stepwise to save on the costing and the time.
Thank you, Dr. Chipra. Dr. Krishnani wants to make.
Just one question, very small question related to tumor mutation burden. If there is no hope, then why can't we go for tumor mutation burden, especially in the resistant patient, if the patient can afford? Because we have immunotherapy for that.
Yes.
Can I answer that? TMB,
Yeah, please.
TMB is usually low in cancers, thyroid cancers, including ATC. So even ATCs have a less than 10 MB tumor mutation burden. So it's not of much help. And in MTs, in medullary thyroid carcinomas, we have done few cases with PD-L1. They are usually PD-L1 negative. So I think immunotherapy is lower down in most cancers, except for ATC, when PD-L1 is more commonly diffusely positive.
Right. So for PD-L1, you're doing by the immunohistochemistry protocol?
Yeah, by Ventana.
Ventana, which clones?
We are using SP260.
260. Okay, thank you, Dr. Shipra. So are there any other comments from the audience? Okay. So thank you so much. That was a very exciting discussion, and this discussion doesn't end here because there is a long way to go. Thank you so much, everybody. As a pathologist, we all know that molecular is in our lives. We are looking at a molecular microscope. Thank you so much. That was very nice of you.
Thank you.
Thank you so much, Professor ma'am, for this discussion, and thank you to all the respected chairperson for this interactive and informative session. All the delegates are requested to take selfie for selfie cup at selfie booth. It will be available till 4 p.m. today. Now we move on next to alert, which is entitled as updates on Pheochromocytoma and paraganglioma. For this, we would like to invite our honorable chairpersons to come on the stage. Professor R.K. Gupta sir, he's the head of department in Sahara Hospital, Lucknow, and he's a former head of department of HGPGI, Lucknow. Professor Nuzhat Hussain ma'am from RML Institute of Medical Sciences. We request Professor R.K. sir kindly introduce our speaker, Dr. Arthur. He will be joining us online. We request Professor Krishnani sir to kindly come up with the dais to moderate this discussion. Here.
दो chairperson एक
But here I will kindly introduce our chairperson, the speaker. We request Professor Krishnani sir kindly introduce our speaker, Dr. Arthur. He will be joining us online. Nuzhat Hussain ma'am.
It's my pleasant duty to introduce Dr. Arthur Tischler as a professor of pathology at Tufts Medical Center and Tufts University School of Medicine, Boston. And his area of interest are cellular and molecular pathology, pathology of pheochromocytomas and paraganglioma. And achievements and as awards is a surgical pathologist at Tufts Medical Center, and he has served as editor-in-chief of the Journal of Endocrine Pathology and as president of Endocrine Pathology Society. He is a contributor to multiple chapters on Pheochromocytoma, paraganglioma in the 2022 WHO Endocrine, Head and Neck, Pediatric and Hereditary Tumor Syndrome Blue Books. He was a founding member of the Pheochromocytoma Research and Support Organization. So he has been recipient of Annual Science Award from the Pheopara Alliance. So with that introduction, I invite Dr. Arthur S. Tissler for presenting his lecture on updates on Pheochromocytoma and paraganglioma. Over to you, sir.
Greetings, Indian colleagues. I'm honored to be invited to participate in your meeting today, and I thank the organizers for inviting me. I hope that we will be able to continue our discussions in person at some time in the not too distant future. This presentation is a brief update on what we know about pheochromocytoma and paraganglioma in 2022. At the end of the lecture, the participants will be able to explain the development of normal paraganglia and corresponding nomenclature, recent changes in the WHO classification of pheochromocytoma paraganglioma, the clinical implications of hereditary pheochromocytoma paraganglioma, and the evolving roles of pathology and biomarkers in diagnosis and patient care. Our nomenclature for pheochromocytoma and paraganglia was originally described by the chromaffin reaction. In the mid-19th century, researchers in a variety of countries were using rather primitive histochemical techniques in order to determine what substances were produced in different cells. It was found that if you fix a piece of adrenal medulla in some ordinary fixative, not very much will happen. However, when the same tissue is fixed in a solution of chromate salts, a dark reddish-brown color develops. It was believed that this color change resulted from a specific affinity for chromium, hence the term chromaffin cell and chromaffin reaction were coined by an anatomist named Alfred Cohen, who was working extensively on these cells in Prague at the time. However, it was subsequently discovered that if you take the same piece of tissue and you fix it in a solution of a weak oxidizing agent, such as iodate, you'll get a similar, though not identical, color change. It was discovered much later on that the color change resulted not from affinity for chromium, but from oxidation of stored substances, which we now know are catecholamines. Consequently, the term pheochromocyte was invented to describe the color change without connoting a mechanism for it. However, by that time, the term chromaffin cell and chromaffin reaction had firmly taken hold for the normal tissue, while pheochromocyte was later adopted for its neoplastic counterpart. Consequently, we start with the peculiar situation in which a normal cell type goes by one name and its neoplastic counterpart goes by another. Alfred Cohen, the researcher who was working on chromaffin cells and the chromaffin reaction, came up with a revolutionary concept as a result of his work. He said, since the chromaffin tissue complexes form ganglion-like bodies, since their elements are derived from ganglion precursors, since they are connected to the sympathetic nervous system and still are not genuine ganglia, I have called them paraganglia. So the concept and the term of paraganglia are based not on proximity, but on analogy to sympathetic ganglia. And this concept was revolutionary because it was the first iteration, first conceptualization of a diffuse neuroendocrine system. In this case, a nervous system-derived diffuse neuroendocrine system rather than an epithelial one that preceded that notion by approximately 50 years. Cohn and his colleagues and others used the chromaffin reaction to map the distribution of chromaffin cells throughout the body, and they soon discovered that small groups of chromaffin cells were distributed throughout the distribution of the peripheral sympathetic nervous system, from stem to stern, and the distribution of nerves from the superior cervical ganglion all the way to nerves innervating the pelvic and abdominal organs. And these were all microscopic except for the adrenal medulla in adults and the organ or organs of Zuckerkandl, which are a large body of, or bodies of chromaffin-like cells at roughly the origin of the inferior mesenteric artery. Similar cells were located along branches of the vagus and glossopharyngeal nerves in the head and neck. Again, these were microscopic and highly variable in location, except for the carotid body, which is macroscopic and is consistently located at the bifurcation of the carotid artery. The cells along the sympathetic nervous system are now known as sympathetic or sympathoadrenal paraganglia, and those in the head and neck are known as parasympathetic or head and neck paraganglia. An alternate term for these that was applied some time ago but is now obsolete was non-chromaffin paraganglia. This term is obsolete because the chromaffin reaction itself is obsolete, and there are much better ways of detecting and identifying paraganglionic tissue. Between World War I and World War II, there was a long hiatus in the study of chromaffin cell biology. And this field remained essentially dormant until the 1950s, when it was reawakened by an anatomist in England named Rex Copeland. Copeland published many papers, but he summarized them in a classic book called The Natural History of the Chromaffin Cell, which he published in 1965. And Copeland mapped the distribution of chromaffin cells throughout the body, as Alfred Cohn had done. And he next mapped the distribution of tumors of chromaffin cells that had been reported up to that time. And he found that this distribution pretty precisely correlated with the distribution of normal chromaffin tissue, establishing the distribution of pheochromocytomas and paragangliomas that we know to this day. And he also reported that these tumors were located, and their normal counterparts were pretty much located or concentrated in the vicinity of nerves derived from the pre-aortic plexuses, particularly the celiac and hypogastric plexuses, and those near the inferior mesenteric artery. This beautiful drawing of those plexuses here is not from Copeland himself, but is an illustration from the 1918 edition of Gray's Anatomy. Moving on to embryology. There have been profound changes in the understanding of the development of paraganglia and the adrenal medulla since Cohn's time. From the 1970s to roughly through the 1990s, we had the concept of a pluripotent primitive sympathetic cell that delaminated from the neural crest and migrated either to the adrenal medulla and extraadrenal paraganglia or to sympathetic ganglia, with its ultimate fate depending upon the environment in which it came to rest. This theory had begun to be overturned by the mid-1980s, but it was finally put to rest in the 1990s and was completely modified as a result of a paper by Furlan et al. In Science in 2017. And the current understanding resulting from that paper and those that followed it is that the fates of cells derived from the neural crest are largely predetermined, and there are distinct populations of progenitors for neurons and chromaffin cells characterized by distinct markers and distinct routes of migration. There are some crossovers expressing bridge cell markers, especially in humans, and some of these bridge cell markers are illustrated here. And there are newly recognized progenitors called Schwann cell precursors that may constitute the majority of cells contributing to the development of the paraganglionic system. As described in these illustrations from the Furlan paper, there is indeed a population of neural crest cells that delaminates directly from the neural crest and makes a beeline for the sympathetic ganglia. However, a perhaps much larger population remains in situ in the vicinity of the developing sensory ganglia. Cells mature in the sensory ganglia, that is the dorsal root ganglia, that subsequently form from the neural crest in that location, and migrate along sensory neurons to join up with preganglionic sympathetic neurons, sympathetic axons that emerge from the intermediolateral columns of the spinal cord. And they use those axons as guidance to reach their destinations in the adrenal medulla and paraganglia, with the exception of a few bridge cells, crossover cells that I mentioned. These cells have been that arise from the dorsal root ganglia and have a reservoir within the sensory ganglia and sensory axons have been given the perhaps unfortunate name of Schwann cell precursors, because they give rise, unfortunate because they give rise to a variety of derivatives other than Schwann cells. But the importance of this concept is that Schwann cell precursors migrate in waves, and they eventually require this axonal guidance because the embryo becomes too large and too complicated with too many obstacles for directly migrating cells to reach their destinations. And the clinical importance or potential clinical importance of Schwann cell precursors, which is they serve as a potential reservoir of neural crest cells after the neural crest ceases to exist. And in that capacity serve a function for expansion and diversification of the cell populations in neural crest-derived tissues. The different paths of migration and different waves of migration of Schwann cell progenitors may explain a number of previously unexplained phenomena, including different types of skin pigmentation and different characteristics of neuroblastomas, as well as paragangliomas that arise in different locations. This is a transverse section of an approximately 19-week human fetus showing what paraganglia really look like. And as a cross-section, these two structures, which are paraganglia here, may correspond to what is diagrammed as the lobes of the organ of Zuckerkandl. They typically are composed of clear cells. You can see these classic cell bond architecture here. And also note that these paraganglia are very close to retroperitoneal lymph nodes. And this explains why you cannot use imaging to tell whether a primary tumor, whether a paraganglioma in any of these locations is primary or a lymph node metastasis. So the only sites of metastasis that are unequivocal are sites in which normal paraganglia do not occur, which are bone and histologically documented lymph node. Normal paraganglia, as well as their neoplastic counterparts, express well-known markers that we're all familiar with, including chromogranin A, tyrosine, and tyrosine hydroxylase. The sustentacular cells, which retain many of the properties of Schwann cell precursors, although they may not be precursors of anything in the adult, express S100 and SOX10 and can be identified using those markers. Tyrosine hydroxylase and chromogranin A may often not be expressed in head and neck paraganglia or paragangliomas, and other markers may be needed to identify them, as I'll discuss later. This is a higher magnification and another view of a human fetus, and this slide is shown to make several points. First, this is the adrenal medulla, and these are the extraadrenal paraganglia. Note that extraadrenal paraganglia are fully formed before the adrenal medulla exists. These pink cells here are provisional cortex or fetal cortex, which are just starting to be populated by these adrenal medullary precursors. Extraadrenal paraganglia are the main source of fetal catecholamines, and they respond directly to hypoxia in order to regulate fetal heart rate before central mechanisms of hypoxic signaling are established. And in that role, they express a number of transcription factors called hypoxia-inducible transcription factors, one of which is known as HIF2 alpha or EPAS1, which plays a particularly important role in the development of a family of paraganglionic tumors. The organ of Zuckerkandl, which has a catchy name, is the largest single collection of fetal chromaffin tissue, but it should be remembered that it still comprises less than 1/2 of the total, according to Rex Copeland. The conventional wisdom about paraganglia for many years had been that they involute in adult life or by adult life, but that in fact is not entirely correct. The organ of Zuckerkandl may involute, but microscopic paraganglia often persist. For example, this one, characterized by the typical clear cell populations and cellballen in the wall of the gallbladder, and here it is in an adult, and here it is stained for chromogranin A. And these persistent normal paraganglia are potential sites both for the origin of paragangliomas and as diagnostic pitfalls in places where clear cell neoplasms may arise. So if you find a paraganglion in the vicinity of the prostate or the kidney and you're looking for a clear cell carcinoma of the kidney or a prostatic carcinoma, you should not be fooled into mistaking a paraganglion for an implant or metastatic focus of carcinoma. The World Health Organization Blue Book in 2004 first codified some arbitrary definitions in order to reduce inconsistent classifications of tumors in and outside of the adrenal medulla that had existed until that time. And the 2004 Blue Book stipulated Pheochromocytomas arise in the adrenal medulla and are derived from chromaffin cells. Extraadrenal paragangliomas arise from chromaffin cells in sympathoadrenal and parasympathetic paraganglia. And as a historical annotation, it added a pheochromocytoma is an intraadrenal sympathetic paraganglioma. Now, although the nomenclature was arbitrary, it does indeed, the special treatment of the adrenal medulla does in fact reflect some distinctive characteristics of intraadrenal tumors. They're often adrenergic, that is, they produce adrenaline or epinephrine, while extraadrenal paragangliomas are almost always noradrenergic, dopaminergic, or non-functional, with the exception of a recently reported group of adrenergic pheochromocytomas in China. They also have a lower likelihood of metastasis, and they also have a proclivity to occur in association with particular hereditary disorders. But quite a bit of awkwardness and quite a number of odd abbreviations result from arbitrarily trying to separate entities that we know are overall more similar than they are different. So the terminology, or at least the concepts that accompany that terminology, have evolved in the 2022 Series 5 Blue Books. The definition now is that a pheochromocytoma is a neuroendocrine neoplasm that originates from chromaffin cells of the adrenal medulla and is an intraadrenal paraganglioma. So the historical nomenclature thing is gone. It is, in fact, a reasonable term to think of it as a paraganglioma. And related to acceptable terminology is intraadrenal paraganglioma or adrenal sympathetic paraganglioma. So while the actual separation of terms still persists, pheochromocytoma is not going to go away anytime soon. A better way of organizing our conceptual framework is to consider all of these tumors as part of the paraganglionic system, with their distinctive characteristics determined both by their anatomic locations and by their underlying genetic abnormalities. And this is, in a way, a trip back to the future, because if we look at literature from the early part of the 20th century, the tumors that we now know of, that we now call pheochromocytomas, were in fact described in this example, in this sample reference from 2029, as adrenal paragangliomas in different languages in this particular paper. WHO 2022 continues, as in 2017, the last series of Blue Books, to discourage the use of the terms benign and malignant for pheochromocytoma and paraganglioma. Sympathetic paragangliomas and pheochromocytomas are all coded as malignant. The terms benign pheochromocytoma and malignant pheochromocytoma are not recommended. They're all combined into pheochromocytoma in the new Blue Book. This brings thinking into line with concepts of gastroenteropancreatic nets, which are all considered to have some risk of metastasis. And this approach encourages risk stratification rather than binary classification. The risk of metastasis in pheochromocytoma paraganglioma is affected by tumor location and genotype. Overall, it is still somewhere between 10 and 15%, and overall for the adrenal, it's still somewhere around 5%, while for extraadrenal sympathetic paragangliomas, the risk is approximately 20%. However, in any location with the succinate dehydrogenase B mutation, Succinate dehydrogenase B being one of the genes that encodes subunits of this Krebs cycle enzyme succinate dehydrogenase, the risk for metastasis is over 30%. The prognosis of these tumors is also affected by tumor stage, which is in turn affected by tumor location. And the 8th edition staging manual of the American Joint Cancer Commission introduced a staging system that reflects both tumor stage and tumor location. So a tumor is classified as T1 if it's less than 5 centimeters in greatest dimension and has no extra-adrenal invasion. It automatically becomes T2 if it's intra-adrenal, measuring more than 5 centimeters, or is an extra-adrenal sympathetic paraganglioma of any size, with or without extra-adrenal invasion. This reflects the greater likelihood of invasion of extra-adrenal sympathetic paragangliomas, and that sharp dichotomy between adrenal and extra-adrenal in terms of survival is shown in this Kaplan-Meier plot. However, if you look again more closely at the data, a great deal of this difference in survival is dependent on the presence or absence of SDHB mutations, since most extra-adrenal paragangliomas are extra-adrenal or abdominal or thoracoabdominal tumors. The staging system does not apply to head and neck paragangliomas because they were generally considered to have a very low metastatic risk. However, even head and neck paragangliomas harboring SDHB mutations, though they are not staged, probably have a higher risk than those with the more common SDHD mutations. Our understanding of the heredity of pheochromocytomas and paragangliomas has also continued to expand both prior to and with the current Blue Book. Key points to remember are that these tumors are the most hereditarily driven of all human tumors, and at least 30% are now known to have a hereditary basis. Tumor locations, syndromic associations, risk of metastasis, and endocrine function all correlate with the predisposing gene. Germline mutations of more than 20 susceptibility genes have so far been reported, and the largest number of familial aggregations of these tumors involve mutations of genes encoding subunits of succinate dehydrogenase, which are sometimes collectively referred to as SDHX genes and SDHX mutations. So if we look at the rate at which new mutations have been discovered, prior to the year 2000, we were very familiar with NF1, VHL, and RET as the main causes of hereditary pheochromocytoma. Revolutionary papers published by Bora Beisal and Hartmut Neumann, respectively, in 2000 and 2002, identified a whole new class of tumors characterized by succinate dehydrogenase gene mutations, and additional hereditary mutations continued to be discovered from that time to the present. An additional new development is that somatic mutations have come increasingly to the fore. So if we look at the combined frequency of germline and somatic mutations for different types of tumors in 2021, VHL and NF1 and RET are still there and are still common. But somatic mutations of NF1 are even more common than germline mutations. And somatic mutations of VHL and RET are also not infrequently encountered. Interestingly, somatic mutations of HIF2 alpha, EPAS1, are overwhelmingly predominant, and if any germline mutations actually exist at all, they are extremely uncommon. And the exact reasons for this difference is not clear. We're very familiar with the genotype-phenotype correlations in classic paraganglioma syndromes. For example, with MEN2B and RET mutations, we have almost exclusively adrenal tumors, and these may be associated by medullary thyroid carcinoma and parathyroid, not hyperplasia or neoplasia. Similarly, in NF1, we have neurofibromatosis type 1. We have predominantly adrenal tumors, and the associated tumors there are GISTs. And in VHL, the associated tumors include renal cell carcinoma. SDHX mutations create an entire new level of complexity in dealing with these hereditary tumors. As I've mentioned, the great majority of familial groupings of pheochromocytoma and paraganglioma, and almost 10% of apparently sporadic tumors, are accounted for by these mutations. The SDH mutations also account for almost 30% of pediatric cases, and at least 30% of the tumors that metastasize and are present in somewhere between 15 and 25% of all patients with paragangliomas. But extremely importantly, the spectrum of tumor types in patients with SDHX syndromes overlaps the spectra of classic syndromes. So this table briefly lists the locations and the types of syndromically associated tumors in paraganglioma syndromes associated with mutations of the different SDH genes. And notice that a common finding in several of these is the presence of gastrointestinal stromal tumor or renal cell carcinoma. Pituitary neoplasia may also occur in some patients. So we have to be aware of these syndromic overlaps, and we also have to be aware of distinctive characteristics of these syndromically associated tumors that occur in patients with SDH mutations, so that we can call attention to the possibility of syndromic disease. So starting with pheochromocytomas and paragangliomas, the biochemical phenotype of the tumor usually points to tumor location and to genotype. Epinephrine, or adrenaline, is normally synthesized almost exclusively in the adrenal. So the presence of epinephrine or metanephrine in general suggests pheochromocytoma. However, a pheochromocytoma that is not adrenergic and that is noradrenergic or dopaminergic suggests the presence of a VHL or SDHX mutation. Thoracoabdominal paragangliomas typically produce norepinephrine and or dopamine and not epinephrine. SDHX mutations account for most of this group, and a tumor that is adrenergic is not likely to be in the thorax or abdomen outside of the adrenal, with the exception of the Chinese group that I mentioned earlier. Most head and neck paragangliomas lack tyrosine hydroxylase and are therefore actually unable to synthesize any catecholamines. And they may, in fact, also lack other markers that are classically associated with paragangliomas, including tyrosine hydroxylase and chromogranin A. And to diagnose some of these tumors correctly, we may have to resort to newer markers, including transcription factors, INS-M1 and GATA3. But it should also be remembered that up to 35% of the head and neck tumors that appear non-functional on clinical assays actually show tyrosine hydroxylase expression by immunohistochemistry, and that can be diagnostically useful in some cases. I mentioned the epinephrine-producing paragangliomas in China. Most of these appear to be associated with somatic HRAS and FGFR1 mutations. And this is a story that is just beginning to develop. The Cancer Genome Atlas study of 2017 divided pheochromocytomas and paragangliomas into genotype-phenotype clusters based on transcriptome, germline mutation, and expression of selected proteomic markers. And the major clusters at that time were called cluster 2 and cluster 1. So our canonical hereditary tumors, those caused by RET and NF1, fit into cluster 2, which is characterized initially by abnormalities of kinase signaling. RET being a receptor tyrosine kinase activated by ligands of the GDNF family, and NF1 being a tumor suppressor gene that interferes or that counteracts kinase signaling through the MAP kinase cascade. Cluster 1 is now known as the pseudohypoxic cluster, and both VHL and SDHX tumors fall into cluster 1, pseudohypoxia. The third relatively rare cluster is a Wnt-altered cluster in which the major mutations are fusions of genes of the mammal family, which is a developmentally regulated gene. If you look at the frequencies of germline and somatic mutations in these three clusters, the Wnt-altered tumors are all somatic. Cluster 2 is a more or less equal mixture of germline and somatic mutations, with a predominance of somatic mutations because of the great abundance of somatic NF1 mutations. And cluster 1, the pseudohypoxic cluster, is predominantly germline. Molecular clusters are important because they may lead to highly selective targeted therapies. And we can understand some of these targets by looking at how cells regulate responses to oxygen. So in a normal cell, in the presence of normal O2 concentration, enzymes that are called prolyl hydroxylase domain enzymes, or PHD enzymes, hydroxylate hypoxia-inducible transcription factors such as HIF2A or HIF1 on prolyl domains. And this hydroxylation tags them to be targeted by the von Hippel-Lindau protein for proteolytic degradation. Under physiological hypoxic conditions, the reverse happens. The prolyl hydroxylase domain proteins show reduced activity. HIF proteins are not hydroxylated, therefore not degraded, and they remain bound to domains in the DNA that cause activation of a variety of oxygen-sensitive genes. In pseudohypoxic tumors, those associated with VHL or HIF2A mutations and some others, we have hypoxic signaling in the presence of normal or elevated oxygen conditions. And this occurs because the PHD proteins are members of a large family of proteins called 2-oxoglutarate-dependent dioxygenases. Alpha-ketoglutarate-dependent dioxygenases would be a different term. that use 2-oxoglutarate as a co-substrate and generate succinate as a byproduct. So in the presence of elevated succinate, for example, which occurs in all of the tumors with SDHX mutations, these 2-oxoglutarate-dependent dioxygenases are inhibited by the presence of excess succinate, and HIF2-alpha, hypoxia-inducible transcription factors are not degraded, and they remain within the nucleus abnormally in the presence of high oxygen, as well as they would with low oxygen. But the exact mechanisms of tumorigenesis with VHL and SDH mutations are quite different, because in VHL, it is the VHL protein itself that's defective. So it's a rather late stage in the degradation of these factors. But in the case of the SDH mutated tumors, there are additional effects of the accumulated succinate. And the additional features of the SDH deficient tumors include a hypermethylator phenotype, because the 2-oxoglutarate-dependent dioxygenase family includes enzymes besides the prolyl hydroxylases, including enzymes, succinate-sensitive enzymes that demethylate histones and DNA. So you have a variety of abnormalities resulting from hypermethylation that in the SDH deficient tumors that you do not see in the VHL deficient tumors. In addition, you also have metabolic rewiring resulting from succinate deficiency, causing alternate utilization of biosynthetic pathways, anaplerotic pathways that branch off the Krebs cycle, and perhaps bioenergetic imbalance resulting from the shift to aerobic glycolysis. The roles of pathology and biomarkers in the field of pheochromocytomas and paragangliomas have also expanded. We have a classic role of differential diagnosis. We now have increasing responsibilities in identifying patients who may have familial disease. We have some possibilities of assessing metastatic potential. At this point, our role may be confirmed mostly to histologic confirmation of metastases, but there may also be some predictive tests in the wings. And in addition, there are predictive markers for imaging and treatment. For differential diagnosis, we know there are many, in addition to the classic cell balling pattern, there are many patterns without cell balling involving cells of different sizes and different cytologic features. And the differential diagnosis is huge, and it can include epithelial and non-epithelial carcinomas. Especially confusingly, it may include epithelial neuroendocrine neoplasms. Our general approach is an immunohistochemical panel to show neuroendocrine markers such as chromogranin A or synaptophysin, combined with the absence of keratins to rule out epithelial nets and the presence of functional markers and transcription factors such as GATA3 as needed. A caveat is that head and neck paragangliomas can be non-functional and also negative or only focally positive for other classic protein markers, as in this tumor, which is completely negative for tyrosine hydroxylase. And in those tumors in particular, transcription factors and panels of markers can be critically important to avoid mistakes with serious diagnostic consequences. For identifying familial disease, there are especially new challenges for clinicians and pathologists because syndromes overlap and include new components such as SDH deficient GIST, renal cell carcinoma, and pituitary tumors. And in addition, some hereditary pheochromocytomas and paragangliomas are not syndromic. For example, those are caused by hereditary mutations of TMEM 127, SDHA, or KIF1B are usually solitary tumors without other accompanying manifestations. In addition, transmission of some hereditary pheochromocytomas and paragangliomas are subject to inheritance resembling maternal imprinting, so that paragangliomas caused by SDHD or SDHAF2 mutations can be transmitted in terms of susceptibility by either the mother or the father, but the disease becomes penetrant only, as a rule, only if transmitted by the father. As a consequence, whole generations of patients with hereditary susceptibility to these tumors can be missed, and that is the reason that it took so long for SDHD mutations to be identified as a common cause of hereditary head and neck paragangliomas. So the warnings to us here are to be aware of the new hereditary landscape, to consider genetic testing for all patients with pheochromocytoma paraganglioma, and to be alert to possible syndromically associated tumors and their distinctive characteristics. So findings suggestive of classical familial disease are multiple tumors and tumors combined with diffuse or diffuse and nodular hyperplasia. We no longer call nodular disease in the adrenal medulla nodular hyperplasia, because all of these two nodules have the molecular hallmarks of micropheochromocytomas. In addition, familial disease in general tends to occur in young patients, to be multiple or bilateral, to have other syndrome-associated tumors, and to have, in some cases, to have distinctive immunohistochemical markers. Additional findings, however, are that multiple tumors in the adrenal are not always, are almost always characteristic of MEN2, but even in MEN2 are not always present, usually not present in other syndromes, often not concurrent, and can be subtle. So there's no question about the multiple tumors in this adrenal, but in this adrenal, the presence of these small nodules was quite subtle, and this can be missed unless,
Sorry, we'll be cutting this talk short as the meet the experts cannot be delayed as that is live. This will be played later when we have time.
I take the privilege to invite Dr. Suresh Babu sir to the dais. I take the privilege to invite Dr. Suresh Babu sir to the dais. He is a senior consultant and professor, Department of Pathology, King's George Medical University, Lucknow. His area of interest include dermatopathology and cytopathology.
And we would like to invite Dr. Sameer Mohinder, sir, who is a renowned gastroenterologist and a consultant here in Department of Gastroenterology in SGPGI.
Before we begin the next session, we have an announcement to make. We need residents' name for the case-based discussion on thyroid cytology for tomorrow's seminar.
We request Dr. Suresh Babu sir to introduce the speaker and the topic for the day. Dr. Sameer has just arrived. Good afternoon, sir. So, please introduce the speaker of the day, sir.
A very good afternoon to everybody. Our next speaker is Atul Singhal. He is designated as an associate professor, director and coordinator of anatomical pathology, research, and director of UPMC developmental laboratories. He is also affiliated to Division of Anatomical Pathology and Molecular Genomic Pathology, University of Pittsburgh. Area of interest is GI pathology, peritoneal and pancreaticobiliary pathology. His achievements, more than 30, in the international publications. He is also awarded to UP CAP Abstract Award 2016 and another award in 2016 is the Resident Research Mentor Award, University of Pittsburgh Medical Universities. He is also get the awards in 2016, the American Pancreatic Association Pittsburgh Research Awards. So I would like to invite speakers.
So before I begin, I'd like to take the time to thank the program committee for inviting me to speak to all of you today, specifically Dr. Jain, Dr. Agarwal, and Dr. Sestava. Unfortunately, I could not be there in person this time, but in the future it's my hope to visit Lucknow soon and meet up with family and friends. Now, as you can tell from the title of my talk, within the next 45 minutes, I'd like to cover neuroendocrine neoplasms of the pancreas, which is a topic that has confused many pathologists, including experts, because of the constant changes in nomenclature, classification systems, grading schemes, and even the AJCC TNM staging system. To address these issues, I'd like to start off with a case presentation and then segue into the epidemiology, nomenclature, and clinical pathologic features of the major pancreatic neuroendocrine neoplasms. Further, it's important to discuss why and how these neoplasms need to be distinguished, including their associated molecular findings. And finally, I'd like to discuss other diagnostic entities that can also arise or secondarily involve the pancreas and may mimic these neoplasms. So let's start with a 78-year-old female complaining of abdominal pain. She also noticed she had dark urine and her skin was yellow. Laboratory tests were ordered and demonstrated elevations in both liver transaminases and pancreatic enzymes. Because of her symptoms and elevated lab values, she emergently underwent a magnetic resonance cholangiopancreatography, or MRCP, to evaluate her pancreas, bile duct, and liver. The MRCP identified a contrast-filling defect within the distal common bile duct that corresponded to a bile duct stricture, as indicated by the yellow arrow. A stent was placed across the stricture to keep the bile duct patent, and the patient underwent further imaging that included a CT scan, which demonstrated a large pancreatic head mass. And it measured about 5.6 centimeters in greatest dimension. An FNA of the pancreas was performed and a diagnosis of positive for carcinoma was rendered, but the cytopathology material could not be further subtyped. The patient, however, was a good surgical candidate and underwent a classic pancreatic duodenectomy or Whipple procedure. As with all of our Whipple specimens, we cut the pancreas along the duct, specifically the pancreatic duct and the bile duct. The bile duct is indicated to the top and the pancreatic duct is to the left. As shown here, the pancreatic duct was completely obliterated by a large mass that again measured 5.6 centimeters in greatest dimension, encompassing almost the entire pancreatic head. Histologically, the mass was centered within the pancreas and composed of closely packed neoplastic cells with little intervening stroma. At higher magnification, the neoplastic cells were organized in a nested architecture and composed of monotonous cells with stippled or somewhat salt and pepper nuclei and granular eosinophilic cytoplasm. A limited immunohistochemical panel was performed and demonstrated diffuse immunolabeling for cytokeratins as well as both synaptophysin and chromogranin. Finally, immunolabeling for Ki67 demonstrated a high proliferation index of 24%. Now, when approaching a pancreatic lesion, I like to apply a systematic or algorithmic approach with the first decision tree based on whether the lesion is solid or cystic in nature. And among the solid lesions, the differential diagnosis includes 6 neoplasms and an important benign entity, specifically chronic pancreatitis. Of course, the topic for today is not pancreatic ductal adenocarcinoma, which is a lecture in itself. but instead neuroendocrine neoplasms of the pancreas, specifically well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas. However, it's probably worthwhile to put these neoplasms in perspective. In comparison to pancreatic ductal adenocarcinoma, pancreatic neuroendocrine neoplasms are the second most common neoplasm of the pancreas. They're also the third most common neuroendocrine neoplasm of the gastroenteropancreatic system, with the first and second spots going to the ileum and rectum. Now, most lay people are unaware of pancreatic neuroendocrine neoplasms, and that's because the majority of patients have a protracted clinical disease course. For example, in the case of Steve Jobs, Irfan Khan, and Aretha Franklin, many of these celebrities were diagnosed years before they succumbed to their disease. In fact, Steve Jobs actually underwent liver transplantation in order to try to extend his life and decrease his metastatic tumor burden, which unfortunately was not successful. Nevertheless, the 5-year survival for pancreatic neuroendocrine neoplasms has improved over the years and hovers around 65%, and almost half these patients live past 10 years. Pancreatic neuroendocrine neoplasms are considered a rare disease, and in the United States, the incidence is approximately 3,000 patients per year. But it's projected that there will be a significant increase in the number of new cases over the next 5 years, likely due to incidental and indolent lesions being picked up with increasing use of radiographic imaging. Now, before continuing on to the clinical pathologic features of these neoplasms, it's important to make sure we're all on the same page regarding terminology. For example, the term differentiation, which can be a little confusing. To put it simply, differentiation refers to the extent a neoplasm resembles its non-neoplastic counterpart. For example, in the case of a pancreatic neuroendocrine neoplasm, does the neoplasm resemble the islets of Langerhans, or does it not? Pancreatic neuroendocrine neoplasms can be subdivided into two main categories of differentiation: well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas. There is no middle category. Well-differentiated pancreatic neuroendocrine tumors are referred to as PANETs and resemble the islets of Langerhans. And poorly differentiated neuroendocrine carcinomas, or PANECs, typically do not resemble the islets of Langerhans. Differentiation, however, should not be confused with histologic grade. Although we often use these terms interchangeably for other gastrointestinal tract tumors, specifically adenocarcinoma, both terms refer to something very different when it comes to neuroendocrine neoplasms. Histologic grade is an indicator of regression, or how quickly the pancreatic neuroendocrine neoplasm, is likely to grow and spread. In contrast to prior editions of the WHO, the 2022 WHO system assigns histologic grade to only pancreatic neuroendocrine tumors. Previously, we would assign grade to pancreatic neuroendocrine carcinomas, but this is no longer done as they're always a high-grade malignancy. As far as WHO histologic grades, there are 1 through 3, which is based on tumor proliferation index using mitotic count and Ki67 immunolabeling. Again, differentiation and histologic grade are separate variables, with differentiation referring to morphology and histologic grade to proliferation index. Now, by far, most neuroendocrine neoplasms of the pancreas are well-differentiated pancreatic neuroendocrine tumors. These neoplasms are defined as a malignant neoplasm arising from the islets of Langerhans and greater than or equal to 0.5 centimeters. Patients can present with a PANET at any age. However, younger patients are usually syndromic, such as those with MEN1 or MEN1 syndrome. In addition, clinical symptoms can vary depending on whether the neoplasm is functional or non-functional. Whether a PANET is functional or non-functional refers to whether the tumor is secreting hormones typically reserved for islets of Langerhans. For example, production of insulin by an insulinoma that consequently results in symptoms associated with hypoglycemia. Historically, PANETs often came to present clinical presentation due to their associated symptoms, so the prevalence of functional PANETs was higher than non-functional PANETs. And it would be expected due to the lack of symptoms. Non-functional PANETs often presented as large, bulky tumors with invasion into adjacent organs and distant metastasis. Thus, outcome for non-functional PANETs historically was horrible as compared to functional PANETs. However, in recent years, with improvements in radiographic imaging, incidental non-functional PANETs have substantially increased in prevalence, and as a result, these tumors are diagnosed at a much earlier pathologic stage. Thus, patient outcome for non-functional PANETs has improved dramatically as compared to functional PANETs. Grossly pancreatic neuroendocrine tumors are frequently tan to brown in color and are clearly demarcated from the surrounding uninvolved pancreatic parenchyma. But in some cases, they can be densely sclerotic and infiltrative. These neoplasms can vary in size from small to quite large, and in fact, size is considered an important prognostic feature. Other poor prognostic findings include venous invasion, as seen here, where the patient's tumor is within the splenic vein. and they can invade other organs like the spleen. Interestingly, approximately 10% of PANETs can present with a cystic component, which are referred to as a cystic pancreatic neuroendocrine tumor and often associated with MEN1 syndrome. Microscopically, these neoplasms are often walled off or encapsulated from the uninvolved parenchyma by a band of fibrosis and arranged in multiple organoid growth patterns that include nests, trabecula that appear as ribbons, gyroform configuration of internastomosing cords, and sometimes a sclerotic appearance with significant intervening fibrosis that can secondarily cause pancreatic duct obstruction and destruction of the pancreatic ducts thereafter. However, despite the variety of organoid patterns, all PANETs show similar cytologic features that are characterized by an eosinophilic granular cytoplasm and stippled or salt and pepper nuclei. Except for one variant, specifically the clear cell variant of pancreatic neuroendocrine tumors that exhibits abundant clear cytoplasm and may mimic a renal cell carcinoma. Hence, demonstration of neuroendocrine differentiation is essential to making the diagnosis of a pancreatic neuroendocrine tumor using immunohistochemical stains such as synaptophysin and chromogram. Now, I do want to underscore the WHO criteria for a PANET requires a size of at least 0.5 centimeters, which then begs the question, what about PANETs less than 0.5 centimeters? Well, those neoplasms less than 0.5 centimeters are referred to as a pancreatic neuroendocrine microadenoma and are considered precursor neoplasms to PANETs. Neuroendocrine microadenomas represent a clonal outgrowth from a single islet of Langerhans. In the case pictured here, a glucagon-expressing alpha cell within a single islet has started to clonally proliferate into a microadenoma. This proliferation contrasts that of a normal islet at the bottom right, as designated by the red arrow, which shows mixed expression for both glucagon and insulin. Poorly differentiated neuroendocrine carcinomas are rare neoplasms of the pancreas, and their origin is unclear. The general thought is that these neoplasms do not arise from the islets of Langerhans, but rather represent transdifferentiation from the exocrine pancreas, such as the ducts or acin or parenchyma. In support of this hypothesis, these patients often present with similar clinical symptoms that include obstructive jaundice, weight loss, and elevated serum markers for CA19-9 as those seen with exocrine pancreatic malignancies. Grossly, these neoplasms are indistinguishable from pancreatic ductal adenocarcinoma or acinar cell carcinoma. But microscopically, they can be subdivided into two types, small cell and large cell carcinoma, akin to the same terminology and somewhat same definition used to describe neuroendocrine carcinomas of pulmonary origin. Small cell carcinomas present as sheets or nests of small cells with hyperchromatic and molding nuclei. There may be areas of confluent necrosis, extensive apoptosis, or death, and obviously abundant mitotic figures. Large cell carcinoma have larger, round, vesicular nuclei that can form an organoid growth pattern very similar to well-differentiated neuroendocrine tumors, but these carcinomas have abundant apoptotic cells and certainly a significant number of mitotic figures. Now, in addition to determining differentiation, I mentioned the concept of histologic grade. In previous editions of the WHO and HACC, histologic grade was assigned to both well-differentiated pancreatic neuroendocrine tumors and poorly differentiated pancreatic neuroendocrine carcinomas. However, in 2017, the WHO removed the histologic grade from poorly differentiated neuroendocrine carcinomas. Histologic grade is strictly for well-differentiated pancreatic neuroendocrine tumors and categorized using a combination of both Ki-67 and mitotic figures. Of note, mitotic count should be measured by evaluating an area of 10 millimeters squared, but only reported as per 2 millimeters squared. So why don't we go through a few examples of histologic grades? This would be a grade 1 PANET, which is characterized by a Ki-67 of less than 3% and a mitotic count of less than 2 per 2 millimeters squared. Grade 2 PANETs have a Ki-67 index between 3 and 20%, or a mitotic count between 2 and 20 per 2 millimeters squared. And then grade 3 PANETs are classified based on Ki-67 index greater than 20%, or mitotic count of greater than 20 per 2 millimeters squared. Now, all of this is easier said than done. The real issues arise when you are near the cutoffs for each of the histologic grades, especially for Ki-67. And unfortunately, a precise method for Ki-67 assessment has not been standardized. The College of American Pathologists, however, does outline a number of methods that have been used to evaluate Ki-67. For example, some investigators have advocated that it's sufficient to report an eyeball estimate for Ki-67, but this should not be done for cases approaching specific cutoffs, as objective quantitation of Ki-67 is associated with significant margin of error, especially for pathologists that do not routinely score Ki-67 in practice. Others have gone to the other extreme, where they are utilizing automated digital analysis. This relies on expensive equipment and creation of complex algorithmic software to subtract the non-neoplastic cells, debris, and junk from the tumor cells that are present. In our own experience, we have tried for years to get this to work and finally have, but it's certainly taking an extensive amount of time, requires a digital platform, and somewhat of an artificial intelligence interface. What has shown promise, probably best in clinical practice, is manual counting of camera captured images. It's quick, inexpensive. You can do it with your cell phone if you like. It's feasible in a busy practice itself and highly accurate with high inter-observer agreement. Using this method, a minimum of 500 tumor cells should be counted to determine the Ki-67 index. And if there are less than 500 tumor cells, a comment should be made that less was evaluated. If evaluating biopsies, our practice is to add another comment that grading has not been completely validated within biopsies on these types of specimens, and thus prone to sampling issues. Finally, there will be cases where Ki-67 and mitotic counts are discordant in histologic grade. And in these scenarios, it is recommended to assign the higher grade. And usually the categorization of a higher grade is based on the Ki-67 index rather than the mitotic count. While I know histologic grade can be bothersome, its standardization has provided important prognostic information, as well as aided clinicians in stratifying patients for specific treatments. For example, patients with grade 1 and grade 2 PANETs are more likely to respond to mTOR inhibitors, while grade 3 PANETs typically do not, and a little more often usually are given more aggressive courses of chemo. In contrast, grade 3 PANETs have shown improved responses, actually, in fact, to etoposide maybe, or capecitabine, as compared to grade 1 and 2 tumors. However, probably the most clinically relevant distinction has to be between grade 3 well-differentiated pancreatic neuroendocrine tumors and a poorly differentiated pancreatic neuroendocrine carcinoma. Patients with resectable, well-differentiated PANETs respond well to surgical intervention with curative intent. And those patients with locally advanced or metastatic disease, medical therapy is the mainstay of treatment, which would include somatostatin analogs, sometimes mTOR inhibitors, alkylating agents, and peptide receptor radionucleotide therapy, or SSTR2 inhibitors. In contrast, poorly differentiated PANETs do not respond to these therapeutic interventions, and instead often respond to therapy that we can give patients for pancreatic ductal adenocarcinoma, specifically platinum-based regimens and or radiation. Moreover, there is a difference in prognosis between G3 well-differentiated PANETs and poorly differentiated PANETs. Patients with G3 well-differentiated neuroendocrine tumors, as seen in blue, seem to fare better than patients with a poorly differentiated neuroendocrine carcinoma in red. Thus, considering the differences in treatment, differences in survival, it's important to distinguish G3 well-differentiated neuroendocrine tumors from poorly differentiated neuroendocrine carcinomas. The problem, however, is the distinction between these two entities can certainly be challenging. Many G3 well-differentiated pancreatic neuroendocrine tumors that again should resemble the islets of Langerhans can demonstrate overlapping histologic features with poorly differentiated pancreatic neuroendocrine carcinomas. For these cases, without additional data other than just the H&E, one cannot really tell which is a neuroendocrine tumor and which is a neuroendocrine carcinoma. But there are some helpful clues, as far as clinical information, pathologic findings, and ancillary studies that can help delineate between these two entities. The clinical features that would favor a grade 3 well-differentiated neuroendocrine tumor would be an incidental presentation with elevated serum chromogranin A levels. In contrast, patients with a poorly differentiated neuroendocrine carcinoma often present with abdominal pain, jaundice, weight loss, pancreatitis, and or diabetes. As far as, new onset diabetes. As far as serum studies, neuroendocrine carcinomas often are remarkable for an elevated serum CA19-9 or even CEA. Again, very similar to patients with pancreatic ductal adenocarcinoma. In addition to clinical presentation, I cannot stress enough the importance of a thorough pathologic examination. Poorly differentiated neuroendocrine carcinomas do not arise from a low-grade component, while grade 3 well-differentiated neuroendocrine tumors often do, and therefore adequate sampling is important. This, of course, can be difficult when dealing with biopsies, but if the patient had a prior pathologic specimen exhibiting a low-grade pancreatic neuroendocrine tumor, that would support a tumor rather than a carcinoma. And lastly, for those that have access to them, I find the limited immunohistochemical panel or even molecular studies to be extremely helpful. When it comes to a immunohistochemical panel, I typically use 4 different antibodies. ATRX, DAX, RB, and P53 have been very helpful in distinguishing between grade 3 pancreatic neuroendocrine tumors and pancreatic neuroendocrine carcinomas. The basis for the immunostains, DAX, ATRX, P53, and RB, is from whole exome and whole genome sequencing results, where distinct genomic alterations were found in both neoplasms. For example, recurrent genomic alterations in the genes DAX and ATRX are exclusively present in well-differentiated neuroendocrine tumors, while RB and P53 are almost always only present in poorly differentiated neuroendocrine carcinomas. Moreover, in a recent study our group has just completed and about to be published, we performed targeted sequencing on over 800 pancreatic neuroendocrine neoplasms that includes over 100 pancreatic neuroendocrine carcinomas. Consistent with prior studies, genomic alterations in DAX and ATRX were highly specific for pancreatic neuroendocrine tumors, especially WHO grade 3 PANETs, while pancreatic neuroendocrine carcinomas were characterized by recurrent alterations in not only P53RB, but also KRAS and P16 or CDKN2A. Of course, targeted sequencing for these genes may not be feasible at all centers due to access and costs associated with the sequencing itself, but these alterations do represent a subsequent loss of their corresponding protein expression, which can be used as a surrogate. So going back to those 2 cases of pancreatic neuroendocrine neoplasms, we performed immunohistochemical stains for the gene ATRX, which once again is lost preferentially in grade 3 well-differentiated neuroendocrine tumors as opposed to poorly differentiated neuroendocrine carcinomas. ATRX is a nuclear protein and relatively easy to interpret. I'm sure many of your neuropathology colleagues are using it for diagnostic classification of gliomas. The case on the left clearly exhibits loss of ATRX within the neoplastic nuclei and retained expression in the stroma, while the case on the right has retained expression within both the neoplastic nuclei and stroma. Therefore, this case on the left is consistent with a well-differentiated pancreatic neuroendocrine tumor. Unfortunately, not all pancreatic neuroendocrine tumors will demonstrate loss of expression for ATRX or DAX. It's a specific antibody or basically a specific biomarker, but it's not 100% sensitive. So the case on the right is still somewhat unclear if it should be classified as a tumor or a carcinoma. And that's where another set of immunostains may be helpful. Similar to ATRX, RB is a nuclear stain, but preferentially lost in poorly differentiated neuroendocrine carcinomas. Once again, the supporting stroma serves as an internal control, and it's relatively easy to interpret that the case on the right is the neuroendocrine neoplasm that shows loss of expression, and therefore consistent with a poorly differentiated neuroendocrine carcinoma, and for this, it would be categorized as a large cell type. Using a limited immunopanel of ATRX and RB, as well as DAX and P53, can be extremely helpful in distinguishing between grade 3 neuroendocrine tumors and neuroendocrine carcinomas of the pancreas. However, these proteins, again, are not lost in every well-differentiated neuroendocrine tumor or every poorly differentiated neuroendocrine carcinoma. Therefore, in my opinion, they should be used to support your presumptive diagnosis on the basis of the patient's clinical presentation and histologic findings. Now, that being said, rendering a diagnosis of a well-differentiated pancreatic neuroendocrine tumor or a poorly differentiated pancreatic neuroendocrine carcinoma is really just half the battle. The next step is staging the neoplasm. Poorly differentiated neuroendocrine carcinomas are easy to remember, in my opinion, as they are staged similar to pancreatic ductal adenocarcinoma, as well as other exocrine malignancies of the pancreas like acinar cell carcinoma. In contrast, well-differentiated pancreatic neuroendocrine tumors are not staged as an exocrine pancreatic neoplasm, which was new for the 8th edition of the AJCC staging system that came out now 4 or 5 years ago. Instead, pancreatic neuroendocrine tumors have their own staging system, which is honestly isn't all too different from the exocrine pancreas. Again, just like the exocrine pancreas, size matters when it comes to T staging. Pathologic T staging is subdivided based on cutoffs of 2 and 4 centimeters, But there are subtle differences at that 2 centimeter cutoff when it comes to comparing endocrine and exocrine neoplasms, specifically deciding between the T1 and T2 stages. The justification for this difference between the exocrine and endocrine neoplasms, as shown here, is that 2 centimeter mark for a pancreatic neuroendocrine tumor is a decision point for many of our surgeons, as based on the NCCN guidelines in the United States, NANETS guidelines, as well as ENETS guidelines. Surgeon has the option to survey a patient considering an incidental lesions are on the rise if they are less than 2 centimeters, and it may follow an indolent course. However, if they're above 2 centimeters, that seems to be the tipping point for when to recommend surgical intervention, as these neoplasms have a higher incidence of distant metastasis, especially among larger tumors. Additional differences between endocrine and exocrine neoplasms include invasion into surrounding organs. Other than being larger than 4 centimeters, a T3 pancreatic neuroendocrine tumor is also defined as invading into the duodenum or the extrapancreatic common bile duct. In comparison, T4 not only includes the major vessels as the celiac axis and SMA or superior mesenteric artery, but invasion into adjacent organs other than the duodenum, such as the stomach, spleen, adrenal gland, kidneys, and others. So let's review the staging system for well-differentiated pancreatic neuroendocrine tumors. A pathologic T1 panet is less than 2 centimeters or smaller than a peanut and confined to the pancreas. A T2 neuroendocrine tumor is defined as between 2 to 4 centimeters in size, or maybe the size of a walnut, but again confined to the pancreatic parenchyma. In contrast, a T3 neuroendocrine tumor is greater than 4 centimeters or extends out of the pancreas to involve the duodenum, as seen here, or the extrapancreatic common bile duct, not the intrapancreatic common bile duct, which would still be considered part of the T1 or T2 category based on size, or T3 in general. Lastly, a T4 neuroendocrine tumor invades the major vessels around the pancreas that include the celiac axis and the superior mesenteric artery, but not the common hepatic artery, which is oddly different from pancreatic ductal adenocarcinoma staging system. A T4 neoplasm could also include invasion into the spleen, as shown here, as well as the stomach, adrenal gland, and so on. End staging is simply the absence or presence of regional lymph node metastasis, and M1 staging is currently subdivided into 3 subcategories based on involvement of the liver. The 8th edition now subclassifies the M1 stage as either confined to the liver, outside the liver, or involving both, by using the designations M1A, M1B, and M1C respectively. This 3-tiered M1 staging system is universally used among all gastroenteropancreatic neuroendocrine tumors. But really, what is the point of evaluating a panet for Ki-67 index, WHO grade, tumor size, tumor stage, and other pathologic features such as lymphovascular and perineural invasion? Well, in effect, we're all trying to determine the prognosis of the neuroendocrine tumor itself. But all of these parameters that I've listed here are really indirect measurements of the tumor and don't actually reflect their pathobiology. Certainly, you have grade 1 neuroendocrine tumors that can metastasize out of the pancreas. And so it'd be advantageous to identify true markers that really get at the heart of the pathobiology of these neoplasms and understanding their true biologic nature. And hence the study of identifying new biomarkers for when it comes to pancreatic neuroendocrine tumors. Now, not surprisingly, I mentioned DAX and ATRX, which, based on our understanding, can be highly sensitive and specific for these tumors as opposed to neuroendocrine carcinomas. But not surprisingly, these markers can also be used as a prognostic biomarker as well. Interestingly, both DAX and ATRX, when they're lost, it leads to a creation of alternative lengthening of telomeres, which results in large telomeres within the tumor itself. It's been well studied in sarcomas and is actually considered a poor prognostic finding. But the question that we and others have had is, can we use these to understand the prognosis of neuroendocrine tumors as a whole? And so we and other groups have evaluated hundreds and hundreds of neuroendocrine tumors, primary neoplasms, and followed these patients over the course of time based on their status of ATRX and DAX as an observational clinical trial. And what we found is that when panets lose DAX or ATRX, patients have a shorter disease-free survival, meaning they do often present with metastatic disease. And they have a shorter disease-specific survival, meaning their survival itself is significantly decreased as those with patients that have PANETs that have preserved staining for ATRX and DAX. Not surprisingly, DAX and ATRX also coincide with several adverse clinical pathologic features like WHO grade, tumor size, and obviously the presence of synchronous and distant metachronous distant metastasis. These biomarkers can be used on cytopathology specimens, and something that is being evaluated in our cohorts right now, as well as in other studies that are ongoing. Now, I've gone through several concepts: nomenclature, pathologic findings, staging, and stains, but I'm not done yet. But this is a good time for just really a brief summary or recap. And so I'd just like to go through that really briefly. First, the differences between differentiation and histologic grade. Again, differentiation refers to the extent of a neoplasm resembling its non-neoplastic counterpart, while histologic grade is strictly for well-differentiated pancreatic neuroendocrine tumors. Remember, it is clinically important to distinguish a G3 neuroendocrine tumor and neuroendocrine carcinoma, which requires consideration of not only pathologic findings, but clinical and ancillary studies. Third, there are some notable aspects to the TNM staging for pancreatic neuroendocrine tumors. In fact, they've got their own staging system. In addition, and somewhat in my opinion, be on the lookout for these routine stains, DAX and ATRX. Although I guess for the most part, many labs don't have them on hand, I do find that it's expanding, and they can be used as a helpful biomarker to discern between G3 PANETs and neuroendocrine carcinomas, and potentially as prognostic biomarkers in the future, in the very near future. And finally, I haven't mentioned this entity just yet, but it should be no surprise to anyone that mixed neoplasms do occur in the pancreas, and mixed neoplasms are now by the WHO called mixed neuroendocrine, non-neuroendocrine neoplasms, which is really, unfortunately, a horrible name in my personal opinion, but it's defined as at least 30% of either component. The mixed component that's non-neuroendocrine could be either ductal or acinar. And these mixed neoplasms, for the most part, the neuroendocrine component is often a high-grade malignancy, so typically a poorly differentiated neuroendocrine carcinoma. Of course, more data is needed to understand the actual pathobiology of mixed neuroendocrine, non-neuroendocrine neoplasms, from which they arise as far as cell origin, and many of those genetic and RNA now based studies are ongoing. Now, before returning to our clinical vignette, I would also like to briefly review the differential diagnosis for neuroendocrine neoplasms of the pancreas, and therefore completing our list of really solid lesions of the pancreas, except for adenocarcinoma. First, solid pseudopapillary neoplasms, which can be solid and or cystic. These are low-grade malignant epithelial neoplasms of unknown origin. They are rare and predominantly occur in young females with a mean age of 25 years of age. Similar to pancreatic neuroendocrine tumors, they are often well demarcated and solitary. Excuse me, I'm sorry, kind of passed through that fast. Microscopically, solid pseudopapillary neoplasms have an insidious growth pattern extending through and around the normal pancreatic parenchyma, which contrasts well-differentiated pancreatic neuroendocrine tumors that are often well circumscribed and separated from the uninvolved pancreatic parenchyma by bands of fibrosis. At a higher magnification, the neoplastic cells of a solid pseudopapillary neoplasm are discohesive and polarized around thin, delicate vessels. A well-known feature of these neoplasms is the presence of intracytoplasmic and extracellular hyaline globules. However, hyaline globules have been well reported in neuroendocrine tumors as well. Therefore, utilizing this feature alone as a specific marker of solid pseudopapillary neoplasms will lead you down the wrong path, unfortunately. What I do, or what at least I find most helpful in performing, in making a diagnosis of a solid pseudopapillary neoplasm, is performing a scrape preparation at the time the specimen is resected, when it's really fresh out of the OR and hasn't touched formalin just yet. Scraping a solid pseudopapillary neoplasm and staining the slides with a quick H&E demonstrates a beautiful branching solid pseudopapillary pattern of neoplastic cells polarized around a thin-walled vessel. In addition, many of the neoplastic cells are free-floating, discohesive, and plasmacytoid in appearance. This contrasts neuroendocrine neoplasms, which show sheets of neoplastic cells rather than papillary configurations with stippled or salt and pepper nuclei. But they too have a plasmacytoid appearance, so cytologic findings alone may be insufficient to separate these two entities. And one of the most helpful findings is the presence of actually mutations in CTNNB1 or beta-catenin, which is for the most part a universal feature of solid pseudopapillary neoplasms. In contrast, pancreatic neuroendocrine tumors are typically absent for these alterations, and therefore beta-catenin can be used to help distinguish between the two neoplasms, with PANETs exhibiting membranous staining, while solid pseudopapillary neoplasms have beautiful nuclear staining. And since beta-catenin is not expressed with the nuclei pancreatic neuroendocrine tumors, LEF1 is also completely absent in these tumors as well. Acinar cell carcinomas can also enter the differential diagnosis for pancreatic neuroendocrine neoplasms, primarily poorly differentiated neuroendocrine carcinomas. An acinar cell carcinoma is a malignant epithelial neoplasm that resembles their cell of origin, acinar cells, and shows evidence of exocrine enzyme production such as trypsin, chymotrypsin, and lipase. These are rare but aggressive malignancies that typically affect older males. Approximately 10% of patients will also present with what looks like peripheral bruising. In fact, their bodies look like they've been in a horrible fight. But this finding reflects what is known as lipase hypersecretion syndrome due to the neoplasm releasing lipase into the bloodstream, which then starts digesting tissue at the end of the peripheral arterioles and thin-walled capillaries. In other words, you can think of this as peripheral fat necrosis. These tumors are often large or massive, easily averaging 5 to 10 centimeters in greatest dimension when they come to presentation. It amazes me how big they can get, but by the time they do come to presentation, they are frequently found in the body and tail of the pancreas rather than the head, but can diffusely involve the pancreas as acinar cell carcinomas invade the pancreatic ductal system and can spread even like a main duct IPMN. Microscopically, acinar cell carcinomas are highly cellular neoplasms that form nodules of tumor cells and lack a desmoplastic stromal response. The presence of a prominent single nucleolus is a characteristic finding of an acinar cell carcinoma and a helpful clue to the diagnosis. In addition, the mitotic rate of these neoplasms can be variable, but more than often quite high. Trypsin, chymotrypsin, lipase, and the new immunostain on the block, BCL10, are all very sensitive and specific markers to confirm the diagnosis of a pancreatic acinar cell carcinoma. The 5-year survival of patients with an acinar cell carcinoma is poor and sadly rivals pancreatic ductal adenocarcinoma. Most acinar cell carcinomas are identified in advanced stage, but a silver lining in these neoplasms is that they harbor frequent fusion genes such as those in BRAF, RAF1, and RET, which are all considered to be targetable from an oncologic perspective. Pancreatoblastomas are another, albeit extremely rare, exocrine neoplasm characterized by both acinar differentiation and unique squamoid corpuscles. These neoplasms have a bimodal age distribution, with 2/3 occurring in children, 1/3 in adults. Interestingly, children with pancreatoblastomas have a much better 5-year survival, 5-year prognosis than adults, suggesting the disease process in these two patient populations may be inherently different. Like acinar cell carcinomas, pancreatoblastomas tend to be large, bulky tumors on gross examination and are also very cellular. Pancreatoblastomas are organized into lobules separated by variable stromal bands. As I mentioned,
So sorry, we are going to interrupt a little bit because the Meet the Expert panel session for 7:30 has to have a hard start. So I just want to thank, you can see Dr. Singhi there. We are all very, very busy, and I'm delighted that he agreed to give a talk here. And as you just heard, for the past 40 minutes or so, he's a fabulous speaker, one of the leaders in pancreatic pathology in the world. And I'm really delighted that he found time to be with us virtually, hopefully in person sometime in the near future. If there are any questions from the audience, please state your name and ask the question. If you are joining us virtually, please put it in the chat box. And if nobody has a question, I have a couple that I want to ask Arthur. So I think Arthur needs to be unmuted so he can, yeah, there you go.
Thank you.
So while we wait for the audience, Arthur, I had a question about the proliferative index reporting in biopsies, and I know that you alluded to it a little bit, and we always have this a little bit of a funny situation where you have a grade 2 in the ileum or the pancreas, and then you have a liver met, and we do it because we are reporting these Ki67 indices, and then you report it as a G1 because it's not really representative of the lesion, and then it creates a situation where something metastasized the liver, and suddenly now is supposed to have a better prognosis because it's now a G1 instead of a G2. Do you report? I mean, yes, if it were a G3, it would help, but do you report the proliferative index in biopsies routinely, and how do you handle do you refer to the previous resection that it was a G2? How do you handle it?
Yeah, no, I have the same issues as well. And the way we would typically report biopsies, as I mentioned before, was the fact that we always put that comment in sampling, and that we may not have sampled since Ki67 and mitotic can be quite heterogeneous, and we don't necessarily get the leading edge of the neoplasm, which tends to have a higher Ki67 or mitotic index. We have that issue of just sampling itself when you get that core needle biopsy. The caveat with Ki67 is that it's not always reflective of the biology, and that certainly we can have tumors where they can have a slow growing or a lower Ki67 because most of these cutoffs are all really arbitrary. The 3 and 20%, honestly, they were arbitrary cutoffs made over a decade ago, where we really didn't have great data at that time, and we still don't have great data at this time enough to justify changing the cutoff or modifying them. There have been some interesting studies from Italy as well as in other places in Europe to present data to modify the cutoffs for Ki67 to either use a 2-tier system where we're using a 10% cutoff, or to go back to and continue with the 3-tier system, but modifying that 3% to now a 5%. And that may, in theory, make it easier for all of us when we deal with G1s versus G2s with that 5% cutoff. Nevertheless, how do we use that data from a prognostic standpoint? When it's metastatic, prognostically, it's kind of a moot point. But our oncologists are trying to use that data to help cater to therapy. And that is still about a moving target, I would say. I'm not sure if it's going to be truly useful, because really when it's metastatic, cat's out of the bag. They really are going to just try to attack that tumor with different modalities.
And then another quick question I had for you: in resource-limited countries or institutions, if you had to recommend a kind of a minimal sort of panel for pancreatic endocrine tumors, I mean, I know that you guys have been at the forefront doing ATRX, DAX, immunohistochemistry, and we do it at Memorial as well. So between those and RB, where you may be pushing for a diagnosis of a poorly differentiated neuroendocrine carcinoma, what would you suggest that people should try and have to help them in daily practice?
So yeah, ideally it would be great to have ATRX and DAX. Currently with supply chain issues, we are actually having issues with DAX and getting enough DAX antibody. And that's going to unfortunately be probably the issue that we're going to be dealing with for the next coming year. There are new antibodies coming out, and one of the things that we lost when we started doing molecular testing is we lost the idea or the understanding of lineage in our understanding of lineage. So neuroendocrine tumors conceptually and more now with data, we know that neuroendocrine tumors are arising from the islets of Langerhans, and we know that the islets of Langerhans for the most part have alpha cells and beta cells, and when neuroendocrine tumors arise, they typically arise out of alpha and beta cells as opposed to the rest of the cell types that are within the islets of Langerhans. So we can use cell lineage markers from that point of view, in contrast to neuroendocrine carcinomas, which are more than likely arising out of ductal or acinar component, and it's really a transdifferentiation from that. So if we kind of go back to what we know about islets of Langerhans and the cell of origin, insulin, glucagon, those stains are actually quite good. Our lab has now moved on to looking at transcription factors because nuclear stains are much easier to interpret than cytoplasmic or even membranous stains. So alpha cells are actually stained with ARX, which helps motivate those in basically germ cells when they're turning into islets into alpha cells. And beta cells are basically transcriptionally programmed by PDX1. And so we've now encompassed those antibodies, ARX and PDX1, to help with alpha and beta cells respectively. And those antibodies are really widely available, and that for us, at least in the research setting, now turning that into the clinical setting has been quite simple for us.
Thanks very much, Atul. That was great. So thanks for joining us. I know you're at work and probably rushing off to do something. So thank you very much. And we will now move on to the next session. And for the audience who's there in person and virtually, we'll have the Meet the Expert session now, because we see them all here online. And then you can have a little break after the session. We'll try and keep it quick. And I just want to start off by thanking the speakers now that you see on the screen, who not just on my behalf, but on behalf of the organizers at SUPGI Lucknow, they're all very busy people in their daily practice, and to find time to record a lecture, and it takes a lot of effort. And so we really appreciate and thank all of them. Dr. Khan, as all of you know, he needs no introduction. He's been a regular at Lucknow. Actually, you know, I was the first time I heard him, I was a trainee at SUPGI, and he spoke on parathyroid then, and he spoke on parathyroid last night for us. So it was great to see him. Dr. Tischler and Dr. Gusai, and we share some heritage from, because I trained at Tufts too. Dr. Tischler was one of my faculty members when I was a resident trainee. And then Peter, I just emailed him because we had a little glitch. The weather played spoil sport yesterday for the organizers, so they had to move the venue. They had torrential rains, you know, which is unpredictable now. You never know when that happens. So they ran a little late. So Peter's lecture will be played tomorrow, but I'm delighted that he is here and managed to join us in person for the discussion. So thank you all very much. And I think there were some questions. I was listening actually to Dr. Khan and Dr. Gusai's lectures last night. And I had a few, but then there are some from the audience that they forwarded me. So the first one is, Ashraf, for you, a question that you spoke a little bit about the atypical parathyroid adenomas, and the question to you was, have you seen progression of these lesions to an overt parathyroid carcinoma on follow-up?
Thank you, Amitav, for the introduction, and thank you for hosting this. Yes, Sanjay Gandhi Institute is where we met first, you know, when you were there at the training in 90s, I think. So, I have a very close relationship with Sanjay Gandhi since then. I've been going back and forth, and we did telepathology then, and we're just doing it again here. So with regards to atypical parathyroid tumor, or what they're called now, according to WHO 2022, we used to call them atypical parathyroid adenoma, which really implied that it's a benign tumor. But from the beginning, it's been thought that they really are tumors that we don't know how they're going to behave. So they need to be, followed up closely. And I remember a paper from Ron Delalis, I think this was the early 2000s. He had a series of about 20 or something cases. And the follow-up in that study, I remember, was, I think the median follow-up was about 8 years or 9 years. And in their study, they didn't find any progression of atypical adenoma to a carcinoma. I have not seen it personally. I know, Ronnie, I know you may have more experience at Memorial if you've seen any cases, or Art, or Peter, but I've not seen any personally tumor that we call atypical adenoma. I've been in practice in the same institution for more than 25 years. I would have come to know about that case that we call atypical adenoma 20 years ago, and now patient comes back with a carcinoma. I don't know, Ronnie, you want to make any comments? Or?
Well, basically, Ashraf, you're right. We call this atypical parathyroid adenoma, or now atypical parathyroid neoplasm. But honestly, I have never seen one, and I think a good study, a well-designed study, is needed here to answer the question, because it creates a lot of anxiety on the part of the clinician and the patient, because ask me, okay, you say there is a small risk of recurrence, but what's the number? I said, yeah. So I think it's very important to do a well-controlled study so we can answer the anxiety. Yeah, I haven't seen one.
I think what I like, just make one more point on this.
Sure.
I think what this might do, this new approach to these parathyroid tumors, as recommended by the WHO 2022 group, is if you start looking at Parafibromin in all these tumors and see if they help in predicting the progression of these tumors. So,
it's a bit of a slippery slope. I have to say, we were asked yesterday. COVID has done one wonderful thing for us, in that when we first couldn't meet in person, we had to do our intra-departmental consensus conference by Teams. And what we decided to do at that point was invite all of our former fellows to show their tough cases. So now we do a weekly conference that's national. All of our former fellows that are across the US show their tough cases, and we talk about it. And our discussion yesterday ended up focusing a bit on Parafibromin stain in these tumors, because it's recommended to do them now in all of them. And I have to say that, our interaction with the Parafibromin immunostain has been sketchy, to say the least. And I'm a person who doesn't believe in it. So I have to say that I'm a skeptic at that point in time. So I feel like, this recommendation actually in some ways is encouraging research rather than actually anything that may be beneficial for the patients at hand. And Ashraf, as both you and Ronnie have pointed out, you actually haven't seen a case that had this progression. I've seen zero also. My experience is somewhat less, but it's been about 20 years. And I haven't had this case happen. And I tend to think it ends up being somewhat subjective. So I have to say that, sort of among endocrine pathologists, I tend to be at the fairly far conservative end of making these calls, because I feel like, to make patients overly concerned about something that potentially or highly likely is nothing is kind of, where I lean. I think we need to be more concerned about parafibromatosis than progression from an atypical parathyroid tumor. Yeah.
So if you don't like Parafibromin, Peter, what do you like? Do you like MIB? I mean, the GI and pancreatic neuroendocrine world has moved to these very rigid, and I mean, it's been reproduced over and over again. The less than 3 to 20, more than 20. Is there something else that you like using instead of the IHC recommended?
Yes, I like an H&E. I like a nice H&E and a clinical history. And
I'm sure the audience would love that.
Yes, and I don't feel necessarily that any adjuvant testing is of particular use in this arena.
Sorry, Artie, you were going to say something?
Well, I did. We have fewer cases of atypical parathyroid adenomas probably than these larger institutions. All right, but I've never seen one progress to malignancy either. But on the flip side of the coin, how many cases that we call parathyroid carcinoma, based even on conventional histology, go on to become metastatic cancers? So if you remove these things when they're early and they're small, it's hard to know what you're really dealing with by I think any of the criteria that we currently have.
Hi, Dr. Amitabh. Samir this side from SGBJ. How are you doing?
Hi, Samir. I think you had a question for Dr. Singhi. I think he's still online. Atul, are you there?
We have a few questions from our side. How has been your experience with the EUS guided FNB needles for biopsy? Are you satisfied with the yield that you get with the EUS endoscopic ultrasound guided FNBs?
And you're talking about pancreas, I assume, and Atul can answer that because he does a lot of that stuff.
Yeah, so I think that with the next generation Charcot needles by Covidian or the Boston Acquire needles, those have done a much better job with getting us actual tissue to evaluate for both immunohistochemical studies and molecular studies. I would say the old Procore biopsies have been extremely bloody, in my opinion, as well as some investigators or some pathologists or gastroenterologists, for some reason, use a Moray forceps for neuroendocrine tumors, which has been also extremely bloody, in my opinion. But for the most part, with the newer needles that come out that have a beveled end, they've done a great job in giving us a good amount of tissue.
Thank you.
I would second that. I mean, there has been in the last 5 years, I mean, the number of biopsies on which we say not enough tissue, I mean, has plummeted. I mean, for any pancreatic mass, there's hardly a case now where we need to ask for a second biopsy. We can usually make a diagnosis for all solid lesions at least.
And another question is, what has been the strategy of gastroenterology in US regarding non-functioning tumors in pancreas which are less than 2 centimeters? I mean, do you need to take tissue always, or you put them on surveillance, or if you feel the characteristic on endoscopic ultrasound decides what to do, whether to put in a needle or just do surveillance?
Yeah, I think that's difficult for the most part. There are many gastroenterologists that can do different things, and insurance also plays a role. So obviously with a neuroendocrine or a lesion that's hypervascular on imaging and is less than 2 centimeters, most of our gastroenterologists are not even biopsying them. They know that they're a neuroendocrine tumor, they're well circumscribed. It's only those patients that are young that typically that they do really want to biopsy that, because if they're young, it's a question of MEN1 syndrome and that, or maybe an attenuated MEN1 syndrome, or if this is a patient that's going to have to be on long-term surveillance, the patient really needs to be given options, assuming that they truly have a neuroendocrine tumor, and that's where a definitive biopsy diagnosis has to be made. For some gastroenterologists, and this might be a little more investigational, it's to use dotatate scanning. And so we know that dotatate scanning itself, or something called NetSpot, has definitely engaged a lot of our oncologists, because they can use that as an ability, as a tracer, to look for SSTR2 and SSTR5 expression, which is often expressed on well-differentiated neuroendocrine tumors. The caveat with using dotatate is that other cells express SSTR2, like plasma cells. So plasmacytoma will be positive on a dotatate scan. You can also see other benign lesions like a serous adenoma in the pancreas can actually have positive dotatate avidity. So that is a bit of a tricky. I know that some gastroenterologists are playing around with that, but for the most part, it really does kind of come to the point of, first of all, clinical presentation, and then determining whether really a biopsy is needed for that patient. If it's an older individual, 80-year-old, 85-year-old, well-circumscribed lesion, less than 2 centimeters, I don't think anybody's going to try to biopsy that patient.
Thank you. Hello, everyone. Now, I have a question and a comment both to Dr. Ashraf. You were talking about atypical parathyroidoma. Now, that terminology had been dropped long back. However, we used to use the term parathyroid adenoma with atypical feature. But recently, I published a series of cases where I found little atypical features, and the mitosis were a little on the higher side. And on doing Ki67, the cases which were having atypical features with more than 5% Ki were classified as minimally invasive parathyroid carcinoma. And out of 9 or 10 cases, 2 cases expired as well. So maybe something like that has to come up in parathyroid carcinoma also, on the lines of minimally invasive follicular carcinoma. Maybe it's more experience on them, but we saw more than, I guess, 50 adenomas, of which only 10 turned out to be like this. So any comment on that aspect or experience on that?
I'm sorry, I missed the last part of what you were saying. The question you were talking about.
The comment was that in my experience, where we have studied more than 50 parathyroidnomas, of which 10 were behaving a little erratically with very high parathormone levels, and they turned out to be having a Ki67 index of more than 5%. So I classified them as minimally invasive parathyroid carcinoma rather than calling them as parathyroid adenoma with atypical features. Atypical parathyroid is no longer used.
So if I can understand correctly, what you're saying is you have a group of parathyroid tumors. The question is it carcinoma versus atypical parathyroid tumor? And Ki67 was more than 5%, you said, in some cases?
Yeah.
I think that's pretty high, actually. If you look at the criteria for carcinoma, if you see mitosis, which is only like 5 in 50 high power field or 10 millimeters square, and if you see more than, but you have to be careful, is it really more than 5%, or is it, again, I go back to Peter saying that look at the H&E, see what you have histologic features of carcinoma, like, and a lot of the time surgeons will tell you, that it was difficult. I think I see Dr. Mishra there, Saroj Mishra. Is it SK Mishra sitting on the? Yes, I think he can tell you that when he operates, explores the neck, they will tell you that if it's a carcinoma or not. That's very helpful actually for us as a pathologist. But Ki67, whether it's 5 or 6 or 4%, I think one has to be really careful with that. But you look at other features on histology. Is there vascular invasion? Is there invasion outside the parathyroid or other features, necrosis, mitosis? So I think you put them all together, and if you still cannot find those unequal features of carcinoma, it's better to call it atypical parathyroid adenoma if it's really not classical carcinoma. I don't know, Ronnie or Peter or Art.
Bringing this up because they were showing cellular atypia, but few of them showing capsular invasion also, and occasional vascular invasion. And the histological features did show anaplasia. That's how I performed Ki67. And 2 of the patients expired as well. That's why I'm saying that maybe this term would come in near future. Those cases who behave little erratically or aberrantly than the usual parathyroidnomas.
Yeah, I think if you have capsular invasion, if you have vascular invasion, and cytology can be really very monotonous in these tumors. They're not much pleomorphism, but it looks like what you see is what you're talking about is I would call it a carcinoma if you have those features that you're describing.
Hi, good evening.
Let's move on a little bit to the other questions submitted last night. One was for Dr. Gusai. How do you differentiate between oncocytic NIFTP and oncocytic adenoma?
Hello, Antal. Can I interrupt you?
Yeah, sure.
Dr. Gusai wants to ask. This is Professor Mishra, SK Mishra. So I think Masarstop knows me very well. So I just want to give some clinical perspective for the parathyroid in particular, because my career started with non-localizing days. We depend only on calcium and hand X-ray. I started my training from those years, and I landed up with all advanced investigation like your localizing scans, all these things, intraoperative QPTH, all these things. So I've seen the journey in the care side. And the other thing is the phenotypical presentations of hyperparathyroidism, and in some cases have been shared when Professor Ashraf Khan was here in many of these postgraduate courses, endocrine pathology. That is the vitamin D nutrition relationship with the hyperparathyroidism. So we used to see very large tumors, and which are sometimes confused with carcinoma for Western colleagues when they come here to operate patients actually. So that's one thing I wanted to bring in for your knowledge. Now we have been correlated with vitamin D deficiency, and it has come out very well in the book on parathyroid by John Belichikian, second edition. You'll find the presentations from the other different countries. One is Brazil, China, and India together. So you'll find very advanced bone disease with the large tumors and vitamin D deficiency. That's one aspect. Second aspect is that we have faced very bad hungry bone syndrome. When you operate these patients, they severe hungry bone syndrome. And now also we see those patients. I think Professor Ashraf Khan presented a case with very advanced parathyroid. It's very unusual to see in the Western country. Third aspect I'd like to see, we have done a study of last 3 decades, how these presentations of the primary hyperparathyroidism has evolutionized. Now we don't see so advanced disease. We see the almost similar pattern like that we see, except that we still detect the symptomatic phase, not with the biochemical screening that you see there. So the third aspect. The fourth aspect is some parathyroid carcinoma. We see such large tumors. We have done a kind of comparison. We say that all the 3 clinical criteria to say that parathyroid carcinoma like palpable tumor, high calcium, we see in the benign conditions like primary hyperparathyroidism. So these are some experiences that I have to share to the group here as well as amongst all of you. You don't see such kind of thing in the Western world. Thank you.
Thanks, Dr. Mishra. Sorry, Ronnie, I was relaying a question from last night about oncocytic NIFTP versus oncocytic adenoma, and does it really matter now that we're kind of switched our conceptual understanding, which you nicely illustrated last night. You're muted, Ronnie.
You're mute, Ronnie. Can't hear you, Ronnie.
You need to, yeah, there you go.
Okay, you hear me now?
Yes.
Okay, yeah, so basically differentiating oncocytic NIFTP, from oncocytic adenoma is based only on the nuclear features, and obviously in practice, and obviously this is subject to a lot of interoperability because the oncocytic cells in oncocytic adenoma, what used to call Hurter cell adenoma, have overlapping features with the nuclei of NIFTP, like for example, we can have irregular nuclei and even grooves in oncocytic non-papillary tumor. I use the nucleoli usually in oncocytic tumor, oncocytic adenoma. You have a large nucleolus that is central, while in the oncocytic NIFTP, it's smaller and at the periphery. However, in the real world, it doesn't really make a difference, thank God. It's just an academic exercise because the treatment is the same. Once an adenoma, oncocytic adenoma, or an oncocytic NIFTP resected by lobectomy, the patient is done. Now, I have to tell you that we published a paper on oncocytic NIFTP. I was surprised to see that the mutation profile was different from oncocytic adenoma. We had much more RAS mutation, for example, than oncocytic adenoma. But I have to admit that it's, of course, a very challenging exercise on a daily basis based on the H&E, but it's not that important clinically.
The other question, again, for thyroid was, given what you said about you sort of moving away from papillary-like nuclear features to encapsulation and the importance of invasion, our focal presence of papillary thyroid carcinoma like nuclear features, is it important, and how should we handle it?
Okay, so the question, I guess, is if if I understand, in an encapsulated follicular lesion, how much maybe a papillary nuclei you need. There is really no consensus about endocrine pathologists. Some people have published papers where they chose a random number of 20%. And in my practice, if I see nuclear features is more than in more than one area, and usually there are in multiple areas, then the tumor fall into that category where you have to decide whether it is a NIFTP, whether it is a follicular event with invasion. Again, really, here the engine of our outcome is invasion, and especially vascular invasion. This will really make a difference in the lives of the patients and not the nuclei. So I think it was a good idea to shift our attention from the nuclei to invasion.
I just want to make a comment because I think Ronnie has hit the nail on the head, both in his discussion of the oncocytic NIFTP and the idea of the nuclei. You know, when we first started having this discussion, about 10 years ago, we were focused on this, and part of it ends up being, I think, is a bridge, because everybody tends to be fixated on the nuclear features. Is it enough? Are there enough? And as it really is turning out, it doesn't matter. The molecular profile combined with the look for, the finding of invasion ends up being what's most important. And even when we started first having the discussion about what to call NIFTP, it really ends up being, in my mind, a type 1 versus type 2 adenoma, one having nuclear features and one doesn't, but they're both benign. And the issue ends up being cytology, because what happens when the cytologist puts the needle in and sees nuclear atypia, and the question ends up being the atypia versus suspicious for malignancy versus positive for malignancy, and what does that imply for sort of the liability of the cytopathologist in making that diagnosis? And I think that once the pathology community and then the community at large becomes more comfortable with nuclear atypia not signifying malignancy, then we'll actually start moving more toward rational, correct terminology, away from things that might sound a little bit silly, but that are intrapathology terms that are helpful for pathologists rather than for the community at large. But what Ronnie's mentioned about the findings of more RAS mutations in tumors that typically don't have prominent nucleoli versus not, those things end up being things for the endocrine people to hash out and have, very floral arguments amongst ourselves, but that aren't necessarily as helpful for people.
And do you think that this conceptual change, which is huge, I think, listening to Ronnie last night, has percolated enough and adequately into the community practice yet, or it still an ongoing process, and just sort of the overdiagnosis and overtreatment has been this sort of the rule of the day for the past so many years. So do you think that it's the new conceptual shift has made its way to understanding of surgical pathologists?
It's political, right? So you can see the shifting practice. Like, look at the politics of the world right now. So it's like every time something like this happens, you say you wait for the old people to die, and then you can have a shift in how you think about these issues. It's sort of where we are right now, is that there are many people who have seen a lifetime of experience that have fixed beliefs that are not open necessarily to having changes. And the only way it's going to be changed is if we actually start talking about them now. The next generation is aware of it. And then when the next generation rises, that it's not a big deal for them. It's sort of like, oh, gay marriage, you know, it's like you have to wait for people to get a little more comfortable with an idea that may be horrific to them, for it to function. So I think that, you know, 10 years from now, so the answer is we're not there yet, Amitabh, but it is possible that that 10 years from now we will be.
No, but
and
I think
no
it's helpful for the audience in India to get this perspective, because I mean, you know, there are different ways we practice medicine in the US and in the West. I mean, there's different considerations in you know, medical malpractice litigation, and all those things are not so much of a concern there. So that's precisely why we need you on panels, Peter. So thank you for that. The other sort of, again, sticking to thyroid, another question which actually I had listening to Ronnie last night was that the non-invasive and invasive encapsulated tumors that you were talking about, Ronnie, do we think of them as two distinct histological entities, or sort of two stages of the same tumor? You were showing this nice cluster diagram yesterday where these tumors clustered separately from all the other in the, I think, the TCGA PTC. So did the completely encapsulated and invasive one, do they cluster together, or are they separate?
You're muted again, Ronnie.
In the TCGA, we didn't go, we didn't go into the detail regarding encapsulated tumor versus not. But so if your question is whether encapsulated tumor have a tendency to be, for example, RAS, I think, I don't know if I'm answering the question, but most encapsulated tumor, whether are non-invasive or invasive, will have RAS mutation, except those encapsulated classical papillary thyroid carcinoma that have a lot of papillae. So the RAS box, in a sense, will include, in my experience and based on my study, all the encapsulated tumor, except, of course, the Hurtos cell and the encapsulated classical papillary thyroid carcinoma. I don't know if I answer. Now, the question whether the invasive encapsulated follicular vans start from non-invasion, intuitively, maybe it's true, but there is no, we cannot prove it in the thyroid, because it's not like in other organ where we see the organ, like in the mouth or in the uterine cervix. I don't know if I answered right.
No, I think that's helpful. And then there was one, again, Ashraf, for you on the parathyroid in terms of sort of frozen section reporting, you know, when we get these specimens from the surgeons, and what is the kind of terminology you use? I mean, one is just identification of the parathyroid, and then I think there's some institutional nuances how people report them, whether it's cellular, hypercellular, or just parathyroid tissue present. Could you comment on your practice? And then I'd like Art Tischler and Peter to weigh in too. Can we mute Dr. Khan? Unmute Dr. Khan, please.
Okay, thank you. With regards to intraoperative evaluation of parathyroids, I think obviously, as we all do, we weigh the gland, you know, so the weight is important, and also we look at the histology if it's hypercellular. I never try to diagnose it's adenoma or a hyperplasia based on histology on a frozen section, you know, because you may not see. And I think, to be honest, it doesn't even matter now, because if you have multiple glands that are enlarged and hypercellular, you reported them as such, give the weight and say they're hypercellular. and surgeons rely more and more on intraoperative, PTH levels. So like the case I presented, we just had it recently that the surgeon, the baseline PTH went down, but still it was higher. And on imaging, they were suspicious there are more than one gland. So I think as long as the baseline PTH comes down to normal after removing the parathyroid, whether it's 1 or 2 or 3 or 4, I think that's when they stop the procedure. The question is, if they start on one side of the neck, if they have to go to the other side, that may make a decision at that point if imaging was suspicious and the PTH is not really coming back to normal. So I think reporting wise, we don't want to make a diagnosis of adenoma or hyperplasia, unless it's really, question is a cancer, which is very obvious, So that's how we report. I'm interested to see how others do.
Well, I agree with everything that Ashraf has said. The only points I would add are that exactly what you say depends a lot on what the surgeon is seeing and on what they're asking and what they give you. Because if you get a very small piece of tissue, it's very difficult to say to even say that what is in that piece of tissue is really going to be reflective of the whole gland. And in that case, I would probably just say parathyroid tissue present. If it's a big piece of tissue and there are a lot of cells, then I would probably say hypercellular.
Obviously, the first thing is you have to confirm it's parathyroid, right? Because you can have a piece of thyroid that can look like parathyroid, or a parathyroid that can look like thyroid. So that's also important.
Yes.
I've sometimes deferred that to permanent section to say that I need an immunostain, but I mean,
how did that go?
They're fine. That's what I'm saying. They're used to it. You listed the 3 things, talking about either parathyroid present, cellularity of the parathyroid, etc. It's like that. For us, we're essentially providing therapy, right? It's like mental therapy for the parathyroid surgeons, and sometimes we're actually providing that therapy while they're waiting for the IOPTH to come back, right? They want something to do in the operating room while they're waiting for those levels. I actually have a review article that's now 3 months overdue that I have, because the residents I had that worked on it did such an extensive job. It reads more of a book than a review article about what to do intraoperatively, and then went into the differential of parathyroid carcinoma and everything else. So it really, we can't do much in the frozen section lab, essentially, except identify it. Especially, if it comes out as a 5 centimeter mass, there may be room for discussion about it. But at the same time, it's like this is a clinical pathologic correlation that the frozen section is not going to change for the most part, right?
So we have one more question. I think this one for Art, for you, about the presence of GISTs in these syndromic tumors of the paraganglia. Does that suggest, you were showing this nice embryogenesis diagrams, does that imply that the interstitial cells somehow of Cajal somehow share embryologic derivation from the same cells?
I don't think there is any evidence so far to suggest that they do. Interestingly, when Cajal described and illustrated those cells, he thought they were neurons. But I think most of the evidence to date suggests that they are not, and that they actually are in some way derived from a precursor of the intestine itself.
Thank you. So I think we are at 8 o'clock now, and the audience needs a break. Dr. Jain, do you want to say something, or should I go ahead, thank all the experts who kindly agreed to be here with us in person, even though virtually?
So, on behalf of organizers, Dr. Vinita, myself, Dr. Manoj and Dr. Krishnani here, and my whole department, we are wholeheartedly thank all the experts. They have made this conference so beautiful, and
thank you all we are so delighted to have the experts in the field with us. We have been reading your articles, and it is really
Very nice to have you all here and see you interact with us. And we hope that we'll be able to put in questions and keep on asking from you whenever we have issues that are related to our diagnosis or our tumors where we deal with. Because in SGPGI, we have a very good department of endocrine surgery and endocrinology. And as a pathologist, we get to see most of these lesions that you've talked about. So it is really nice to have you here. Thank you so much. All of our participants and everyone has gained a lot from it.
Well, Dr. Mishra is online, so I mean, I think you should get all these experts that you see on the screen. This is who's the who of endocrine pathology, so you should get them to Lucknow in person and host them there, and I think it'll be a great future event at some point. So thank you all again, and I know that all of you have to rush off to your daily. At least it's morning here, and I think we'll end this session now. And thank you all once again very much from my side as well.
So I wish next time in person we would like to invite everyone in India. This time we couldn't. Dr. Ashraf was trying, but he couldn't make this time. So I think next time you all try to come here in India in person. That I wish. Yeah. Dr.
So, thank you to everyone, and we have learned a lot. And I know we have still many questions to ask, but because of the time, we are not asking you at this moment, but we will keep on writing and we definitely want to interact with you. Thank you so much for such a good information.
So I'll also log off, Dr. Jain, and then I'll log back on for the next. Thank you.
Thank you so much.
I think we can break for some time for 10-15 minutes. Then next talk Dr. Mamta will be taking, and Dr. Amta will be taking on my name, and yes. So in short, just 20 minutes they will be taking their talk. Then we'll be finishing today's program. So tea break is there just for 10 minutes.
मुझे पता है म्यूट कर लो ना रुक जा वो आ मैं ये कह रही तुमको इतनी ज्यादा वो क्यों हो रही है
मैम
Hello, Dr. Mamta. Hello.
hello hello can you hear me
Can hear you.
can you hear me clearly
Yes, ma'am, we can hear you.
oh okay thank you so I'm just let me know when we need to start because I may have not heard you a little bit before this.
Oh, okay.
With the settings, yeah.
So, shall we start?
No, take your time. There's no rush.
Ma'am, you can start.
Oh, okay. If you're sure, then let's start. Let me just minimize this. Okay, so actually for you guys, it's good evening, everyone. I'm sure that you have heard lots of very, endocrine lectures today since morning with a very deep dive into molecular of all those endocrine organs. So now it's still for adrenal. It's a big endocrine organ and it's a very important one. So I will be talking about the adrenal cortical endocrine lesions today. And I tried to make it more simplified version of what the advances are with some of the background knowledge. And I'm sorry, as I couldn't hear you a little bit before this start, those who do not know me, some of you obviously know me. My name is Mamta Gupta. I'm one of the genitourinary and GYN pathologists at Beth Israel Deaconess Medical Center in Boston. So this is a common organ which we receive in our practice. We see a lot of adrenal resections actually on our genitourinary bench. Adrenal gland, as previously known as suprarenal gland, as this diagram shows, is a couple of glands which are located on the upper pole of the both kidneys. Grossly, the adrenal glands are triangular structures, and they just have two portions of this gland are cortex and medulla, and you've already heard about the medulla. That's the center part of the gland, which is brown in color on gross examination, and the outer cortical portion appears tan yellow. Here's something to see about what the layers of the glands are, because they are important. And when we discuss the lesions of the adrenal gland, there are 3 layers of cells in the cortical region. As you probably all know, that they are called glomerulosa, fasciculata, and reticularis, and they all have one important, hormone function, from mineralocorticoids to glucocorticoids and androgens. So cover a lot of actually hormones which are very important. I'll skip this slide. This is just a very quick reminder of what these hormones are important for, and you'll see many of our actually daily functions are dependent on this. Why they're important for a surgical pathologist? Because the adrenal glands present to a surgical pathologist with mass lesions or enlarged glands. In autopsy reports, it's reported that up to 5% of our population has some kind of adrenal nodule. And to our clinicians, then how do these lesions present? Again, with the same thing, that depending on what hormone function the mass lesion or the enlarged gland is presenting, that is the presentation is based on. So for example, some of these patients present with hyperaldosteronism, which is the mineralocorticoid aldosterone excess, and these patients, as you will discuss probably in some other lectures later, that the presentation is usually with headache, palpitation, weakness, polydipsia, polyuria, hypokalemia, and increased cardiovascular disease. Similarly, the hypercortisolism presents with the typical features of Cushing's syndrome, and virilism, rather rare presentation of these mass lesions, is just the virilization or feminization of an individual. And it's actually more common in carcinomas, adenocortical carcinomas, which is itself is a very rare disease, or in the pediatric adrenal tumors. We don't see this presentation in adult patients. And some of these mass lesions actually are incidental findings, which are detected on imaging for some other reasons, or they present with the mass effect. That means these are non-functional lesions. These patients do not have any excess of hormones, and they are just detected either as simply the symptoms of a mass effect or incidental findings. And as you all are familiar with this, I will skip this slide also very quickly, that these excesses of each of these hormones actually have a specific name, like a Conn syndrome, Cushing syndrome, or adrenal virilism, as we just discussed. And the lesions which we are talking here, very briefly, their nomenclature is just adrenocortical hyperplasia, nodules, adenoma, or carcinoma. These are the primary adrenal lesions on which we will be discussing today, because these patients can present with the similar hormones syndrome, but lesions may not be actually located in the adrenal cortex, and that's not the topic of discussion for this talk. So the important diagnostic tests done for these patients are plasma cortisol, aldosterone levels, ACTH levels, and aldosterone to renin ratio, suppression test of different hormones, and adrenal vein sampling. This is an important test, and I will elaborate why this is important for a pathologist to also understand what the adrenal vein sampling lateralization means. This test actually tells a clinician whether lesion is unilateral or bilateral, and which side. The imaging studies are very important. Most of the adrenal cortical lesions are benign, but there are some imaging findings which can point towards the more malignant nature of the lesion. So let's start with the case discussion. The first case is a 30-year-old female presented with a headache, anxiety, attacks, palpitation with feeling of chest compression, no weight changes or realization. So in briefly, we can say that this is more of an hyperaldosterone type presentation, and the examination of this patient revealed hypertension and hypokalemia. And on imaging, a 1.7 centimeter nodule was found on the left side of the adrenal, and a left adrenalectomy was performed. Here you can see a grossly 1.7 centimeter lesion, which is tan yellow in color. On microscopy, this lesion showed a compressed adrenal cortical rim on the periphery and the central large nodule, which on a higher power showed a typical adrenal cortical fasciculata layer of cells. So these are packets of cells which are large and vacuolated, but these are fine vacuoles. They resemble the immature fat because these are steroidogenic type of cells. So fasciculata cells have very fine vacuoles, centrally located nucleus, no atypia. So the diagnosis on this case, as most of you know, would be the adrenocortical adenoma. What are these adrenocortical adenomas? These are just the nodular lesions, by definition, more than 10 millimeter in size. So there's a cutoff of, and it's an arbitrary cutoff of 1 centimeter lesions more than 1 centimeters. If they're single or sparse nodules, would be called adrenocortical adenomas. And most of the adrenocortical adenomas present with the hyperaldosteronism, and this, if they're usually unilateral, but if they are bilateral, then they are enriched with the cortical hyperplasia of the background glands and microadenomas. So microadenomas are less than 1 centimeter in size. Cortisol producing adenomas are mostly unilateral and small, and they present with the cortical atrophy of the background gland. These lesions, as I just showed you, can be yellow, orange, or tan in color, and they microscopically show a mixture of different kinds of cells. So here are 3 examples of actually Cushing syndrome related cortical adenomas. And you can see on the very top that this lesion looks very tan in color. Typically cortisol secreting lesions are described as tan dark in color, which can mimic some other lesions in the adrenal. And the other 2 are from orange to yellow in color. Really, there is not a very tight correlation with what the lesion secretes and the gross color of the lesion. This is just an example of a non-functional cortical adenoma, and this is also very tan bright in color, and you can see a small area of hemorrhage, which can also show degenerative changes of different kinds, which I'll show you in a minute. Just the higher power of the same lesion, and what I mean by mix of cells is that typically you will see these fasciculata type large microvacuolated cells, or you can have a mixture of cells where the cells can be, as you can see here, are more clear vacuolated, or in the center the cells look more eosinophilic and compact and small. And this is just the higher power of the central portion of the eosinophilic cells. Sometimes the cells resemble just the reticulous layer of the adrenal cortex, and they can be very small blue round cells with the scant cytoplasm with intervening vacuolated cells. And sometimes these lesions are very dark in color because of the increased pigment in these glands. As you know that these go through that melanin formation tyrosine, chain of the pathway is here to produce melanin. So one can see these lesions with those pigments or lipofuscin-rich lesions. Here, just to show you that sometimes the lesions are very eosinophilic. This tan red lesion, which I just showed you here as a nodule, is very densely eosinophilic, again with some pigment here, but round central nuclei with a small nucleolus, no atypia. These lesions typically can also show endocrine nuclear atypia, what we usually call it, and where you can see small nuclei to very large hyperchromatic nuclei, but they are kind of have a wrinkly appearance. And this is sort of degenerative type of atypia and doesn't suggest any malignancy, but it's a common feature and one should just keep this in mind. And here is a degenerative change one can see in the center, and that's that small nodule red area I showed you on the gross. This is the myelolipomatous change, meaning there is a trilineage hematopoiesis happening in this area. And then, as I said, this picture just shows the cortical atrophy. This is the thickness of the entire adrenal gland here. From this point to this point is less than 2 millimeter. And that happens with the glucocorticoid secreting cortical adenomas. Then what is new about adenocortical adenomas? Really, there is a lot of advancement from the prior, in past few years, and from prior 4th edition of WHO Fascicle to now 5th edition of WHO Fascicle, which is available online. It's not in prints yet. That we have learned a lot about the molecular or the genetics of these lesions. The adenocortical adenomas, aldosterone-producing adenomas, are enriched in these mutually exclusive somatic mutations of the following: KCNJ5, and these are long names, so I'll skip reading them, but you can see that all these mutations are related to the ion channels expression in the zona glomerulosa, which is the mineralocorticoids. And as this red indicate here, KCNJ5 is the most common mutation found in most of the 40% of the aldosterone producing adenomas, followed by these other calcium channel and chloride channel related mutations. And a subset of these lesions can also have the mutations in Wnt signaling pathway, and which is the beta-catenin or CTNNB1 pathway. And there is some correlation with what the mutation is and how the patient's presentation would be, and their age and clinical presentation. As one can see obviously here, that this kind of mutation is seen in aldosterone producing adenomas, and it is also most commonly seen in younger females. Whereas the CTNNB mutations are seen in the can also be seen in the non-functional and aldosterone producing as well as cortisol producing adenomas, and these patients are older in age. Here on the other category of cortical adenomas, which is a cortisol-producing adenomas, have typically mutations in the protein kinase A pathway of cortisol secretion from zona fasciculata. And among this group, the PRKCA, is the most common mutation seen in these cases. The other mutations as listed here are less common, and these mutations can be seen both in the sporadic form as well as in the hereditary form of adenocortical lesions. The mutations of the sex steroid producing adenomas are not known yet, and they are, as I mentioned, are rare tumors. Now, moving on to the next case, which is a case of a 54-year-old male who presented with symptoms of abdominal discomfort and weight loss. The imaging revealed 17 by 15 by 12 centimeter heterogeneous lesion in the suprarenal area, suggesting an adrenal origin. Biochemical workup did not reveal any evidence of hyperaldosteronism, hypercortisolism, or excess of androgen. So in brief, we can say that it was a non-functional lesion. Adrenalectomy with nephrectomy was performed for this patient because the lesion was big and was causing mass effect. Here is the growth of this lesion. As you can see, a large lesion with the kidney on the lower portion of the of this picture. The lesion appears to be in the fat of the perirenal fat, but doesn't include, doesn't invade in the, doesn't appear to actually grossly invade into the renal cortex. Here is another example of an adenocortical carcinoma. So this larger lesion of the adrenal, which are variegated in appearance, show all this hemorrhage and necrosis and are above 5 centimeter and very heavy, are generally the malignant lesions of the adrenal cortex. And these are called adenocortical carcinomas. What are adenocortical carcinomas? It's a simple concept that it's just a malignant counterpart of an adrenal cortical adenoma, which are larger and show lot of atypical features. And now we will discuss that very, shortly after few of these slides. So how do these lesions look? These lesions are usually solid or nested, as you can see here. Again, they can show eosinophilic cells. They can show a variety of mixture of cells, but typically are solid and very oncocytic looking. Here you can see the higher power of that, and with mix of a little bit of more vacuolated cells in the intervening areas. And here is a much higher power of those eosinophilic areas. These are large eosinophilic dense cytoplasm, central nuclei with some visible nucleoli here. And then there were some myxoid areas in this lesion. So the background stroma here is very bluish and loose hypocellular myxoid stroma. There were abundant areas of necrosis, as you can see on this picture. And there were mitoses, as one point. I'm not sure if you guys can see my arrow, but here is one mitosis. So the mitotic count on this was increased. And counting the mitotic counts in these lesions is actually a bit of a work. If they are not apparent, one should diligently be counting the mitosis in these large lesions to identify the highly mitotic areas and to come up with an accurate count. And you will see why that is important. So what are these adenocortical carcinomas? As I just discussed, these are not very common tumors. They are about up to 2 cases per million in US population, but there is increased prevalence of these lesions in the southern Brazil because of higher prevalence of P53 mutation variants in that area. There are lots of genetic syndromes associated with it, with the susceptibility of the various genetic cancer syndromes. The important ones are Pheochromocytoma and Lynch syndromes, and there is a whole list of hereditary syndromes which can show a predilection for adenocortical carcinomas or even adenocortical adenomas, including multiple endocrine neoplasia syndromes and others. This lesion, as you can see, are usually large and malignant lesions are the most common cause of death from adrenal neoplasias, because the adenocortical adenomas and other lesions of the adrenal cortex are benign lesions. They cause a lot of morbidity, but they are not really a cause of death usually in these patients. How one can suspect, obviously, from the mass effect, and if the lesion is functional, then the clue to the malignancy, other than imaging, is also a quick clinical presentation, meaning a rapid onset of Cushing syndrome or virilization and feminization, or a synchronous or co-secreting tumors can show both virilization syndrome and Cushing syndrome. In a small percentage of cases, these are incidental tumors. These are found incidentally, but those would not be as large as the lesion I showed you. Hopefully, they're not missed, until they are so big. But these lesions are more than 4 centimeters, but not really huge lesions, which are detected or imaging done for some other reasons. Weight-wise, these lesions are typically more than 200 grams and more than 5 centimeters. I showed you some of the gross pictures, and that's exactly how they look. Very variegated appearance with necrosis and hemorrhage, and the adjacent tissues in adipose tissue and the organs can be involved. They can also invade into large veins, and as I showed you in the microscopy of that lesion, there can be a mixture of different cell types, but largely solid, broad, trabecular, nested growth of eosinophilic cells with loss of reticulin. So if we did the reticulin stain, that wouldn't show a heavy meshwork of reticulin, and there would be loss of reticulin. We typically don't use this, but I'm just mentioning it here because there are some updates on how this should be used in the new classification, WHO fascicle. And then I kind of covered in that lesion that as there can be mixed areas, there are some subvariants of adenocortical carcinomas, and they can be oncocytic, myxoid, as I showed you some areas like that, and sarcomatoid adenocortical carcinoma. Just to keep in mind that something looks sarcomatoid in that region, that could also be an adenocortical carcinoma. How do we make the diagnosis of malignancy is a complex issue in adenocortical lesion. And I think we all always have to use a cheat sheet when any of these lesions, malignant lesions actually, or larger adenocortical lesions present for a surgical pathologist. The reason being that they are not very common lesions. So you're not seeing them every day. So, you have to just make sure that what you remember from your prior reading is still holds true, and it's all features you have applied for the diagnosis. The other reason is that the criteria for malignancy have been worked for a long time, and it's a complex algorithm how we make the diagnosis of these lesions. There are various, scoring system which have been used, and here are the names of those scoring system. I'm sure that you all are familiar with the Weiss scoring criteria, and then a modified Weiss criteria, Lin-Weiss Besselia criteria, Helsinki's criteria, reticulin algorithms, which are some of the new ones, and then the Vinke criteria for pediatric adrenal cortical neoplasm. This slide just shows you which criteria to use for what kind of adrenal cortical neoplasm. So the conventional adenocortical neoplasm, these are the 3 or 4 scoring system one should be using. For oncocytic adrenal cortical neoplasm, the Lin-Weiss and Helsinki criteria scoring system or the reticulin algorithm should be used. And for pediatric tumors, the Vinke criteria should be used. And these are complex criteria. And here is just, these are from the new WHO fascicle, the features which are evaluated and then given a score. But you will see most of these criteria typically use the same features, which is the mitotic count, degree of nuclear atypia, necrosis, capsular vascular invasion, and what kind of cells you are seeing there. And in the reticulin score, of course, the loss, how the if the reticulin framework on reticulin staining looks altered, and each feature is given a number, and then based on what the total score is, the malignancy is decided. And usually you should put, if the features are not like a very high score, one should always describe in their note what features did they see, not just a combined score, rather what features they are seeing, so the reader can see that how the scoring was assigned, like what things made it to a score 4 or 5 or whatever that might be. These are the few other criteria as I just discussed, and in some of them they might be based not on kind of the number, but you have to also remember that at least like in oncocytic adrenal cortical tumors, that one has to have there are some major criteria and then some minor criteria. If one major criteria is present, lesion is actually called malignant. But if one minor criteria is present, then one can call it a lesion of uncertain malignant potential. And absence of any major or minor criteria actually decides that one can call the lesion as benign nodule. This is just a chart for the pediatric adrenal tumors, which we as a pathologist for adult adenocortical tumors, I don't come across the pediatric lesions as much, unless the patient is at a very cutoff age. But you might encounter these lesions at your benches. What is the molecular advancement in the understanding of adenocortical carcinoma? Like the adenocortical benign lesions or adenomas, we have learned a lot about the molecular of the carcinoma, carcinomatous lesions of the adrenal cortex, and the two important pathways for adenocortical carcinomas are Wnt signaling pathway, the same, beta-catenin, CTN, and B1 mutations, and these are the mutations, most important ones, and then RF3 deletions. So mutations and deletions in the Wnt signaling pathway is what we see mostly in these tumors, and the cell cycle regulation, mutations that will include TP53, RB1, MDM2, CDK4, and CDKN2. Mutations. The other classes of mutations which are seen in adenocortical carcinomas are chromosomal maintenance and chromatin remodeling mutations and amplifications. The mutations of PRKAR1A class, and then the aldo. But these lesions do not show aldosterone, even when they are aldosterone producing carcinomas, they lack the aldosterone driver mutations, the one we just discussed in the adenocortical adenomas. There is, a classification, which is the CpG island methylation. Based on that, actually these lesions can be simp high, simp low, or intermediate, and the simp high lesions are associated with high risk, are high-risk lesions, and they show much worse prognosis. What are some of the differentials which you should consider on the gross as well as in microscopy are, one is the Pheochromocytoma, which you heard a lot about, I'm sure. They can mimic actually these 10 red adenomas. And if the lesion is larger, as this one was 6 to 7 centimeter, one would think that it could be an adenocortical carcinoma. Because these lesions also look, pheochromocytomas can look very ugly, but they are typically very blue, but still with the packeted cells and rich in vasculature, there can be, lymphovascular invasion. So just keep in mind and keep a low threshold of doing the stains and working it up. The metastatic tumors in the adrenal can present as a non-functional adenoma, and this is an example of a large metastasis of carcinoma from the lung. As you can see, a very variegated looking large nodule here with hemorrhage and 10 red and a 10 white appearing lesion. And this is the low power of this lesion, very nodular lesion with the central areas, big areas of necrosis. But when you look at the higher power, there is some similarity. It looks eosinophilic. And as I said, these lesions are not common. Adenocortical malignant lesions are not common. So, one may be not as experienced to actually look at and think about it immediately. So it's a good idea to keep all these differentials in mind. And you can see here in the central area, a little bit more of the ischematization of these cells. And here is the lymphovascular invasion, which is present. And this is the background adenocortical gland. One can use the staining profile. Here you can see cytokeratin cocktail, CK7, TTF1, and Nepsin A. All these were positive in this tumor, identifying this as a metastatic tumor. Here, this is Melan A stain and synaptone chromo to identify the background normal adrenal cortex. Metastatic hepatocellular carcinomas can present like that. This is an example of a very eosinophilic looking metastatic hepatocellular carcinoma. This is the background. This longer picture here is the background adenocortical lesion, adrenal cortex, I should say. And these two stains are the heparin stain and the glutamine synthetase stains, which were strongly positive in the lesion, and the background adrenal cortex is negative. Myelolipomas is another thing which has been added as a new chapter in the new WHO fascicle. And these lesions can be big, usually small as a degenerative change, as I showed you in the prior adenoma, but they can also be big lesions with increase, meaning then their weight is more, their size is more, and they have this variegated tan red appearance. So one would think that it could be an adenocortical carcinoma. But on microscopy, you can see a lipomatous component and a trilineage hematopoiesis. One can see here megakaryocytes and all other, background hematopoietic cells, immature hematopoietic cells. So myelolipomas can be associated with a very thin rim of adenoma in their periphery. So as I mentioned, some of the hepatocellular carcinoma and the other differentials that obviously you would use the organ specific, the site of origin organ specific stains to identify those lesions. But remember, these are some of the important immunostains for the adrenal cortex, that they are positive for cytokeratin, melanain, inhibin, and synaptophysin, but they're not positive for chromogranin. The most important, or the most the stain which I like, is a SF1 stain. It's a nuclear positive stain one can use to actually identify the adenocortical origin. Then this stain here, CYP11B2, is another name one should remember. Even we don't have it and we are not using it, but this is the major change in the WHO fascicle in the edition 5th. And then these lesions are negative for CD117, 45 microepithelioma factor, S100, chromogranin, Pax8, and CA9. These are all the things which can be in the differential from the organs which are adjacent or can arise in the kidney or the perirenal adipose tissue. TFE3, adrenal cortex can be TFE3 positive. So just remember that TFE3 positivity doesn't always mean a TFE3 positive renal cell carcinoma or translocation associated carcinoma. This is a big change in the WHO fascicle 5th edition, that now we are using the CYP11B positive or immunostain to classify these aldosterone producing nodules in the adrenal. So adenocortical carcinoma and adenomas are not a problem because we know the clinical picture, but then these are bigger lesions, more than 1 centimeter. One can see them grossly. One can see them by immunohistochemistry and a microscopy, no problem. But then there are smaller nodules, and how do we identify or classify them? Any nodule less than 1 centimeter, which is visible by H&E, and even by gross perhaps, and stains positive for CYP11B. And what is CYP11B2? This is an immunostain for aldosterone synthetase. Positive nodule, you can call it as APN, and any nodule which is not visible on H&E, see the color change here is in yellow, and you only identify it by immunostain, but obviously you got the adrenal because patient was presenting with the hyperaldosteronism. Previously we would call them aldosterone producing cell clusters, but you can call them APM, meaning micronodules, and these are typically 4 to 5 millimeter in size. And then there can be a mixture of APN and APM, and they will stain or will be seen on H&E according to what they are, APN or APM. And we used to call them micronodular hyperplasia, but then you call them, now we will be calling them multiple APN or APM. Then there can be aldosterone producing diffuse hyperplasia, and you will see a rim of positive staining in the adrenal gland. So this is an important advancement, but we don't have that stain here either in our labs, and we will be getting it hopefully soon. And then the other advancement is an adenocortical nodular disease, which presents as a Cushing disease. This is a very complex slide, and all I would say that adenocortical aldosterone producing diseases should be classified like the one I showed you. But if there is not a big adenocortical carcinoma, Cushing, presenting, or adenoma, but the nodules are smaller and are bilateral, then you're thinking about the bilateral micronodular adenocortical disease. And these patients are, young adults or children, and they have specific mutations associated with it, as the protein kinase A, as we just learned in the cortisol-producing adenomas also, and they can be pigmented or non-pigmented lesions. The pigmented lesions are associated with the carnase complex, and the isolated non-pigmented lesions are not associated with the carnase complex. Not all of them, but even in the pigmented nodular disease, but a very significant proportion of that. And they have specific germline variation, germline mutations associated with them. This is a complex one. No need to memorize it or worry about it unless you come across with a case, and then you can go and use this flow chart to sort of see how to work it out. Bilateral macronodular adenocortical disease, even I haven't seen a case yet, but it's a disease where the nodules are larger, more than 1 centimeter, and these lesions occur in adults. And the pathogenic germline variants here are ARM-C5, MEN1, fumarate hydratase, and adenomatosis polyposis, colonic syndrome type mutations. So just a few gross examples from my cases, that this is a microadenoma or a micronodule, less than 1 centimeter, like these are 0.8 to 0.9 centimeter sort of nodules. And here is this gross picture of that microadenoma, very eosinophilic looking lesion. And this is the gross example of a diffuse micronodular kind of disease. These nodules are not really 1 centimeter or even close to that. These are just very few millimeters looking, nodules. It's a very fine, actually, gross. If you look at these, some are 4 millimeters, some are 3 millimeters, and or even smaller. And this is how a scanner view or a 2x view of the adrenal will look like. These are multiple nodules, as you can draw lines around them. And here are more nodules to show you. Some can be with the clear cells, vacuolated cells of fasciculata type, or they can be very eosinophilic looking. Different nodules can have different cell type showing in them. So that's the understanding of the micronodular disease. That's a very significant advancement, I would say, major change from WHO fascicle 4th to 5th, to understand the micronodular disease and how to classify the aldosterone producing tumors. Then in the new fascicle, they have added few other lesions as a separate chapter. One is the adrenal cyst, and adrenal cyst, as you can see, one example here are these larger cysts in the adrenal. They can be associated with an adenomatous or a neoplastic lesion, or they can be by themselves. The typically adrenal cyst, so this adrenal lesion shows an intense hemorrhage. So hemorrhage can cause a pseudocyst. So one type of the cyst can be a pseudocyst, or one can have an endothelial type of cyst. This is a cyst lining. You can see a fine endothelial lining sitting on a fibrous sort of cyst wall. And this is CD31 and D240, which shows a positive staining of this lining. So this is an endothelial type of cyst. So you can have a pseudocyst, you can have a endothelial type of cyst, you can have really a mesothelial type cyst, or rarely in endemic areas, you can have a parasitic cyst, echinococcus related parasitic cyst. I think this is all I have as an advancement in the adrenocortical lesions, and I'm not sure because I couldn't keep the track of time, but if there is time, I will be happy to take any questions now. I'm sorry, I'm unable to hear anyone here.
Hello, thank you, ma'am. Thank you for a nice, detailed, illustrious presentation and update. And do we have any?
My pleasure.
I think we don't have any questions here. You have, Acha, there is one question.
Hello, okay. Nice to see you. This is, I'm Vinita here. So,
hi, Vinita.
So
nice to see you too.
Yeah, I was just wondering, so how do you go about diagnosing adrenocortical hyperplasia? That is one thing which is really difficult at times for us. So how do you make a diagnosis of adrenocortical hyperplasia with the new classification coming in of a micronodular disease and bilateral micronodular and macronodular disease? So what happens to the hyperplasia that we used to diagnose?
Yeah, so that is the major change, I would say. So let's, because we are still not using those staining, so I think we are still a little bit, on our practice are still in the 4th edition. So all the examples I showed you here for the micronodular disease are from the cases which I signed out until now, right? So one important thing is to keep in mind what the clinical picture of the patient is. And that's why I included some of those cases. So if you know a patient had a hyperaldosteronism or hypercortisolism, and then they did imaging, and there is not a big nodule or a big mass lesion. And then the lateralization test actually shows a bilateral disease, right? Still, they probably won't be taking both the adrenals out, but the experts of endocrine surgery can tell you more about it. And then you go get the lesion at your bench, and you're not seeing adenoma or carcinoma-like lesion. Rather, you are seeing the lesions I showed you, very small nodules, right? Or variable size nodules, but all less than 1 centimeter or in the range of 0.3 to 0.4. Now you have all the information with you. What was the clinical picture and what was the lateralization and what your growth looks like, and then the microscopy. Then these are hyperplasia. So you're right that we were calling them micronodular hyperplasias, but now with the understanding of the new thing, we would be saying for a while, probably what I would be doing, I would say micronodular hyperplasia, aldosterone, micronodular disease, previously called micronodular hyperplasia, aldosterone producing lesion. In the absence of availability of the CYP11B2 staining, I will be putting a note that clinically appears to be a bilateral disease or whatever, or the nodule size, typically in the aldosterone producing ones, and then saying that this will be in a new classification would be called like so-and-so, like an on producing microadenoma, micronodules or nodules or whatever, right? And if it is a cortisol producing lesion, then similarly, you would say that this appears to be, overall picture appears to be a micronodular disease or macronodular disease, whatever that might be, and then put that these are the mutations or known significant associated mutation described, and a clinical correlation is recommended. While we as a pathologist are learning, I think our clinicians are probably ahead of us and they know about these things. So when they are seeing these clinical pictures, they can also put 1 and 1 together and then know that their patients, what additional testing their patients may need. But to my understanding, these micronodular diseases, which were called previously, especially the nodular diseases of cortisol producing, fortunately are not very common in its hereditary form, like the ones pigmented and non-pigmented and bilateral macronodular, because I haven't seen a case yet at my bench of a macronodular disease, and I sign out a whole lot of adrenal cortical lesions. Does that answer your question? It's a long answer. Yeah, but that's kind of the main brief update of the WHO Fascicle 5th.
Yeah, that was helpful. Thank you so much for the clarification. It was really nice. Thank you.
We have another question, Krishnani. We have one other question from Dr. Krishnani for you.
Yeah, please.
My question is...
Hello, boss.
Hello. So my question is just reverse of it, that how can you identify atrophy, especially in the cornea complex, where there is a small patches of atrophic cortical tissue is seen. So I always find it difficult, especially in cornea complex. Otherwise, if it is a diffuse atrophy, we can easily identify based on the thickness of the cortex. So that is what I always face.
Yeah, so identifying cortical atrophy on these diseases is not easy. But the best way to identify the cortical atrophy actually is the area where you're not seeing nodules. And the picture I showed you is away from that nodule. And typically, do all pathologists, elaborated way, do they comment on the background cortical atrophy? Probably not. But, that's something we should be doing more and more. But this is also to identify the lesion. When you are seeing all of that, then you're keeping in mind that I should not be seeing a hyperplasia of the background, cortex. Rather, I should be seeing an atrophy. So even if you're not measuring it, you have an idea of what the background adrenal cortex should look like. And slightly going away from the nodule area is the best place. That would be my understanding. And that's how I have measured the picture I showed you.
Okay. Thank you, Mamta.
Okay, so there are no more questions. Thank you, ma'am, for such a nice presentation. Thank you.
Thank you. Nice seeing you all. Have a great evening and enjoy your dinner.
We'll miss you. We'll miss you and Dr.
I know. I wish I was there to have delicious dinner with all of you and enjoy the evening next time.
We will have it
here. Thanks. Bye-bye.
Thank you, Dr. Mamta. Thank you so much.
Bye.
Bye.
Thank you, ma'am. We have an announcement.
We have an announcement to make. The studies selected for oral presentation are Alka Singh from SGPGI Lucknow, Nilima Gupta, SGPGI Lucknow, Pranita Gaddam from AIIMS New Delhi. I request the participants to make a short presentation of 5 minutes. And please keep 2 minutes for question and answers.
Dr. Mamta, we are closing this session and we are...
Dr. Mamta, can you hear me? Manoj, Dr. Manoj. So tomorrow, ask and tomorrow morning we will be having Dr. Amitabh Chowdhury because it's late today. Can you hear me? Usko unmute kar.
Ma'am.
Sorry. Yeah. Okay. So I think I unmuted myself.
8:15 Indian time will be. That will be quarter to your time. 2 days your time, quarter to 11. We'll be having a live session of Dr. Amitabh.
Okay. And say my hello to Dr. Madhumati Goyal. I can't see her, but I see her message and I'm unable to send her a message. So convey my regards and hello to all of you and to her too.
And you can see her online by the name Avya. She has logged in with her granddaughter's name.
Oh, okay. But I see him. Okay. Thank you. Thanks. Bye.
Yes, she has come. She's there. Can you see her? Dr. Madhu ma'am?
And unko bhi spotlight pe kar dijiye.
I am here. Can you hear me?
Dr.
I am here, Mamta. Hello?
Ma'am, leave kare.
Acha ma'am.
I am here, Mamta.
Mamta ma'am has just left. She didn't.
Okay.
You will be there.
Right.
Okay, ma'am. Nice to see you.
At 7:30.
7:30.
We now invite all the dignitaries and the delegates to a cultural program and dinner, which will be starting at 7:30 p.m. in telemedicine auditorium.
Yeah.
Here in this hall only. Students whose papers are selected for presentation are requested to make a presentation. 5 minutes time is allotted for presentation and 2 minutes are allotted for question and answer session. The session will be starting at 4 p.m. tomorrow. So tomorrow's program, because in this hall tomorrow there will be a institute class, so our session will be starting on second floor. First talk of Dr. Amitabh and Peter Sado will be taking up on the second floor. Later on we'll move here down the stairs at 9:30.
So we'll reassemble here at 7:30 with some cultural program and dinner.
So at what time tomorrow? We thank all the online participants. This has been a long day. We will start tomorrow because some of the talks which had to be held today could not be held because of the timing issues. So now we will start at 8:15 tomorrow with Dr. Amitabh's talk, which was not held today. And then after that, if we have time, we'll take up Dr. Peter Sadow's talk. And then the program was circulated at 9:20. We will start our routine program that was circulated today. And all the online participants will receive a new link. So this link will not work from tomorrow, for tomorrow, and you will have a new link which you need to join. If you have any issues, please let us know on the same group. Anyone has any comments or any issues today, you can just put it in the chat box. You can all unmute yourself if you have any issue. Okay. Okay, then bye for today. Thank you for joining online.